and that is one of the challenge right now we are have, that will be reduced with the digitalization. Urban-rural divide, I already have told you that there is a 65% population reside in the rural area only. There is a limited access to immediate healthcare services, especially in tier 2 and tier 3 cities. With providing the telemedicine, tele-ICUs, IoT devices, we can also improve this access to immediate care also for the emergency and ICU care also. That is, I think, can reduce lots of mortality in tier 2 and tier cities, tier 3 cities. We all know that we are very affordable as compared to developed countries, but we are spending only 2.5% of our GDP on healthcare system. That is less than 1/4 of the developed countries. Most of the developed countries, they are investing more than 10% or even 15, 18% of their GDP. It means we have to be more affordable also still, and we have to allocate more budgets to our healthcare system also. So for that, we should have something tech-enabled so that we can be cost-friendly and we can be accessible in the remotest area also. I know that there are remotest of village, they have lack of telemedicine, lack of still teleconsultation, video consultation, still we have lots of ATM installed in remotest of village, but still around 70-80% villages, they lack these telemedicine centers. And during COVID, we all realized that millions of people have been saved because of teleconsultation from doctors only. If you do digitalization, it will reduce the paperwork, it will empower the doctor, it will improve the efficiency of the healthcare staff, it will improve the patient experience also, and it will provide access to immediate data of the patient. Telemedicine, I think this is one of the sub-vertical of healthcare system or healthcare division. It is growing at a rate of around 24% of cumulative annual growth rate, CAGR of 24%. And we will be having a market share of more than 90 billion, 900 billion, means current healthcare structure is around 600 billion in India. And if we talk about the globally, then it is quite high, but definitely telemedicine will be having a big chunk of the total healthcare system. Like most of the patient, still they are dependent upon the hard copies of their healthcare record from lab, diagnostic, pharmacy, and medical prescriptions. But if you have patient portal on your website, appointment booking system, access to medical record from patient or doctor, then definitely the accessibility of the healthcare record through EMR, through HIS can be feasible with this system, and it is part of digitalization. And I think right now less than 1% of the hospital or even diagnostic chains are using this system right now. What are the benefits? We have already told you that it will improve there are three parts of the ecosystem of the healthcare. One is the patient, and we are all patient-centric. Second is the hospital provider, that is the healthcare provider. Third is the doctors. And fourth is if we talk about the insurance players. Everybody will have some benefits if we implement this digitalization in ecosystem of the healthcare, like there will be improving the operational efficiency, reducing costs, reducing manpower, reducing errors, reducing complications, reducing cost. Everything will be better. It will improve the EBITDA, it will improve the profit of the hospital, it will improve the experience of the patients. All are these benefits of the digital transformation in the healthcare system. What are the component of digital transformation? We all know that AI is disrupting everywhere, and AI will not replace doctor exactly, I am telling you, but definitely it will empower doctors. It will reduce improve their efficiency. It will reduce their time. It will improve their TAT. It will reduce the complications, side effects for the patients, and definitely it will improve whole ecosystem. It will disrupt, and I am telling you one thing more, a step ahead from this point. In next few years only, patients will be visiting hospitals only for emergency care and major or surgeries or procedures. All other services, either they will be provided through telemedicines or home care services. This is the future. Hospital will be assigned to provide only tertiary, quaternary care healthcare services, emergency healthcare services, and major surgeries and major procedures. Rest, everything will be at your doorstep, or it should be accessible through telemedicine to you. all the hospital infrastructure, medical equipment, machines, monitoring machines, monitors, they will be integrated with the HIS, with the EMR. All the data can be transferred through this IoT, Internet of Devices, to the EMR, electronic medical record system, to the billing modules also. There will be billing leakage will be reduced. Like all the medical record, there will be no negligence, medical legal negligence will be reduced, and definitely they will empower doctors also. And if you enable this with the AI, then they will help doctors to predict how much sick is the patient also, and what is the RRT. Like they will, before doing any like CPR, they will tell one day before that this patient is going to be serious in next 24 hours, and you can take these steps to reduce this CPR or reduce the mortality also. So they will empower doctors also by providing the predictive analysis based on the patient history, past history, medical history, reports, diagnostics, and all the chief complaints. Now, अभी इस सर बात कर रहे थे, this is the intelligent village. The intelligent village, there is a new name terminology coming for the hospitals, smart hospitals. The smart hospital will be process-driven hospitals, system-driven hospitals, AI-enabled hospitals. They will have robotics, they will have 3D printing. I will not discuss, I think they will have telemedicine, they will have precision medicine, they will have genomic printing. So all these things will be patient-centric. They will help patient, healthcare providers, hospitals, so that they will improve their efficiency. And if you include component of a smart hospital, so digitalization and automation. Automation is, I think, to scale any hospital. You can do POC, proof of concept. But if you want to scale that hospital, then you should have automation in system and process of your each and every department, so that you can replicate this same institute any other way. It means for scaling, you need automation. IoT devices, I have already told you, these are required for integration with the HIS and EMR module. Augmented AR and VR, very important for medical training, surgeon training, robotics, and these can give similar experience that you do on the live patient. The AR and VR is one component of smart hospitals. AI and robotics, I have already told you, robotics are taking everywhere, not in clinical departments like ortho, neuro, nephro, and every surgical devices, but they are doing the back office work also. They are replacing manpower. Means they are improving efficacy. They are reducing the complication and side effect. They are improving the turnaround time also. So means robotics as one of the key component will be for paramedical, non-medical, and clinical departments of any hospital. 3D printing, if you want to give accurate medicine, currently we are giving medicines, but they are broad spectrum. They cover most of the things that are not required also. They have more side effects, more complication, reduced efficacy also. But if you give precision medicine based on a genomic blueprint of any patient, then it will be hitting the target, and it will have reduced side effect, improved efficacy, improved outcome, and improved prognosis of the patient. Blockchain and cloud compounding. Blockchain means data-based everything, data safety, data security, data distribution, data MIS from the data, and data-driven decision, everything will be with the cloud compounding and the blockchain. If you use blockchain, that is one of the core area of right now in smart hospital. Data is everything. If you know how to read data, how to interpret data, and how to take decision on that interpretation, that is MIS, Management Information System. So I think everything will be surrounding this data only. And last is genomics. I have already told you 3D printing. Genomics is new thing. It will improve cancer. It will improve everything in the clinical departments if you use the genomics. I will not cover, I think these are, already I explained all these things. Now about the government initiative. Ayushman Digital Health Mission, ABDHM. I think most of person have heard about this ABDHM. Please raise your hand. So still, I think we need to create more awareness about the ABDHM. Like we have all Aadhaar right now, we have all Aadhaar, everybody. So like Aadhaar, we will have ABHA ID also. And ABHA ID is the one of the most ambitious project of Narendra Modi or BJP government, and they are going to implement it very fast. Already lots of work has been done. More than 50 crore ABHA ID has been distributed. More than 2.5 lakhs facilities like hospital and nursing homes, they have been registered, and digital health care records has been at least stored, and that has been digitalized also. I think this is the future of healthcare in India, controlled by government department as per government guidelines, and they will give accessibility to patients also, healthcare staff also. It will improve interoperability, and interoperability means inside data sharing inside the hospital and outside other hospital for second, third opinion, or referring a patient or taking a treatment from other patients. It will improve telemedicine, it will improve e-pharmacy, it will improve tele-prescriptions also, digital prescriptions also. So all things will improve with this ABDHM. What are the challenges right now? We are already discussing that there are lots of infrastructure challenges, poor internet connectivity, IoT devices are not available in the remote area of village. These are the challenges. Digital literacy is poor, like most of the people are not knowing that what is ABDHM. It means we have to create more awareness. There are hesitancy among the private hospitals to provide the data, to integrate. The government has already incentivized this also, so that they will be motivated to register their data centers with the ABDHM. Lack of training among the healthcare staff, that is also one of the challenge. But what is the future? What is the future way? Future way is to develop paperless system, AI-driven system. ABDHM will work on this, mobile app, digital pharmacy, inventory, and improving digital leaders in healthcare also. How we can do this? We should have PPP model with the private sector, so that all the data, because 70% of the healthcare services are provided in India by the private healthcare provider only. If you ignore them, you cannot implement any system. Being it OPD, IPD, indoor surgery, everything, 70% services are provided by hospital, private hospitals only. It means you have to have something like PPP models, strengthen cybersecurity and data-driven decisions, data protection laws also, health incentivizing, promoting healthcare startups, technology-enabled startups also, improving accessibility of all these things in the rural area. I think all this has to be done to have digital healthcare system, ecosystem in the India. I think, thank you so much. Thank you for patiently listening. Anything, any question, I'm ready to ask. Thank you.
Thank you, Dr. Gupta. So he somewhere agreed with me what Microsoft chairman has said. AI will replace the doctors. And Dr. Gupta, Sharma ji is the one who created all this Aadhaar and everything, who's sitting next to you. Hanji, Hanji. So he's the one who's the producer of all this from the government of India, on the behalf of government of India. Ladies and gentlemen, let me invite the next speaker for the session, Shri Arvind Kumar, who is the Director General of Software Technology Park. You can see few of the startups in the medical, because they have a huge startup medical system, ecosystem created by STPI. Ladies and gentlemen, put hands together inviting Shri Arvind Kumar.
Good afternoon. Today's chief guest, Dr. R.S. Sharma. He is Aadhaar of Aadhaar. Yes. So he is Aadhaar of that Aadhaar, which has become Aadhaar of digital public infrastructure in the country. So he has played a very major role in creating this digital public infrastructure. Today everybody talks success story of digital public infrastructure of this country. He has been instrumental, he has been Aadhaar of this whole digital public infrastructure. And God has also played the role in that manner. Initially he was with Mighty, so he has created big digital India program, you know. And the Digital India program, the kind of enthusiasm, I don't know anybody remember that his picture when he is inaugurated, having the white color safari and all. I mean, the kind of it has created among all the engineers who were there in that Vigyan, when I remember. So he has been in MIT, created Digital India program. Then most critical part of that was connectivity. So he has been moved to TRAI, and he ensured fastest rollout of 4G and 5G in this country because of his quick decision, because of his far-reaching effect of the decisions. Then he wanted to show how this connectivity and Digital India program can be used one of the application, then he moved to Ayushman Bharat, and he has shown this can be done for the healthcare, which is the most critical sector of this country. So this is the way God plays the role, create Digital India program, show how the connectivity can be done, then how the one of the application, which is most successful application, this country can be done. He has been mentor, he has been guru for me, not only to me, so many people maybe here, maybe sitting here also, Robert, everybody, he is here. And for guru, I can't say Bhishma Pitama because Bhishma Pitama last mein Saiya par the, but he is here only. But he is Bhishma Pitama of whole Digital India program. Guru for me, mentor for me. Sri D. Suja, Vice President, Nazaret Hospital, Prayagraj. This is actually first hospital I visited in my life when I just went for graduation in Allahabad. For me, that Prathmik Swasth Kendra of my village was the hospital. I have that image of the hospital only. First time when I saw the Nazaret Hospital, that means such a big hospital. Hospital means so many doctors, hospital means neat and clean kind of the room. Otherwise, for me, that hospital road means public health care center, which is PSU of my village, which is in Bundelkhand. So the Nazaret Hospital, I owe the Nazaret Hospital. They were able to show me what kind of the hospitals are. Robert Ravi, my friend, technology man. He talks technology, he walks technology, and I think he has now changed the shape of Bharat Sanchar Nigam Limited, which is most responsible for telecom revolution. So he has vision to connect each and every village of this country. And when we say connect, means connect for everything, whether it's Aadhaar, whether it's health or everything. Mr. D.K. Gupta has created a lot of impact, as he told, in Noida, and he has vision to create and connect all villages nearby. Sasi, always, I think, anything who has done real convergence is Sasi. So you have the event on 6G, so technology. Then his second event would be on data center, cloud services. Then you have event on healthcare. So this is all, he complete all spheres of the technology and healthcare in this country. And if you remember, for us, so either students will become the engineer or they become the doctors. And these two streams, once you become the doctors, and then doctors do not talk to engineers because you are talking something else, we are talking something else. So the whole life we remain the friend, but we never talk about our subjects. There's a difference. Even after retirement, because doctor does not retire, we retire, engineers retire, even they don't talk about it. Even after retirement, we are not on the same wavelength because doctors think I am superior, I am not retiring, I am doing a lot of good things. Engineers think, okay, I know what you are doing. So this keeps happening whole life. But now things has changed. We are running multiple center of entrepreneurship across the country. We are running around 24 center of entrepreneurship across the country. Out of them, 3 are dedicated to healthcare. One is at Lucknow, which we call Medtech at Sanjay Gandhi PG Institute, within Sanjay Gandhi PG Institute. We have one at Bangalore, which is in collaboration with Narayan Hospital. Third is in Northeast also. So we have 3 big center of entrepreneurship, and the difference we can see when we meet founders of those startups, one of them could be engineer and another could be doctor. And that kind of synergy which we were looking at since last 20 years, that synergy, I can see it. They are contributing how to solve the health problem. And there's the change which can be seen now in each and every startup. All the startup which is on health tech, what kind of the problem, whether they are solving predictive problem, whether they are solving preventive problem, but both people are there. As far as this startup health tech market is concerned, we are growing very fast. I think we are only, when it's a tech part, not the whole sector as such, we are targeting, there is a extrapolation which says 50 billion market will be for startup technology only by 2030. And as far as when we say we are going to achieve, we are going to become Viksit Bharat by 2047, we are targeting 10 times, 10-fold increase in our GDP and per capita income. There is no use of 10 times 10-fold income unless we are not good at health. Even if you have a lot of money, people who have a lot of money, if they still have some small health problem, end of the day you think, whatever happens, money goes wherever it wants to go, but I want to become the right. Same is true with the national health of the country. So unless we are not able to we are not able to give health for all, we are not able to give health insurance for all, apart from insurance for all, pension for all, unless we are not able to give health for all, there is no point of becoming the Viksit Bharat. Viksit Bharat will take real meaning if we are able to solve health problem of this country for each and every citizen of this country. This should be our target. And as somebody says, AI is only a tool. Doctor, sisters, they should not be afraid of that any job is going to cut down because of the AI. AI can solve the problem. They cannot create problem statement. We can create the problem statement, and there's a difference between AI and our mind. We know what the kind of the problem, and we all doctors are sitting there. Many times when I meet the doctors, they say there are some agreement with the hospital. We cannot advise to anybody. They sigh of advising to startup. I request hospital, please come forward, ask them to suggest advice to the startups, because you know the problem statement. They are fighting here and there. They don't know what to solve. Recently, we have also entered into an MOU with All India Medical Institutes. I said, please, we have number of startups. We are supporting more than 2,000 startups in this country. Ask them, those who are interested in health tech, take the budget of AIMS. They will tell you hundreds of the problem which can be solved by the technology. So you take a startup, take a route of the AIMS to them. They will tell what kind of problem can be solved by the technology. Support them, not financially. Support them just by giving how the problem can be solved. Give the problem statement. Today for a startup, problem statement is more important than money or anything else. And especially in health sector, because health is the biggest sector, and here we can do wonders. Health, everybody, if you talk to Stanford University, they have some biodesign center. I talk to them. They say, Arvind, if you want to do any help of us, please do in the health. I want to enter into agreement with the UP government because it's the biggest state, and they want to data for that. And please don't shy away with the data. This is a data which will create a models. We are India-specific models. You should all share. Hospitals should share their data. We are converting this whole data into digital format of Sanjay Gandhi Pages Institute. You see some data from 1960, 1965. That data is completely in the paper form. We are going to convert it to digital, want to use for AI tools. Today, if I go to some startup, I say, what the solution is? I have created non-intrusive blood pressure meter. I created non-intrusive blood sugar meter. How much data you have? I have said 2,000 patient data. This is not sufficient. I again request all pathology lab, please be generous. Start this support to startup. We want to collaborate with you. We want to create a new center of entrepreneurship just to provide the data. We are open to it. All hospitals, all pathology lab, they should come forward, share the data. If data is biased towards any other country, your problem will not be solved. If we really want to solve the problem with AI, we should have our own data. This should be the spirit. Everybody should come forward like we have come in number of things like donating organs, donating anything. This is small data. Make it anonymized, whatever way you want, but that data could be critical for the. I am not impressed. I have data. I have Center of Entrepreneurship on automatic shared vehicle. I am not impressed. Somebody says this country has created flying car. I'm impressed when somebody says I have reduced the cycle of drug discovery. I'm impressed when somebody says that yes, now cancer can be predicted in very pre-early stage. That is the satisfaction we want. I'm not interested in flying car. I'm interested in diagnosis. I'm interested in the solution which can help old age people. Old age people can sitting at their home. They can go talk to their kids who are in USA. They can talk to director directly. They can have all solution when they are in bathroom. Some people, some old age people, when fell in the bathroom, nobody is there. We should want these solutions. These solutions are required for this country. We are a vast country. We have a lot of data. We can lead in AI, especially in healthcare. There is no doubt to it. But we have to come together. We have to first give the data, organize the data, and we have to train AI tools from that data. And that should be the spirit, that should be as a mission mode, and then only we can achieve that all technologies are available for us, for our health sector. Diagnosis is the big issue which I always found. It is very difficult to exactly diagnose what is happening. If you go to the doctor, you have pain in the full body, you say there are muscles pain, there is stiffness, they have some bone density meter test, then they go to, if you go to a neurologist, they will have NCV test, then go to gynaecist, everybody will tell, finally you will find nothing, then we say it is a like fibromyalgia, which is nothing but like you go to psychiatrist. Because we are not able to diagnose this because we are not using the technology. Why not we give this all data, and then why people should go to psychiatrist when there must be some problem? I'm sure that problem is the diagnosis problem. That problem is not that medicine problem. But diagnosis is not happening properly. If you have stomach ache, you go to 3 places, they will do some endoscopy, they will do something, finally they say nothing is found, you have IBS. So you have stomach pain sometime, and whenever pain, you just treat the pain. Why not we have created technology solution to diagnose the problem? This is all we need: support from doctors, we need support from pathology lab. Technology, we are in actually very, very interesting, very exciting innovation stage. This times comes once in centuries. We should capitalize this. We are not able to capitalize, but today we say we are best in digital public infrastructure. Best does not remain always the best. It is easier to become the first, but it is always difficult to remain the first. So we are first in digital public infrastructure. Unless we don't share the data, unless we become first, unless we are not able to capitalize this digital public infrastructure by using the applications, then there is no use of becoming the first in digital public infrastructure. When we launched 5G, there was always an assumption that 5G is not about the data speed. It is all about the applications. But if you think 5G finally become the highest data speed, that was not envisaged when the 5G was rolled out in this country, because lack of data, lack of cooperation with various sectors requires to really make use of this 5G or 6G or 7G, whichever comes in the way. We all should unite together. Doctors, engineers should sit together. Hospital, pathology lab, technology innovations should sit together and find some solution which is good for this country, whether AI, whether blockchain, whatever it is. Thank you very much. I wish all the best for this full day event.
Thank you so much, Sri Arvind Kumarji. I do agree the doctors and engineers should sit together. Maybe Father Ishwar D'Souza and Rupcha can create a committee for doctors and engineers together, and we can sit with Arvindji and CMD BSNL all together to form something, how to take the technology and the medical together. The next speaker is, as Arvindji said, that he has been to that hospital when he was graduated. So I invite Reverend Father Ishwar D'Souza, who is the Vice President of Rupcha and Director, Nazareth Hospital, Allahabad. Please.
Esteemed dignitaries on the dais, Reverend Fathers, Sisters, ladies and gentlemen. Dr. D.K. Gupta has extensively spoken about the contribution of the digital transformation in the healthcare. So I would like to point out a few things, just a few things. Well, it's my honor and privilege to stand before you on behalf of Rupcha, that is Rajasthan Uttar Pradesh Catholic Health Associations in India, to speak at this Bharat Digital Healthcare Summit. In fact, we stand at the healthcare crossroad between healthcare and technology. It's a kind of defining moment for us, which in fact is reshaping our experience in the care. Digital health is more than innovation. In fact, I would say it's a kind of revolution today. It is empowering patients with the wearables, equips doctors with the AI-driven diagnostics, and strengthens public health with the data-driven strategies. But with these advancements, there come great responsibilities also. Because ensuring accessibility, addressing ethical concerns, and adapting to new systems is very, very important. So together we can ensure digital health becomes an inclusive tool that delivers care efficiently, ethically, and equitably. So we are here to discuss how to make this transformation one that benefits humanity in an extensive manner. Imagine a world where a simple app can track your health, especially the heart health, connects you to a doctor within a minute, and offers a kind of personalized advice to prevent illness. This is not the future I am speaking about, it is happening today. However, technology must be used wisely. We must protect data privacy, understand the tools that we are relying on, and advocate for transparency. By embracing these responsibilities, we can ensure that digital health truly serves humanity, taking healthcare smarter, more efficient, and more compassionate. Well, for over 3 decades, RUPCHA, that is Rajasthan Uttar Pradesh Catholic Health Association, has been a beacon of hope in North India, championing comprehensive health care. Since its inception in late 1980s and formal registration in 1991, RUPCHA has gone beyond curative care to focus on preventive and promotive health initiatives. Now, in the digital era, we are committed to integrating technology into our healthcare systems, enhancing outreach, improving efficiency, and ensuring that no one is left behind. When we are fast moving in the digital transformation, I wanted to make a study how this digital transformation can be incorporated into our healthcare system. So I made a study, and I also visited a few hospitals along with the Reverend Father Vipin D'Souza. We visited medical colleges like St. John's in Bangalore, Father Muller's in Mangalore, hospitals like Holy Family in Delhi here, Holy Family in Mumbai, HCG Cancer Center in Mumbai, and many more hospitals, just to study how digital initiatives are aimed to improving the patient care. So this study and these visits have, in this moment, I have noticed how doctors could instantly access patients' history on their screens through electronic health records. There is no question of carrying bulky files. It really helps avoid repetition, speeds up decision making. Secondly, in a few hospitals, I saw telemedicine, patients consulting doctors over video conference. It was especially helpful for those from distant places, that is quick, easy, and effective. Some diagnostic labs use AI tools to scan X-rays and MRIs. The reports were generated faster and with impressive accuracy. I also saw some patients wearing devices that tracked their heart rate and oxygen levels. Doctors could monitor them remotely, early alerts and quicker actions. In one of the hospitals in the surgical unit, I also saw robotic arms assisting in operations, so precise and less invasive. There are also possibilities of machines dispensing medicines in pharmacies, reducing the waiting time. Though still new, a few places are trying out blockchain. Sir has explained what blockchain is. So for secure data sharing, patients could control who accessed their records, quite futuristic and safe. So in this manner, digitalization of digital transformation is helping the patient care. India's healthcare is undergoing a major shift because with a population of over 1.4 billion, there is a growing need for better, faster, and more accessible healthcare. Traditional methods are no longer enough. So digital transformation is stepping in to meet these challenges using AI tools, telemedicine, electronic records, and wearables. These technologies are helping improve care, reduce costs, and make healthcare more efficient and personalized. Well, while the strides in digital healthcare are commendable, challenges are there. The first challenge I would say, digital literacy. A significant portion of the population remains unfamiliar with the digital tools, so they do not know what digital tools are. Secondly, data privacy and security. With the digitalization of health records, safeguarding the patient data against breaches is paramount. And thirdly, infrastructure limitations. Rural areas may lack the necessary infrastructure, such as reliable internet connectivity or to support digital health solutions. Investments in infrastructure are crucial to bridge the divide. So overcoming these challenges requires strategic planning, continuous training, strong leadership, and robust regulatory frameworks. So in conclusion, I would reiterate that the journey of digital transformation in healthcare is a collaborative endeavor. It requires the concerted efforts of the policymakers, healthcare providers, technologists, and community at large. By embracing innovation and addressing the accompanying challenges, we can build a healthcare ecosystem that is inclusive, efficient, and patient-centric. As we deliberate and share insights during this summit, let us reaffirm our commitment to harnessing digital transformation for the betterment of patient care across our nation. Thank you.
Thank you, Father D'Souza, for sharing on the rupture as well as on the views of yours on the digital health. Ladies and gentlemen, let's put hands together in welcoming our chief guest, Dr. R.S. Sharma. As you heard, is the Digital India started by Dr. Sharma. Sir.
Thank you, Shashi, and good afternoon to all of you friends. Father D'Souza, Dr. D.K. Gupta, my friends Arvind, and of course Robert Ravi and Shashi. It's really a privilege for me to be here with you this morning. I'm sorry I got delayed because the driver depended too much on Google. So when you depend too much on Google, and that is how, that is a lesson. When you depend too much of technology without applying any mind, you might get some very different kind of things. AI also, they call it hallucination. It hallucinates. So that's what I'm sorry for that. It's really, I don't know, Arvind talked about it, but for me, it has been a very interesting journey, so to say, in the service. I would not have stood before you but for this coincidence in some sense. Let me share with you, and I think a lot of things have been spoken about digital health and the benefits thereof and the challenges which are happening. So I don't want to get into that issue, and in any case, my doctorate is not really in the medical field. I am one of the, I don't know, fake doctors or whatever you say. It's a doctor of philosophy. That's why I'm not really competent to talk about the medical stuff. But just wanted to share with you some little story. And that story relates to my own career. I joined the administrative service at the age of 22, just after completing my, post-graduation. And of course, then I was allocated Bihar cadre, and I've been working there for a long time, 20 years or so. And then, I was doing, I had interest in digital technologies at that time also. So I purchased my first computer in the year 1984. And many of you guys would not have been born by that time, right? So since then I've been interested, and my area of interest has been how digital technologies can be applied to public service delivery, to essentially, make things better, governance largely. So we wrote a software way back in 1986 on public grievances, on the rural employment program at that time, on the court cases, a number of other things, how we can systematize these stuff. Anyway, I want to cut short that story. Come back, fast forward to 2009. It was only a coincidence that I joined the Unique ID program of India as the Chief Executive Officer, Director General and Mission Director, with Mr. Nilekani, who was the chairman. And we started doing the world's first digital identity project. And at that time, everybody said it cannot be done. It's just not possible. You don't have the authority to do it. It has already been done. All kinds of, naysayers were there. And of course, the biggest halla was done by the privacy and surveillance group, which says that India will become an Orwellian nation and everything can be seen by the government. But then we continued, and we did not know at that time, and honestly, I think Nandan also did not know. None of us knew actually the kind of widespread application this will have. And the basic idea and why did it have widespread application is the architectural principles which we incorporated in the design of Aadhaar. When we designed as a pure identity without eligibility. We designed it for a scale. We designed it to ensure that one person gets only one number so as to ensure that there are no duplicates and ghosts in the system. We designed it for an open standard-based system so that it can plug into any kind of transactions. So various kinds of architectural principles went into the design of Aadhaar. And then today Aadhaar, of course, as Arvind said rightly, it is actually at the center of the digital governance in this country, and it is one of the digital public infrastructure which everybody talks about. And after that, I went as Chief Secretary of Jharkhand, because by that time, Bihar got divided into Jharkhand and Bihar. And when I started working, I started applying, some stuff on Aadhaar. So people did not understand what is an authentication. So I said, let me start with authentication. So people were coming late to the office and not coming to the office, and I said, let's start digital attendance system. Aadhaar-enabled biometric attendance system. So that was started in Jharkhand in 2013. And then when I came to Government of India, the new government had, took over almost at the same time. And our Prime Minister actually asked me to do, first of all, of course, they were opposed to Aadhaar. BJP as a party had said that we will scrap Aadhaar or we will revisit Aadhaar and stuff like that. Somehow the Prime Minister got convinced, and I have never met a politician who is so sharp and so, takes technology and he immediately thinks of applications of technology. So I think he immediately got it that Aadhaar is a very transformational project, and he started, he said, let's do it. And we started digital attendance system in Government of India, and now I think almost every department of the government has got the Aadhaar-enabled biometric attendance system. So that was also a coincidence that I got posted in the Information Technology Department of the Government of India. We started Digital India program. And a couple of areas of Digital India was, one was digital connectivity as a utility to citizens. And that is, digital infrastructure is so important, because if you don't have connectivity, then you don't have anything. I mean, nothing can, systems don't talk to each other. So connectivity is at the heart or the base of digitization or digitalization, as some people say. So that was one area. Another was software and services on demand. And third was citizens empowerment. So we started that program. And then fortunately, after, maybe about 15 months or so, I got posted as chairman of the Telecom Regulatory Authority of India. And then that time the data was selling at 275 rupees per gigabyte. Today's data is selling at 7 rupees per gigabyte, because you can get 28 gigabytes of data in 199 rupees, right? Ravi, what rate are you selling? You are also selling the same rate or maybe cheaper? Great. So this is how, so that, today we have 1.28 billion mobile connections. We have 800 million internet connections. We have, digital ID for everybody. And now, even, laborers from my state of Bihar and Jharkhand who are in Delhi, every evening they talk to their families on a video call. They don't bother about, the rates, because the rates are so insignificant and so low. Earlier, if you remember, many of you may remember, the call was costing 8 rupees 40 paisa for 1 minute. And if somebody gave you a call from outside, then even that recipient was also paying the same amount. So people were doing missed calls. So now, now this is the situation. So I think our country in a way is hyper-connected. Now we have 4G, we have 5G, and it's fantastic. And the bandwidth is also not a major problem. 64 KB, which Ravi talked about, is no more, it's a history. Now we have sufficient bandwidth, a very quality video calls, and which happened. So then I retired back from, the TRAI in September of 2020. And then COVID happened. COVID happened in March of 2020. So then one of the issues was, how do you vaccinate this country of this size with, maybe multiple doses of the vaccine and multiple types of vaccines? And you can't do the cocktail of these vaccines, with the sense that if you have vaccine 1, then Dr. Gupta is sitting here, you can't have the other vaccine after certain time, so you have to have the same vaccine. So then the problem was, how do you ensure an orderly vaccination in this whole country of 1.3 billion people? And then I was lucky to have been drafted for CoWIN. So, because I had given a presentation to the Prime Minister saying that vaccines may come, we don't know when they will come. This was June of 2020. But if and when it comes, we should have a very good digital backbone to ensure that we are able to vaccinate our people. And that digital backbone somehow could not get created, and then, suddenly I got a call from the Cabinet Secretary saying that you come and join the Government of India, and you are in charge of making CoWIN. Name was given, of course. So this was in the 6th or 7th of January, and the Prime Minister was launching the vaccination program on 16th of January 2021. So that is how I came to health. And they said, you have to have an office or something, so we will make you the CEO of the National Health Authority. So as I said, I have never worked in health space. I worked in all kinds of spaces, science and technology, rural development, education, HRD, personnel department in my state, Department of Economic Affairs in Government of India, and IT ministry, never worked in health, never. So this is the first time I got to work in the health space. And CoWIN, of course, developed. Initially, it had some issues, but fortunately, it worked. Now we have 2.4 billion records in our database in CoWIN, which is basically every person, 1.2 billion vaccinations, and everybody has got 2 or 3 vaccination records. So this is how it happened. And during that period in the National Health Authority, I came across, I realized that after fintech and after digital infrastructure, etc., health is a massive opportunity for digital technologies to permeate in. And therefore, we started what is called the Ayushman Bharat Digital Mission in September 2021. Prime Minister launched it on I think 21st September or 23rd September 2021. And we had learned by this time from UPI experience, from Aadhaar experience, from other DPIs, we had learned that for any societal digital system to succeed, we need to have certain attributes of those digital systems. These attributes, as I said, should be open source, openness, open standards, open APIs, and of course, scalable, interoperable. These are some of the stuff, because India is such a fantastic country. There's no country in the world which is as diverse as India. Talk of diversity in every sense of the term, every dimension of diversity, whether it is language, dresses, cuisines, anything. It's so fantastic. And we celebrate diversity. We don't think diversity is a challenge or something, to be ashamed of. We are proud of this diversity. And therefore, for any system to work in this country, that system has to cope with this kind of diversity. So we created a very, very democratic, open system called Ayushman Bharat Digital Mission. And the essential idea was that, we learned, for example, from Aadhaar, that we need to have federated infrastructure, federated data. And what is the meaning of federated data? It means that when you are getting, let's say, ration from using Aadhaar authentication, the ration transaction data is with the ration fellows, not with Aadhaar. Aadhaar does not even know for what are you doing the authentication. You are doing electronic KYC for bank account opening. Aadhaar does not know. Aadhaar just simply, at the instruction of the individual, Aadhaar just dishes out the KYC digitally signed document. So this is called federated data structure, which means that the transaction data is federated. It is not with the same person. So Aadhaar cannot do any profiling. Aadhaar does not know your activities. People think that Aadhaar knows every time, what did I do? Aadhaar does not know anything, believe me. There have been 117 billion authentications in Aadhaar so far. But Aadhaar is not aware of any kind of activity which you do. So essential idea is, similar is the federated data structure in Ayushman Bharat Digital Mission. This is one principle. Second principle is that it is the patient who is the owner of that data. He's a data principal, which means that, without patient's command, data can never be transferred, shared, or made visible to anybody. So that's another principle. So on these principles, we have structured and made Ayushman Bharat Digital Mission. Now, for Ayushman Bharat Digital Mission to succeed, what should happen? Every health facility, and Dr. Gupta is here from Felix Hospital, every health facility has to make the records, because records are not going to Ayushman Bharat Digital Mission. Only the link of the record is going to that. So we are just having a URL, the ABDM IECM, this is called Health Information Exchange and Consent Manager, HIECM. This information exchange and consent manager is essentially going to store only the URL of the data where it is lies. So therefore, all the hospitals have to make the data available at a place which can be accessed 24/7 and which can be accessed at the patient's command. Now, how does the patient give a command? Because now patient has got a digital identity and there is a consent artifact which actually is the token, is the digital token which tells that yes, I am giving the command to HIECM to fetch my data from Felix Hospital or wherever my data is lying to the doctors to whom I am consulting, and he can also decide as to which data to share. Suppose a person has got AIDS, he may not like to share the data with somebody for bone fracture he has gone to. So therefore, what is important is he shares the data which, which he wants to share. It's a very granular kind of architecture which has been made. Now, the success of this will depend on the hospitals participating in this whole program. If no hospital participates, then this HIECM will have no data. And if HIECM has no data, there is no Ayushman Bharat Digital Mission. The patient cannot really, he will have to have the jhola with all the X-ray report and everything, go to the doctor. So it's not going to work. So therefore, PPP, somebody talked about PPP. It is already built in without PPP, and I completely agree that 70% of the health care is being provided by the private people in this country. And therefore, if you exclude them, there's no ABDM. So, but what is important is, now what is happening, I am seeing this, is that everybody wants to see others' data. Nobody wants to share their own data. So Felix Hospital will like to see the data of the Escorts or the Medanta or whatever, Max. But they will not like to share their own data to them. Now, everybody thinks that, this is my data, I will have, mera pura control is pe rehna chahiye, nobody should see the data. It doesn't work. And therefore, my recommendation to the government is that, you should give this, you should have some regulation in place to ensure that everybody who participates in the ABDM, if he agrees to share his data means the data which is kept with him, to the others at the patient's command, then and only then he should be capable of seeing others' data, other hospitals' data. So this should be a binding, legal binding. And unless the legal binding happens, unless there is an MOU, whatever way, I'm not saying regulation is the only way, there could be a willingness on part of everybody, there could be a coalition. When I was the CEO of NHA, I had called, all the diagnostic labs. Diagnostic is very important. I want to share my diagnostic data, blood reports, all samples to others. So we called all the Dr. Lal and other major diagnostic facilities, and we said, please, share the data. And the way to share the data is through the common identifier, which is called Aadhaar, Ayushman Bharat Health Account. This number is largely built on Aadhaar only. Aadhaar is the underlying identity so as to ensure that people don't get 2-3 Aadhaars and they will get confused themselves, which one to use. They will have only one Aadhaar, and that's the identifier across the system. Now what happens? Felix gives his own UHI, unique health ID, right? When somebody goes to your hospital, you give your own UHID. Then they go to Max, they give their own UHID. Now if the UHIDs don't talk to each other, you could give a common identifier, which is Aadhaar, and then ensure that records are there. Recently, I wrote an article, in fact, on 9th of April, I shared with Arvind and Ravi in Indian Express, where I said that patients should be incentivized to share their data. There should be, what is happening, we all talk of AI, and this is an AI thing, and I have not talked about AI till now. The AI is essentially dependent on data, because the programs depend on the instructions, but AI depends on the underlying data on which it is trained. And if there is no data, then there is no AI, right? You can't, use the Western data to treat the patients of India. India have got Kala Ajar, Now, you don't have Kala Azar in America, right? You don't have certain specific diseases, all doctors are here. So therefore, I think what is important is that we should have the data, the anonymized data. Unless that happens, the system will not work. So I just, wrote it, and it is very coincidence again that today I am, I got to know about this participation, but I had not thought about it. I had sent this data article maybe about a month back to Indian Express, and they published it on 9th of April. So this is how I think data sharing is very, very important for the entire digital health system to work, for ABDM to work. Without that, it shall not work. You see, adoption of technology is very, very important. What happens is we may have technology tools, but then unless they are applied, and I completely agree with Ravi and Arvind that, unless, howsoever sophisticated the technology may be, unless the technology is useful for the people, it's of no use, it's useless to my mind. So therefore, I think it should serve, and it should serve rather bottom of the pyramid. Today in India, we have the tools to make any transaction happen in the digital space. Let me take one example of telemedicine, teleconsultation, which is so much required in this country, because this country cannot have doctors in every panchayat. Doctors also have their children, and they want their children to study in good schools and good. So therefore, they will always be, city-centric. They will be concentrated on the cities. So how can you ensure that, we are able to optimally provide service to the villagers? Fortunately, today we have the connectivity. Every village is having 4G. Every person has mobile phone, and the mobile phone numbers are about 700 million, if I'm not wrong, to the last count. And they are actually growing at the rate of 25 million per quarter, maybe more now. I'm a little obsolete in terms of these figures. But then everybody has got a mobile phone. Everybody has got connectivity. The data is very cheap. Now everybody has got digital identity, which means that the person who the doctor sees, he is able to be sure that this is the person who he claims to be. Similarly, doctors have been provided what is called health professional registry. So they also have health professional ID under the ABDM. So the person who is being treated also sees that this is the real doctor. He's not a quack. That's another part. Then doctor requires money to be paid, consultation fees. Now, because they are, doctor is sitting in Mumbai and this person is sitting in Lohardaga in Jharkhand, this person cannot pay him the fees. You have the UPI, you have the digital transaction, so you can pay that. Then doctor writes prescription. The prescription, he cannot deliver it to him immediately. Now you have the digital signatures, which is called eSign, signatures on demand. You can do, so the entire life cycle of all kinds of procedures can be done using digital technology. So we have all the infrastructure in place to make that happen. I mean, there is no, no way we cannot, nothing can be sort of, nothing is impossible, because every system, we have a consent token. I can share my record sitting to the doctor on the other end just by a QR code. I scan the QR code and immediately all the records are fetched. So this is how, things have been enabled. So all the enablers are in place. What is required actually to accelerate this pace, and I think acceleration is absolutely required, is the fact that we should create, we should obey certain principles. We should obey the principles of, obviously data security, data privacy, data encryption. These things are very, very important. We should have them. But what is important is it's a collaborative effort, and we should accelerate, and we should share the data. This, I think, will happen. AI is a great tool in areas of diagnostics. It's wonderful, because you can always have second opinion, and what we had wanted to do was essentially, create software as a service, SaaS model, whereby I can just plug in my MRI and the machine can come back to me and say, aapki ye samasya hai. This is how it should happen. It should be user-centric stuff. So that should happen. By the way, currently I am heading a group. I am mentoring a group in IIT Kanpur where I am the professor, visiting professor there. I am mentoring a group on creating digital in public infrastructure in health. So basically we are creating an HMIS for a small clinic. Because large hospitals like Felix, Max, etc., they can afford to have an HMIS, large HMIS. And even the eSushrut, e-hospital, eSanjeevani, all these things are there for large hospitals or government hospitals. We are creating something which is, which can be used like a, you create a Gmail account. Similarly, you can create an account and, you are good to go. You can manage your calendar, you can manage your appointment, people can book appointments online with you, you can do teleconsultation, you can do physical consultations. These kinds of things are being done. And the idea is, because that got this whole 2 years of my life in National Health Authority actually convinced me that this is an area where we should continue to work. So whatever little contribution I can make to this area, I'm trying to do that. But I can assure you that after FinTech, health tech is an area, and to the innovators and the starts of Arvind, that the STPI, which he is actually mentoring 2,000 startups, I would say this is a fantastic area. And I'm also convinced that the creativity can happen at the intersection of two disciplines. Creativity does not happen in IT, creativity does not happen in health alone. Once these fields intersect, then, real creativity happens. And I think the collaboration between the doctors and engineers must happen. And we must create new tools, new products. India must become a product nation. Thus far, we have been just a service use nation. We have never created anything very, very substantial. And I think we should. This is a great opportunity. There's a great incentive by the government of India to have the programs of startups, and I think we can tremendously benefit by these things, and we can create. This is a moment. Actually, this is digital health is an idea whose time has come, and I think we should all collaborate to make it happen. Thank you very much.
Thank you, sir. Thank you so much for sharing how the digital India and digital Aadhaar and you got into the health. Ladies and gentlemen, we will not have a break. We'll have the session continue as the CIO session is waiting. We'll have a break at 2 maybe 2:15 or something, the lunch, because we are late on the session. I request the chief guest to present the mementos to the panelists. First to Sri Robert Reviji, the CMD BSNL. May I request Dr. Sharma to present this memento. Ladies and gentlemen, give him a big hand. Then to Arvind Kumarji. Once upon a time, all the three were together in the same department in TRAI. Then to Dr. Gupta. And then to Father D'Souza. Now I request all the panels along with me together to hand over this memento to Dr. Sharma. Thank you. We'll start the next session immediately so that we'll have at least the lunch, maybe not very late. I request the chairman Mr. Sumit Puri, CEO of Prana Wellness, to come on the stage, please. Praveen Bist, CIO Amrita Hospital. Arun Goyal, Director and CEO Sir Gangaram Hospital. Vivek Gupta, Vice President, CISO Business, Country and Management, Manik Pharma. Pankaj Gulati, Vice President, IT, Culture HealthCare. Dr. Amit Dixit, Founder and Managing Director, Amrit Medtech Private Limited. And Ms. Noor Fatima, Chief Technology Officer, Islovi Solutions Private Limited. May I request all of you to please come on the stage so that we can start the session. Please come on the stage. Ms. Noor Fatima is around? Yeah, please come. Please come. Sumit Puri, over to you. Don't waste the time. Yeah.
Hello. Yeah, good afternoon, everyone. I know we are probably between you and lunch, so we'll try and keep it short and sweet. I'm Sumit, and I basically have worked about 30 years in consulting, insurance, and healthcare sector across geographies. And obviously, I used to work for Max Hospital as CIO. I was at the Evercare Hospital as Group CIO in Dubai. And now, of course, doing Prana Wellness. But without further ado, I will, kind of start the question round for our esteemed panelists. I'm just going back in time a little bit because, we asked about my CEO once, what about IT keeps you awake at night? And this is a question for many CEOs, actually. And you talked about cybersecurity. My patient data getting lost, getting hacked. So that's the topic. That's what you're going to talk about. How do you ensure security of data? And I'm sure we have esteemed panelists with a lot of experience around this. So that's what we basically will talk about. So hopefully it'll add value to all of us. The first question really, to us, of course, Praveen, will start with you. What are the most pressing challenges that IT leaders face in safeguarding patient data across increasingly complex healthcare systems? We have legacy, we have the new age systems, all of this coming together. Now we have telehealth, we have IoT devices. What do you think are the most pressing challenges that you face in safeguarding this data?
Thank you everyone. And like you suggested, yeah, we'll try to keep it very short because, we all feel that we are right in the middle before the lunch. So in terms of safeguarding the data, obviously that is very paramount today, because with the advent of digital transformation, we all understand how critical it is to digitize the data. But then there is a flip side to it, which is how do you ensure the safeguarding of it? And it is, I always like to give this example that digital data is not something that you can very easily perceive, right? You cannot, control it by keeping it under lock and key. You can have the complete data with you, but the same thing could be, taken away by somebody else, being misused, and you won't even get to know about it. So it's much more different than a physical upkeep of any other property for that matter. So that being said, we are using the latest technology. We are working constantly on using AI to ensure that we are able to look at all the possible transactions. If somebody is trying to access the data, is it the right user? Any anomaly in the requests that we get from the different servers. We, with the advent of big data, with the advent of AI, we're able to do this very, very quickly. And another analogy I always like to give is, the decision making or the time to response is very, very critical. Just imagine you are in a driverless car and there is an obstruction in front of you. And car is able to figure out, yes, there is an obstruction. But if it takes more than few milliseconds to react to it, it's too late. You're already hit the bump. So that being said, yes, it's very critical, and we have to use all possible technologies. Unfortunately, the other side, or whoever is trying to get into your firewall or your boundary is also having equally equipped with the tools and technology. So it's a constant fight. And yes, it does give me sometimes sleepless nights. Thank you.
Thank you. So I think I'll probably, pass it on to you. And very clearly, it is about being one step ahead of the hackers. Over to you.
Hello. Okay, so in my opinion, the most critical data item is data security. These days, as we are aware, it's AI versus AI. So at one side, one edge of the security side, we are tackling with AI. On the same, we need to use AI for the data security as the hackers are much ahead of us, I will say. They are 2 steps ahead, so we need to think from there. We need to put ourselves in their shoe and think as they are thinking. So data security is one of the most critical aspects we need to take care of. And data security can be handled through cybersecurity aspects, through tools, with hardware like firewalls, webs, and many tools are there. So we need to incorporate all these things into our infrastructure.
Thank you. Fatima, please.
Yeah, hi everyone. Hello, I'm Noor Fatma. I'm the co-founder and CTO of a startup. It is EasyOfy Solutions. And what we have built is so it's a lot talk about AI. So what we have built is an AI-based image analysis tool. So we analyze X-rays, CTs, PET, MRIs, and for specific diseases, for TB, chest health, lung health, then MSK, we do brain tumors, a lot many things we are doing. So for us also being a startup, it's very challenging for us to ensure that whatever patient data is coming onto our system, it's safeguarded. So we have so many things in place. For example, the data servers which we are using to store, so it's a cloud-based system. So the data servers which we are using, those have to be compliant with GDPR and HIPAA. That is first and foremost. The platform which we have built, that should be compliant with these compliances. The second thing is we follow the standards in healthcare. So there are so many types of data. So there is the clinical data, there is the text data, there is patient data, there is medical imaging data. Now all these data have standards for storage as well as for communication, how we are communicating, because ours is a very small peg in the system and it integrates with other hospital systems. So that is that was very foremost for us. Like when we started building the platform, we studied all the data standards which were there in the world, which were being followed, and we were very stringent on following that. There were no shortcuts about it. And that is how, and then there are regular audits. There is regular cleanup of the system, vulnerabilities, because new vulnerabilities could come in the software. So all those things we take care, and that is how we have built the system until now, and 2 years of operation. And touch wood, we have had no such instances.
Wonderful. And I think, I guess, all of us are obviously doing what is required to somehow safeguard. And as, we actually heard, hackers are always trying to also outthink what we are trying to do. Now, beyond this, we now have AI, right? I mean, we briefly mentioned to AI, coming up. Now, this is artificial intelligence multiplied. We pretty much have so much of data which is now being used to further refine algorithms and also, in some ways, enhance the efficacy of hackers, right? So I would say, specifically on AI and machine learning, this has its own unique set of challenges, on how do we really safeguard data. This is where some unique risks and some unique approaches might need to be done. Because, now data is multiplied. What it used to be, it's like what is now created in the last, I believe, 2 years has not been created in the last 100 years. That's the amount of data that's coming up. So I'd like us to touch upon a little bit more about those unique challenges which AI today poses to us, and what could be the possible solutions to make this, kind of a better management of our patient data, for the hospitals. Ravi?
Yeah, definitely. It is challenging, and like you very rightly said, the amount of data that is being generated is exponentially rising. Now, you talk about any device for that matter. You talk about wearables. It is able to give you so many parameters, and all of it potentially is digital data, which can be compromised if you don't keep it in safeguarded properly. So when it comes to some of the unique ways in which how technology can be used to further protect it, I think we have to go back to the basic rules. One, most of the cases, if you look at in the past, the root cause, so to speak, of a data leak is actually your internal users. If you can ensure that they are doing some basic, very basic routine hygiene procedures, if they're following, you can prevent majority of it, because it could be an email that somebody is looking at and clicking on a link, which happens to be spam, which he or she should not. It could be as simple as that. And a lot of times it's always a 80-20 rule. So 80% of the threats, the cyber attacks are resulting from those commonly used tools, so to speak. And if you can prevent that, that itself give you a big boost. But at the same time, there are more sophisticated tools. So we use SIEM, we use SOAR. So these are tools which can kind of automatically look at all your traffic that is coming in, and if they detect any anomaly, it's able to shut down or isolate that part of the system where that potential threat is coming from. And it is also able to then further analyze, either alert the right people that it has to be taken care of, and also act upon it to look at the DR side if we have to go to that level. So all of this can be automated, and now with more so with agentic AI, right? We have not only AI, but how do you automate and ensure that the AI is actually able to do, not just provide you with information, but actually take decision and move forward with the execution of it. So that, I think, we also have to be equally clever in the use of AI, and agentic AI is another good way to make use of it.
That's a great point. Great point, Wayne. What's you, please?
So to start with, I will say there are some basic techniques these guys are using, starting from social engineering techniques, which we are aware of, phishing, wherein they are sending some of the emails with some links, some attachments, and normal user falls in their trap. So now some new techniques are coming in, which is like wishing and smishing, wherein instead of sending out the emails, they are now using the voice calls. These fraudsters are directly calling the end users and trying to fetch the required details through voice calls or through SMS, which is known as wishing and smishing. So these are some of the new techniques they are using to trap the innocent or the end users, I will say, to get the required data and misuse that data. So we need to be very attentive and don't fall in these traps.
Dr. Fatima, please.
So there are certain things wherein we can use AI itself to see if there are any anomalies. For example, if there is very unusual traffic on your system, or you can train the AI to learn how a user is basically responding, what are his behavior. So for example, there would be certain users on your hospital system, they have their logins, emails, everything. Now a certain user, you can train the AI to learn their behaviors, when he is logging, when he is logging off. If there is unusual activity, if there is a fake login or something, it can detect and it can tell you what problems are. Then regular audits, if your data has been accessed by other people as well. So there is a trail, and when there is an audit, you know that there is a problem, and you can take care of that problem. Then also, the other thing with the threats, etc., is that one is the stealing of the data, the second is shutting down of your system. So there was an incident at AIMS where the servers, basically their medical images servers, they shut down. And when those servers shut down, basically the operation of the hospital also shuts down. The patients are there which are affected. So there are when the hackers strike, they are targeting you two ways. One, they are stealing your data and you misusing it. The second part is they are shutting down your hospital, your operations. So the second part also we can take care. We can have backup servers as well, wherein if it automatically comes up if there is some problem with the main server. So these are certain ways in which we can ensure that it runs smoothly, because what happens is more and more data is coming onto the platform, more and more AI models are being trained, and they are being trained on all sides, cybersecurity as well as our medical images, medical technologies. So these are the systems wherein we can assess what has to be gone into the workflow, and we can prevent such mishaps in the hospital system.
So I think, again, some great points made. And I must say that, if we just talk about a few points, we've said that, yes, patients are, and, in some ways, it's absolutely sacrosanct. The data is sacrosanct. I just was reminded of an incident where the US Vice President, this is a few years ago, about 5-7 years ago, there was actually a news that somebody was trying to hack into the pacemaker of that hospital to actually, cause his death. Now, this is the kind of risks we carry, in terms of cybersecurity, if we have, vulnerabilities actually available in the system, biomedical devices that we actually have, those are also sometimes, not patched as well. So significant challenges. And as we rightly mentioned, it is about educating the weakest link, which is our employees, right? And of course, also leveraging AI, agentic AI. When you actually have the dark web, you also have, from your side, prepare your defenses, become much more, stronger when we actually fighting these forces from the hackers. So I'd like to talk about more the weakest link, the employees, the internal threat. What could we do to, in a way, foster a culture of security? Because frankly, as CIOs, as CISOs, and I've been a CIO myself, security is everybody's problem. It's not only IT. What do we do to foster that culture is what I'd like you to comment upon, please.
Yes, so we do face this question from our management very often, that how do we ensure, especially the weakest link, which is the employees themselves. Nobody intentionally want to do anything wrong, but it does happen with now. He just mentioned that it's not just the email now. There could be a voice call with mimicking exactly maybe your boss saying do this, or act on some particular fashion which is detrimental in a long run. So I think the basic is going back to our employees, reminding them, and humans in general, have very short memory, right? We already have forgotten how COVID was, even though we went through it for 3-4 years. But the idea is that constant reminder, and then also we try to do as many mock drills as possible, because that is something that stays in their memory. If there is something they do in action, as opposed to just listening through a lecture and then trying to recollect or remember when they happen to see an email with the link that is not supposed to be clicked. So I think we do such mock drills also that helps them. And other thing is, like I mentioned earlier also, emphasize that it's not a physical, data is no longer physical, that as long as it's there in my servers, it is safe. It could be copied, it could be distributed, it could be misused in so many ways without you even realizing. So the importance of it, the severity of it, I think if we keep emphasizing on that and make sure that the message is driven home, and from their brain it should go to their heart as well, and then they get it. So that's all.
From the brain it should go to the heart. Excellent, excellent. No comments, please.
So I will say it should be the top to bottom approach. Management commitment should be there. We, as a part of the management, start and lead by example. So if we start leading by example, it should come down to the end users as we committed. Normally we see in the organizations, in the hospitals, data security awareness trainings happens at the time of joining, when the new hires are there as a induction program. And after that, we forgot about it. And just to be compliant, just to stay on the regulatory compliance piece, we just had once every year as a kind of refresher training. So my opinion is, instead of getting these refresher trainings once every year, it should be an ongoing exercise, and random, every week, every month, with different set of end users, so that mock drills can also be taken care of, these kind of things for the end users, security and awareness. That's my say here.
Excellent. Dr. Fatima, your comments, please.
Yeah, so we are a HIPAA compliant platform. So we have regular audits. So there is an audit trail which is included in the code, which tells us who has logged on, what data he has accessed, and if it was necessary or not. So that is one thing which keeps check on our employees, that they do not access data which is not permissible for them. The second thing is GDPR, then the DPDP Act coming, and also for us, what is important is so as a platform, there are certain things. So there is storage of data, there is AI running on one server. So there are certain things which are coming together, and then the platform is running. So we also have to make sure that when we are checking in the code, so there is a repository wherein we check our codes and everything is there. So we do not expose any sensitive information, the server information or any key or all those things. So for that we have regular trainings for our employees, and we also ask each of the employee every time to take a training. So every time one of the employees would take a training of others, and there would be a quiz which they would answer. So that is how we ensure that the weakest link, which in our case are the employees, they take care that they do not expose anything which is not permissible for them, and they do not risk any exposure.
Excellent. So I think some great points. I mean, if I just was to quickly, summarize some of those points that are made, we all know that there is a need to probably do mock drills to kind of have more internal trainings done to users. We've talked about the fact that we should be regulatory refresher training happening maybe once a year, where people mandatorily have to go through the details of cybersecurity. Everybody's educated and aware. And, trying to look at also the brain to heart, kind of appealing to their heart, because obviously healthcare, extremely sensitive data. How much you are also responsible to protect your patients, your customers. That's also very important. At the same time, use tools. Tools like, of course, you could use different kind of assessment tools. You could have software quality assessments done. What could you do to strengthen, on that side? And of course, even agentic AI and all of that can also be used there. So in parting, I'd just like to have one line from each of you on how do we strengthen cybersecurity. What could be the one message takeaway for everybody? Because, like I said, I want to promise to be short and sweet. One line from you on what could we do to enhance cybersecurity.
One-liner would be to keep it simple. And I'll give you an example. We once tried to enforce that the user should have a very complicated, strong password. And I'm sure you cannot relate to me. It will say you should have so many, special characters and caps lock and all that. And then what ended up happening was the password was so strong that they didn't remember themselves. They would end up writing it and sticking next to the, wherever device they are using. So that beats the whole purpose of it.
Keep it simple. Awesome. Great.
So I will say ongoing training is required. So instead of, as I mentioned in the previous comment, instead of the annual refresher, it should be an ongoing exercise, and continuous monitoring should be there for all the data security parts.
Great. Dr. Fatima.
So for me, the one thing would be the compliances and the standards. For us, we have been following the standards and the compliances, and we are good to go. We have that confidence that yes, the data which is coming onto our platform is secure.
Excellent. Thank you so much. Thank you, audience. Any questions? Otherwise, please.
Yes, sir. Namaskar. I'm Dr. Jagdish Shivahari, professor and ex-scientist ISRO. Sir, my question, how is the digital healthcare system in India efficient and different than developed countries in terms of digital healthcare model, potential priorities, and implementation challenges?
Who would like to take this?
I can answer it in a lighter tone. So I was in US, it's maybe like a decade ago, and we were talking about moving the system from ICD, 9 to 10 at that time. It was a huge task in the US, and we used to joke around it. Arey, India mein to humne bas change kar diya, change ho gaya, because we never used to use it in India. So, it's on a lighter tone. So I think the major challenge is the usage of it, and sometimes usage in India is low. We have to accept. But with the use of AI, we can make a big difference. And again, I want to give an example. The biggest challenge today in healthcare in getting digital data is able to capture what doctor really has when he is conversing with the patient. You know, he can speak to the patient for 10 minutes during consultation, and he has to, you expect him to enter in the computer, it's not going to happen. It has not happened in the US, neither it's happening in India. So how easy can you make it? So now we have come up with the tool which is able to record your conversation and with the use of AI, categorize it to the right, you know, whether it's a diagnosis that you have been talking about, whether it's a medication you have been talking about, whether you have been the social history or family history or whatever it is, it categorizes and then pushes it back to the EMR. So that's the kind of tool and technology we have to, you know, use to leapfrog. We have done in UPI, you know, financial system, and we can do it in healthcare as well.
So I'll just say that also, just to add to what we just heard Veen talk about. I think the fact is that India will actually, it has so much intellectual power. We will actually invent, very ingenious solutions. We are kind of, in some sense, overburdened, by the fact that there's so much population and so much diseases. We are the disease capital of the world, and we also have excellent doctors. There's no question. But the fact is, and I'll give you an example because I've worked in quite a few countries. In a few countries like Australia, there is a mandate that you have to spend at least 15 minutes with each patient. If you look at the US, the difference between a good doctor and a doctor who's sued is 17 minutes, which basically means if you spend less time, the patient feels that this person is not a good doctor. You cannot have that approach in India. The number of patients that come to visit AIMS or Safdarjung or any of the government hospitals, just imagine. You'll probably be seeing 30 patients, 40 patients an hour. That's the number. So we have to make technology accessible and easier for the doctors. When you talk about digital health infrastructure, the infrastructure is there. We just heard, sir talking about amazing, kind of work done in Ayushman Bharat and the Aadhaar IDs and everything. But the challenge is, how do we make the technology extremely accessible and easy for doctors? When I was at Max, I must tell you, our KPI was, as CIO, the KPI was, when you did e-prescription, when you have to enter data in the system, the time taken to enter the system should be less or equal to the time taken to write the prescription. That is how compliance can happen. Standards can be followed. And that's how we moved from a 7% to an 85% adoption. So tools are there, but then we also have to realize the context. What is the context we have in India? How do we make it possible? Because you could have medical transcriptions in US. You might not be able to do that in India. We have to do it with technology, with our ingenuity. I mean, how Chandrayaan has gone to the moon at, lower the cost than gravity movie. It is our ingenuity, Indian ingenuity. So to me, that's something we have to kind of keep in mind, that standards are there. We will need to follow it using smartly technology that we actually have at our disposal. So that's what probably I'll add to. Any other questions?
Hello, the panelists. I am Dr. Vasantara from Mediseva. We work into rural domain of India, and we facilitate them, the rural patients, for the urban doctors. Our challenge is how we correlate the technical advancements of India to the rural patients. As what ma'am is saying about her technical advancements, as what you guys are saying about your technical advancements, we are seeing the 75% of the Indian population which is sitting in rural area, and they are not even aware about what is teleconsultation. How do you correlate it, and how do we restrict with the compliances for the data that they'll be giving to us?
Great question. Nama, do you want to start?
Yeah, so we, as a company, we have been working in rural areas. So we are working in MP, we are working in certain parts of UP, and we are working in Northeast India also. There we are facilitated and helped by the government agencies. So we are working with Niti Aayog, we are working with the local collector of the area who are basically creating awareness and then adopting our tools at the regular PHC or the CHC level. So that type of policy, see, as a startup or as a company, we do not have the means and resources to go all over the place. So that ways we have to be facilitated by some government agency. For example, if you are working there, you will have connect with your collector, or you will have connect with your the CMO. So you can ask them for such tools, and they will for sure they'll facilitate such tools. So there are public companies like NIC, etc., who are working on such tools. We are working with them to help them build those tools. So they will put you in connect, and so the requirement should come from there. I mean, the local collector or the CMO is responsible for these things, and the requirement should come from there. And once the requirement comes from there and it is necessary, then the government also works in facilitating those things. Yes, it would take time because of the scale of our country, the population of our country, and the challenges. But with the network coming in, with the 5G, 4G in place, so now for us working there is not a problem. We are working. So that is one of the challenge, and it would come. So you will have to, as a healthcare worker, you will also have to put in a little effort so that it comes to you. And you can contact companies, and they'll be very willing to help and facilitate such certain things.
First of all, I want to definitely appreciate your work. I know I've been also in multiple rural areas where it is not as easy. So, great work. With respect to how we can bridge the gap, I think awareness plays a big part of it. And I think we should, suggest to some of the government officials, just like we all hear Paytm karo. Instead of that, it should be ABDM karo. That's the way we have to encourage all the people. And with IT, yes, everybody has a smartphone. So it's an app that is being delivered, which they also equally have, just that they don't know how to use it or what it can, do to them. So it's just a matter of awareness, and I'm sure we are there with the advent of technologies.
The population majorly is very much scared about sharing the data. That is the prime, restrictions there. So that is something which obviously, as what ma'am has suggested, as what you have suggested, ABDM karo is the best thing. But but there we would like to have the help from government initiatives a lot. Yeah.
Sure. I'll just say that, look, it's also about, in a way, creating a collaborative ecosystem, right? Frankly, I mean, if you look at, what we heard in the previous panel, we had BSNL, STPI, we had such amazing talks about how can we create, a very digital infrastructure across the country. Ultimately, even at primary healthcare centers, it is how do you really leverage some of those technologies and tools and infrastructure that's available to our benefit. So we will need to, actually try and be a part of the ecosystem. It's not only, the government of India's responsibility, it's also our responsibility to explore where can we create collaboration. In some sense, that's going to be very important as we go forward. So I think there is a need to start looking at this. The success story of UPI gives us so much hope. I can tell you, I have had examples from Kenya, from countries like, in GCC, in Gulf countries, asking us how UPI was created in India. They are really marveling at the actual, infrastructure set up by us. So the same way UHI could become a reality, ABDM, exactly as Praveen said, there is a huge possibility. If we create a collaborative ecosystem, if we start sharing data, if hospitals, private hospitals in particular, start making it more about us than them, you will see a lot of difference happening. And there is going to be training, there is going to be awareness, all of that will need to be done, but we will need to be a part of it. It can't be left only to the government. That's my sense. Thank you. Any other questions?
So I'm Varun from Pyramid Cyber Security and Forensics Limited. So as we are discussing about phishing attacks and the social engineering cyber attacks, what about, and we have discussed about the AIMS attack in 2022. It was very famous in the medical sector. So what about implementing multi-factor authentication? And like in WhatsApp and other social media tools, we have two-step authentication steps where we are securing our data. And also, what about implementing training programs in hospitals and medical centers where nurses, doctors are trained about how to use the system and safely use the system? So talking about these.
Yeah, I think somebody has to talk.
I would like to answer this question as we discuss social engineering, phishing, wishing, and all. So two-factor authentication is one of the best practice one should follow. But on the other hand, I will just share an example with you or a real case with you. That's a US case. One husband and wife were there in the room, and after a while, police was called by the husband and said, one person came, he was a thief trying to stolen some things. He tightened our hands, and my wife was against them. She was countering in them. So basically, during the argument, those thieves killed my wife. And there was no one else, no cameras, no CCTV. But police was in a kind of a situation where they were not believing his story, husband's story. So they tried to do the research, trying to find out the CCTV footage. There was no evidence which was going against the husband, but police was still not believing his story. So they wrote, during the investigation, they found one Alexa device was there. So they wrote to Amazon, asked for the Alexa evidences, if what had happened during last 1 hour, during when the incident had actually happened. So initially, at the very first go, Alexa, that Amazon guys replied that we are not listening to any conversation, we are not recording anything, so we can't provide any evidence on that side. But later, when they insisted, they had gone to their terms and conditions, their fact sheets, so they finally agreed to share the data. And during that conversation, it came to know that a husband actually had the argument with his wife and killed his wife after that conversation or the argument. And with the help of that Alexa recordings, they were able to identify that or solve that particular case. So yes, two-factor authentication, to answer your question, is one of the best thing. Encryption and all needs to be supporting along with that. So technology plays a vital role there.
So I think it's on a lighter note. I mean, we're saying Alexa, be wary of Alexa. I think that, but in general, of course, there is a need to enhance, two-factor or multi-factor authentication for sure. It will need a coordinated effort. There's a cost involved. There's a response time problem also, which is there. But for sure, this is very critical, in terms of enhancing overall, security for the data. And I'm sure it's left to individual institutions to decide what is the best course of action for them and the wisdom of all our IT leadership. But thank you so much. I will not take any more time. Thank you again to the panelists. Eminent, amazing. Thank you.
So, thank you so much. Please. With Pankaj note, I hope you guys will not go home and throw the Alexa from the room. He just shared the double authentication. As we said, the database in the morning, in the inaugural session. See, database is the main, bread and butter for any hospital. For that matter, for me, this database is my cream, because I invite. So how do we share the database? Until and unless the rule comes in, none of the hospital wants to lose their patients or whatever it is. It's very easy to say we believe in empty beds, but really the hospital like that? No. But when we write a slogan, we write we believe in empty beds. Having said that, thank you very much. We are late on the lunch. So quickly, we'll have a memento presentation. I'll request Sumit Puri to present it to Praveen Bist. Thank you, Praveenji, joining us here. Thank you so much. To Pankaj. Pankaj is not only a professor, he is my neighbor also. He stays in third floor, I am on the fourth floor. And to Madam No Fatima, the ladies would have been first, but here the ladies are coming last. So thank you so much. I request Mr. Deepak Garg from BSNL's GM to present it to, he is another CIO of BSNL, to present it to Sumit ji. Thank you so much. Thank you so much. Thank you. Thank you. We'll have a 45 minutes quick lunch break.
FRX defibrillator demonstration. The Philips HeartStart FRX is designed to be an easy-to-use, rugged and reliable, automated external defibrillator designed specifically for those who get there first. This demonstration illustrates the functionality of the HeartStart FRX, including easy-to-follow voice instructions and descriptive visual icons that take you through each step of the process for both adult and infant-child defibrillation. To start the defibrillator, press the green on-off button and follow the HeartStart FRX's voice instructions.
Remove clothes from patient's chest. When patient's chest is bare, open gray plastic case and peel off white adhesive pads. Look carefully at the pictures on the white adhesive pads. Peel one white pad from the gray case. Place pad exactly as shown. Press firmly to bare skin. When the first pad is in place, peel the second pad. Place pad exactly as shown. Press firmly to bare skin. Stay clear of patient. Analyzing heart rhythm. Stay clear of patient. Analyzing heart rhythm. Shock advised. Stay clear of patient. Press the flashing orange button now. Deliver shock now. Shock delivered. Be sure emergency medical services have been called. It is safe to touch the patient. Begin CPR. For help with CPR, press the flashing blue button. Place the heel of one hand in the center of the chest, between the nipples. Place your other hand on top of the first. Push the chest down firmly 2 inches. Keep time with the beat. Pinch nose, tilt head, and give 2 full breaths. Breathe. Breathe. Continue with compressions. Keep time with the beat.
CPR should continue to be performed according to standard protocol. To initiate infant-child defibrillation, insert the infant-child key. To start the defibrillator, press the green on-off button and follow the HeartStart FRX's voice instructions.
Infant-child mode. Remove clothes from patient's chest. When patient's chest is bare, open gray plastic case and peel off white adhesive pads. Look carefully at the pictures on the infant-child key. Peel one white pad from the gray case. Place pad in center of child's chest. Press firmly to bare skin. When the first pad is in place, peel the second pad. Place pad on child's back. Press firmly to bare skin. Stay clear of patient. Analyzing heart rhythm. Stay clear of patient. Analyzing heart rhythm. Shock advised. Stay clear of patient. Press the flashing orange button now. Deliver shock now. Shock delivered. Be sure emergency medical services have been called. It is safe to touch the patient. Begin CPR. For help with CPR, press the flashing blue button. Place the heel of one hand in the center of the chest, between the nipples. For patients less than 1 year old, use 2 fingers instead of the heel of your hand. Push the chest down firmly. Keep time with the beat. Pinch nose, tilt head, and give 2 small breaths. Breathe. Breathe. Continue with compressions. Keep time with the beat.
CPR should continue to be performed according to standard protocol. Innovation and you, Philips.
We live in an age of nearness and ease of access to every need and in fracture around us. We have this concept of growing smart cities where we have all the living amenities together. Today, the idea of community living has transformed into sensible cities. We do not have to step out from smart cities for any of our needs. Let it be the schools, hospitals, malls, entertainment hubs. Everything is available just a couple of steps away. A well-planned community living facility brings the world together to where you live instead of making you wander for them. While we are aiming for accessibility, we need to ensure these cities are safe for living. Yes, security systems are vital for smart cities. Why do we need to have a security plan in the first place? The answer is simple, because we as a community are going to live there. We need to ensure social safety, assuring complete city monitoring, help to maintain law and order in the community, controlling the traffic flow, improve city functioning, crowd management, and analysis. How Norden Communications can help with all the concerns we discussed. City surveillance with constant video monitoring, providing public safety with accurate surveillance, traffic monitoring and law enforcement ecosystem, proper law enforcement with ANPR, automatic number plate recognition, and FRS, facial recognition systems. Smart crowd management and people counting, real-time alert for analytics and safety. Smart cities are meant to be safe cities too. Contact Norden Communication to discuss further.
Welcome to the Philips HeartStart FRX defibrillator demonstration. The Philips HeartStart FRX is designed to be an easy-to-use, rugged and reliable, automated external defibrillator designed specifically for those who get there first. This demonstration illustrates the functionality of the HeartStart FRX, including easy-to-follow voice instructions and descriptive visual icons that take you through each step of the process for both adult and infant child defibrillation. To start the defibrillator, press the green on-off button and follow the HeartStart FRX's voice instructions.
Remove clothes from patient's chest. When patient's chest is bare, open gray plastic case and peel off white adhesive pads. Look carefully at the pictures on the white adhesive pads. Peel one white pad from the gray case. Place pad exactly as shown. Press firmly to bare skin. When the first pad is in place, peel the second pad. Place pad exactly as shown. Press firmly to bare skin. Stay clear of patient. Analyzing heart rhythm. Stay clear of patient. Analyzing heart rhythm. Shock advised. Stay clear of patient. Press the flashing orange button now. Deliver shock now. Shock delivered. Be sure emergency medical services have been called. It is safe to touch the patient. Begin CPR. For help with CPR, press the flashing blue button. Place the heel of one hand in the center of the chest, between the nipples. Place your other hand on top of the first. Push the chest down firmly 2 inches. Keep time with the beat. Pinch nose, tilt head, and give 2 full breaths. Breathe. Breathe. Continue with compressions. Keep time with the beat.
CPR should continue to be performed according to standard protocol. To initiate infant-child defibrillation, insert the infant-child key. To start the defibrillator, press the green on-off button and follow the HeartStart FRX's voice instructions.
Infant-child mode. Remove clothes from patient's chest. When patient's chest is bare, open gray plastic case and peel off white adhesive pads. Look carefully at the pictures on the infant-child key. Peel one white pad from the gray case. Place pad in center of child's chest. Press firmly to bare skin. When the first pad is in place, peel the second pad. Place pad on child's back. Press firmly to bare skin. Stay clear of patient. Analyzing heart rhythm. Stay clear of patient. Analyzing heart rhythm. Shock advised. Stay clear of patient. Press the flashing orange button now. Deliver shock now. Shock delivered. Be sure emergency medical services have been called. It is safe to touch the patient. Begin CPR. For help with CPR, press the flashing blue button. Place the heel of one hand in the center of the chest, between the nipples. For patients less than 1 year old, use 2 fingers instead of the heel of your hand. Push the chest down firmly. Keep time with the beat. Pinch nose, tilt head, and give 2 small breaths. Breathe. Breathe. Continue with compressions. Keep time with the beat.
CPR should continue to be performed according to standard protocol. Innovation and you, Philips.
May I request all of you to please take your seats as we are running very late. Smart hospitals and AI transforming healthcare infrastructure for the digital future. That's the topic for the next session. The chairman of the session is Dr. Vishal Gandhi, founder and CEO, BOAR Venture Advisors Private Limited. May I request all of you to please take your seats. If we still delay, the dinner will be at 10 o'clock. So Dr. Vishal Gandhi, may I request Dr. Vishal Gandhi to come on the stage, please. Dr. Vishal Gandhi. Ranjit, can you get Dr. Vishal, please? Ranjit. Dr. Vishal Gandhi. The speakers in the session are Shyam Kumar, Chief Operating Officer, STPI Medtech; Dr. Amitabh Yadwanshi, Coordinator and Head of Cardiology, Holy Family Hospital, New Delhi; Prashant Oberoi, Director, Global Business, Data Center and Intelligent Cabling, Northern Communications; Prashant Oberoi; Wasim Ahmed, Vice President, Sales, Meet Monk; Dr. Vishal Arora, Chief of Business Transformation and Operational Excellence, Artemis Hospital. May I request all of you to please come on the stage. Dr. Vishal Gandhi, please come on. All the speakers. Shyam Kumar from STPI. Thank you. Dr. Vishal Arora. Dr. Vishal. May I request those who are behind standing, please join. Please take your seats. Dr. Vishal Arora, please come. Dr. Vishal, over to you. All yours.
So a very good afternoon to each one of you. Thank you very much for being here today, and it's my proud privilege to sort of chair and moderate this session. Thank you, Shashidharanji, for inviting me to be a part of this wonderful event. I think the many events like digital healthcare I have seen, but the one which I'm attending today and I'm part of very deeply, I think it's very exceptional because the inaugural session gave a lot of thought leadership, which I personally was very much interested in taking up, and I was very, very happy that there's so much to take back from here. Also, I was able to reconnect with all my old friends, so that's another good opportunity. Coming back to, we've all heard about the healthcare challenges, and we all know that the healthcare it's such a complex topic. It's so important to each one of us, and we can relate to it so wonderfully, but still, we are contributing to whatever shape and form for our healthcare and for other healthcare in a very, 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 very minimal way, right? While the potential, each one of us sitting in this room, some of us are still having lunch, it's fine, but then, each one of us have a very crucial role and responsibility to fulfill the needs of 1.4 billion people in the country. How are we going to do this, right? This is not going to happen just because of the asset infrastructure. Hospitals are okay, but you know, the whole healthcare ecosystem in India is actually not a healthcare ecosystem. If you look at, I call it sick care system, you know, because there was hardly an angle of preventive health. But today, if you see, you know, there's a lot of preventive health fields which are getting involved, and we are seeing that the preventive health is actually growing much faster than the curative health, right? So I feel that you know, we are at a cusp where such leadership engagements are very, very crucial. And one of the aspects that is very, very crucial, because tertiary care, you know, where we all go to is actually hospitals, right? Whether they can be single specialty hospitals or a multi-specialty hospital, but at the end of the day, a lot of it is still delivered in hospital, because insurance, right? Today, insurance is actually the largest payer for the healthcare in this country. Now, if insurance has to pay for the healthcare, fortunate or unfortunate part of that is that you got to have in IPD, you got to be inpatient to be able to qualify for that. And that's an unfortunate part of it, but that's how it is, because there's a lot of fraud which actually can happen, if such loops are not closed. And I think this is one of the technology, again, we're not talking about AI, but I think blockchain is a very, very crucial aspect to achieve what we want to achieve from a fraud detection and mitigation plan. But coming to today's topic, and I think I've been tasked to sort of, lead all of you to this wonderful topic, which is smart hospital and AI. I think smart hospital and AI go hand in hand. They are so correlated. So today, you know, most of us may not recognize, but all our homes, right, have actually become smart, because most of us have a smart TV at home. Most of us have smart AC at home, right? So most of us have Amazons and those Alexas of the world, right? If you're having a smartphone, you are actually smart already. Now, if you are smart and the hospital is not smart, then there is a compatibility issue. So I think hospitals have actually become smart, because I think they have a huge responsibility to deliver healthcare very transparently. And one of the things that I think is very, very crucial, which we probably may not have understood earlier to the gravity that needs to be understood today, is medical legal issues. Now, patients were not aware about their rights, you know, neither the doctors were so worried about their medical legal cases, but the medical legal cases are increasing, right? How do we ensure and how do we create that kind of impact that, you know, genuine people do not suffer, right? It's only people who have committed medical errors, you know, because of whatever reason, they must be at least accountable, right? So coming to a smart hospital, I think we all know that, index of smart digitization in India, in any of the best to best hospitals that I have visited, personally, I would have visited 1,000 hospitals in my career of last 25 years. And I think in last 3 years, what I have seen, the best of the best hospitals do not have more than 40% of digital index that I can think of. And I would reflect to one of the hospitals that, you know, my mother was recently admitted to, and she was also admitted in 2022. So I was just doing a comparison between 2022 incidents to 2025. I felt their comparative account of digital index actually went up by almost 20%. Very, very encouraging, because any doctor I wanted to interact with, because when mother is in the ICU, you got to interact with multiple specialties, so neurology to gastro to, you know, dentistry. You know, I never had to carry a physical record of hers. Only physical record, what I got a little bit, only at the time of discharge. So I think that is the digitization, and that's the transformation which I could witness in one of the best hospitals, and I'm assuming that other hospitals are also gearing up, because at the end of the day, healthcare is an industry. Of course, it has its own challenges, but healthcare is an industry. Transparency is the key. There are regulations around it, but I feel that digital index in any hospital will certainly go up, because if they want to be competitive. competitive, right? So I think for any industry to be competitive, they've got to do something called digital transformation. And from that perspective, there are nuances around if you want to increase your digital index. You know, you got to think about cybersecurity, you got to think about, you know, networking, connectivity, you know, and then of course you got to think about your digital health infrastructure in terms of telemedicine, because that's where you acquire a patient, either for an OPD or IPD. And then of course you have to integrate technologies. Today, you know, when we talk of wellness, you know, can you think wellness without genomics profile, right? Having such technologies embedded in the whole ecosystem of a hospital really identifies you to give the right treatment. And we are moving to a world of precision medicine. I have no idea how many of you know about the concept of precision medicine. So those who know and heard about precision medicine can raise their hands. Okay, so guys, we are almost at the cusp of adoption of personalized medicines, and we are also almost there in digital therapeutics. So gone are those days where people will talk of pharma, medtech, and you know, other sectors. People will say that I am on a digital therapy, right? I have been recently, you know, meeting so many startups who are addressing problem of autism, right? And every startup that I meet on autism is addressing this problem through digital journey. You know, so that speaks about the importance of digitization. That speaks the importance of smartness, you know, in the whole value chain of healthcare, whether within the hospital or, you know, healthcare continuum, because a lot of it is not within the hospital, but it also needs to be managed in terms of healthcare continuum. And one of the speakers in the mornings talked about, you know, even the healthcare will be delivered at home, and it is being delivered, but the kind of, I would say, the usage of home healthcare is very limited. But in the future, we will see that how home healthcare will become an integral part of the overall healthcare value chain and management. Coming to, you know, leveraging AI and big data for public health, I think Dr. Sharma spoke so amazingly well. There was so much to learn from his experience that unless and until interoperability do not happen, we are not getting there, right? The whole perspective of taking these hard copy records, it will continue, right? So I'll again give you a very simple example. My mother was admitted at about 8 o'clock, and then doctor said that there needs to be an MRI. And then, you know, I suddenly remembered, because being an educated guy, I remembered that she had a TKR. Now they said that TKR happened, okay, we don't know whether she can go for an MRI. What was a TKR? What was the implant? And what was the style of implant? Now they wanted this information to be residing with me, which actually should not be, because I was admitted in Max, like my mother was admitted in Max. The TKR surgery actually happened even in the Max, but can you believe there was, even after like 48 hours, they did not have any clue whether she is actually having an implant which is MRI compatible or not. And everything was dependent upon me, so I had to look at the discharge summary which was submitted to the TPA, and in that there was a concept says deploy, this is the kind of, and then they did whatever they did, but everything was dependent upon me, and this is a state of the best hospital. And since I'm a healthcare management guy myself, so I understand how difficult it was to tell the doctors to go ahead and do MRI, and all the burden was on me, not on them. And then after they got to know that the TKR implant you know, is MRI compatible, then in the file, they made it very clear that TKR implantable, because she was required to go for CT scan, MRIs. Now these are the real life examples, nothing like I'm talking about 15 months back, I'm talking about last week, right? So much dependency, you know, on patient, right? I think unless and until you don't have smart hospital, you know, the whole dependency will lie on the patient. And how much patient remembers in the distress situation? Do you remember when you go on a distress situation, you know, you will remember everything. Even if you remember everything in a random access memory, you will not be able to use that data to drive the right information for the doctor. So I think, guys, it's really time that, you know, we must know what is a digital index of a hospital, you know, that we are taking our parents to or our family members to, because that really synchronizes the whole accountability of a healthcare ecosystem. And I think each one of us needs that accountable, because we are looking for equitable access to healthcare, and I think only can be achieved when we have a smart hospital. You know, fortunately, unfortunately, we all have to go there for whatever time frame we have to. So I think with that note, I have set the real context in terms of the problem statement, and I also feel there's a huge opportunity to integrate, smartness in the whole healthcare value chain. So I can only share with you that today, you know, in this panel, we couldn't have had better people than what we have actually got, and I'm sure we are all going to learn. So we will start with Dr. Vishal Arora. He comes from, a hospital called Artemis, and which I feel must be a smart hospital, and we will learn a lot about that from him. But at the same time, I think it's important to understand the context of a hospital to begin with. Then we will come down to another presentation, which is cardiology-related presentation. We are fortunate to have Dr. Yaduvanshi to talk about his experience of AI, robotics, and his insights. What is the current index of AI in his practice? And then, of course, robotics. I don't know how much robotics is being used, but I really feel very, very fortunate to be able to fund a startup in robotics, which is solving a problem of GI and many more specialities, because the robotics for each specialty is going to be a different ball game altogether. But it's good to see the Indian startups are doing that, and hopefully in 7 days we will be announcing funding of 5 crore to a robotic company, which is really solving a problem which actually needs to be solved. Then followed by that, we have Shyam. I'm very proud to associate with STPI, which is a thought leader and really executing startup agenda in almost all the sectors. And I think one of the sectors that they have sort of chosen to work in tandem with you, and that's what we saw in commitment by Arvindji in the morning, is the Medtech. And so Shyam represent as a CEO of STPI Medtech, which is very strategically got it in a hospital, because when you think of Medtech and you don't have the hospital understanding, I think it's very difficult to develop something which is really required for your end users. And can you think about developing a product not keeping your end consumers in mind? And that's why they are very, very strategically located in the Lucknow, one of the very, very pedigree hospital. I will let Shyam talk about that. And they are promoting a lot of medtech innovation, which is really the need of the hour, because when we talk about 1.4 billion people, now, we cannot, give them an access unless there is an affordability angle. And to bring that affordability angle, it's very important that we align to the Make in India campaign. And that is where such CEOs, Center of Entrepreneurship in Medtech, can play a pivotal role in promoting indigenization. And further, I think communication, the cloud management, and all that is so critical that we have two more wonderful panelists. That's, Prashant Oberoi, who represents Northern Communication. I'm really excited to learn more about it, because I thought communication is only communication as in terms of PR, but I think there's much more to communication, which I'll be very, very happy to learn during your presentation. And followed by that is Mr. Wasim Ahmed, who's the Vice President Sales, Meet Monk. Today, we are in the era where AI is taking over everything, and we will have our processes also being taken over by AI. They call it agentic AI, speech to text or whatever. I will let Wasim talk about it, but this is very, very exciting to see that how each of these panelists are going to bring a complementary view on overall healthcare management within the hospital. Outside the hospital, I'm sure that's a different topic, but within the hospital, we've got relevant stakeholders to talk. And I will let now invite Dr. Vishal Arora to take over the stage for about 5 to 7 minutes and begin his presentation. So Vishal, is that okay? Yeah? You want to do it from there, or you want to come here? Yeah, please. Thank you. Thank you, guys. I know we are between lunch. I'm sure some people are still having lunch, but I would request each one of you to give patient hearing to each one of them. They've done a wonderful job. So over to you, Dr. Vishal. Thank you.
Thank you, Dr. Vishal. From one Dr. Vishal to another Dr. Vishal. Good afternoon, everyone. I'm Dr. Vishal. I am the Head of Business Transformation for Artemis Group of Hospitals. And happy to be and honored to be standing here in front of you and speaking on the topic, smart hospitals. So I have a small presentation, it's already there. So I have a small presentation to be put across where I would walk you through the challenges we guys have in the hospital, how technology can shape us, overcome those challenges, and how we can make our hospitals more smart, more efficient, and more throughput can be generated, resulting in efficiencies, which eventually would lead to the three things for what hospitals are: a happy patient, a happy environment, and good clinical outcomes and happy staff. So these are the levers basically around which we run around. And let us first understand the challenges, and then I'll walk you through certain initiatives which have been taken in and out across the organizations in the terms of leveraging technology and how they have been beneficial for the hospitals. Yeah. So when we talk about the challenges, so first and foremost challenge all of us in India would agree to is the workforce challenge, right? So we are short on manpower, given we are 1.4 billion plus. We have a dearth of healthcare resources across, especially the manforce, right? So how do we best optimize our processes that the load on my workforce is not that, and the study says that 30 to 40% of the time of the nurses go into non-value add activities. How can we leverage our processes that is reduced and they can treat more efficiently, put their focus on more efficient clinical outcomes, right? So that's something we need to understand. Then eventually there are too many laborious tasks which we are doing in the organization day in and day out, leading to a maybe overburdened employee, leading to high attrition rates. So how we can work around that? So that's an area I can touch upon. Then process inefficiencies. Still in an era where everything in our houses is smart, as Dr. Vishal said, and we're moving towards smart hospitals. Still in hospitals, most of the things are still not automated, right? My processes are still what they were 10 years back. What can we do to automate those processes? Decision making. Decision making is delayed because the data is not real time. How can we actually leverage data that can help us make a real time decision, that can help us take a faster decision? Then moving to clinical outcomes. So how can technology be leveraged? I'm sure there are doctors on the panelists, they'll add to it. How can technology be leveraged to help in a real-time clinical decision support system? So CDDS, what we call, right? So that can help us predict and do more precise treatment, and at any critical juncture or any crucial juncture can help save us time and save a life. That's what all of us want to do within the heart, right? Save a life. And of course, why all this? Because of the technological gaps, right? So there is low digital penetration. There is a lot of resistance, people from amongst all of us, right? So that's another thing. Guidelines are not proper. Guidelines have not been laid down. Data privacy issue. That's of course one thing which was highlighted in the morning also. That data privacy. Hospitals are not ready to share data. They feel that that is what they own. That is their custody. But eventually, till the time we are not able to devise a methodology where all the hospitals are ready to share data and a data interoperability system across the country exists, right? AI will just be a talk, will not be able to deliver, right? So these are the certain initiatives, certain areas which we'll be touching upon. How AI can address India's healthcare challenges? So I've already touched upon this. So enhanced clinical decision making. So early diagnosis, we save life, precise treatment, boost efficiencies, digital. I'll tell you, as a chief of business transformation, my team takes around maybe 20, 25 initiatives every month. And trust me, more than 60, 70%, every 2 in 3 initiatives are digital based or data based, right? And none of the initiatives is without a data backing, right? So that's the crucial juncture we are in. Expanding access and equity. So a big country, limited resources, high burden on hospitals, very remote locations. How can we reach out to those locations? So that's where technology again comes and plays a role. So telemedicine, as we have heard in the morning. So telemedicine is the talk which needs to be developed and rendered as soon as possible so that it reaches out to the masses, to the area where people cannot. Then preventive care, wearables is again a topic which is something all of us would be knowing, right? So I will just touch upon 2 case studies. These are real-time case studies of Indian hospitals. So reducing wait time. So by leveraging, so there is a stat which again says, a research which says that 20% of the patients don't prefer to go to the hospitals where wait times are higher. And we spend dollars in getting patients footfalls to our hospitals, right? And if that is not leveraged, the patient not coming back, that's the last thing as a hospital business guy I would love to have. So what can be done around that? So that's a case study which was done in one of the leading hospitals in the country. So long wait times, they were able to triage using AI, predict queue management systems, predictive analytics was put in, which counter, which time will have how much queue, which specialty, which area of the hospital. And they were able to reduce 25% wait time and NPS went up by 15%. Again, a case study, automation for admin excellence. Again, a leading chain of hospitals in India. Without naming the hospitals, these are hospitals on the likes of Apollo's, NH, or Max's. Time-consuming billing and onboarding processes, they put in RPA for claim automation, they put in automating onboarding process. Just imagine if I am about to onboard a hospital and everything is done digitally, I'm not required to sit in a room, sign hundreds of papers, right, before I am onboarded. So that's the happy moment, the nirvana moment as an employee I would look up to. And saves on time, energy for everyone. And the records are not in a hard copy format where a file will be maintained in one of the HR admin blocks. It is completely digitized across the hospital. So that's the era we are talking about. I will just touch on the previous slide, and maybe around this slide is most of my conversation going to be for next 3-4 minutes. If I take a 360 view of the hospital, so this is how a hospital would look like. First, a hospital operations area. Second, patient flow and wait times. Third would be supply chain automation, clinical enhancement, data analytics and insights, and expanding access and reach. So that's, if I'm able to touch upon these 6 levers and leverage technology in these 6 levers, I'm through. And that's where we want to leverage technology. Certain examples where AI has been able to deliver in these areas. So just imagine, I'll give you a hypothetical scenario, dynamic rostering system. So I see most of the sisters sitting here. If we are, right now, most of the hospitals have a static system of rostering. If there are 20 beds on a hospital, I put in 1:5 nursing. I will place 4 nurses there. That's how we roster. Morning, I'll get to know that on that floor only 12 patients are there, so 1 nurse can be freed out. Can this happen more precisely? Can I tag them? Can I predict my bed requirement for the next particular day and have a dynamic rostering system where my nursing, every morning before the shift, my nurse would get a WhatsApp, you are rostered on this particular floor today. Can we save overtimes on that? What eventually we would do? If we have rostered 3, right, then I will, and there were 17 patients while the sisters were leaving, I would request one of the sisters, please do a overtime for me. I'll ask one of the ward boys, please do a overtime for me. Can we predict that? And so in both the cases, overtimes also, which is again, I'm loading my employees, and in the case of shortfall also, where it is a excess spent on the manpower, right? Can predictive analytics be done? Of course, the answer is yes, it can be done. How precisely, that's we want to understand. HR process automation, I already spoke upon, onboarding process. Billing and claim. Half of the times, right, so the TPA, there is a guy who would be running across all the TPAs, how much payment has come in, how the payment reco is happening. It is a bunch payment. They are not able to figure out only the payment has come against which patient, how much payment has come against which patient. Can I automate that? Putting now CGHS and ESI patients, we need to upload bundles of documents, right, on their website to get in the approvals and the statutory requirements. People around this area won't know that. Can a tool be created where the relevant, if I am a 100% EMR adopted hospital, a tool be created where a discharge summary is pulled out automatically, then the patient stay things are pulled out, the reports are pulled out, the discharge summary is pulled out, the doctor notes are pulled out, they are annexed in a manner which is required by the CGHS, and the entire thing goes at a click of a button. So can that be done, right? Yes, it can be done. But right now, average file upload time from scanning to collating and to putting it is nothing less than 12 to 13 minutes for an employee who does dedicated this job, which by technological adoption can be done in less than 30 seconds. Moving on to the next subsection is patient flow and wait time. So queue management. This is again, whatever we do, right? Discharge stat is always a problem for everyone. Hospitals have done 6 sigma around discharges, right? That's still a problem, and that will remain a problem. Can I automate that thing also? Yes, of course, it can be done. If it is done in an efficient manner, if I can actually start my thing from the processes can be that synced up that back-to-back things happen, the pharmacy returns happen, the discharge pharmacy is there, the auto-discharge in pharmacy indentation happens, the billing is done, and it is sent to the TPA seamlessly. So yes, the mechanisms can be devised and eventually a happy patient. 70% of the negative feedbacks come for the time of discharge. The patient throughout the journey is very happy, but at the time of discharge, spending 6 hours in the hospital just waiting to be freed. That's where the entire thing gets tossed over. Real-time feedback system, again an area. So most of us, we do a retrospective feedback system. We get a hard copy feedback filled up or a software feedback at the time of patient discharge, and when it comes back to us, right, we analyze and call up the patients. We at Artemis have put up QRs across the hospital. within 30 minutes, the patient is made happy, the complaint is resolved. So that comes to, there is a team working around it, that comes as a complaint, you just scan a QR, your things are satisfied at your bedside. So eventually you end up as a happy customer. Many such areas can be clubbed up on this thing. Supply chain. Again, an redundant area and not a very strengthful area for most of the administrators. So this area also, we are completely remote. How we function today in a simple anarchical manner where my reorder levels have been defined, my buffer stocks have been defined, does not factor in the dynamicity, the seasonal variations, right? So as many medicos and most of them from the healthcare fraternity, my June, July months would be high on urology. My November, December months would be high on cardiac and low on orthopedics. My May, June, July is again high on internal medicine. The dengue season kicks in Delhi NCR. But my stocking is static. If I keep 15 vials of a particular drugs, that will be 15 vials across the year. My buffer stock has not been defined as per the thing. There is a lead time. So internally, from raising a PO to PO going to a vendor, we will waste 2 minutes, which is just a 30-second job. Can I automate that? The answer is yes. That's the level we have to leverage technology and automate our stuff. Dynamic supply chain process not only saves me reducing the inventory levels, but also saves me on time, effort, money. And these operational efficiencies, most of the topics we're talking about, would lead into operational efficiencies and some cost savings for the hospital, which eventually gets passed on to the patient. Right now, we all completely say that the cost in healthcare is going up, especially in India, it is going up day by day. We are 1/6 of what the global cost is, but still, given the earnings in India, per capita in India, it is still significant. Technology is the answer to it, where technology can come as a support and help us reduce those costs. Clinical enhancements I've already talking about, and I will leave that to Dr. Amitabh to answer that in the next session. Data analytics and insights. Trust me, guys, we at Artemis have developed a very robust mechanism of data analytics where any decision taken in the hospital is data backed. If I'm required to enhance one seat at my billing counter, we will analyze the data. We will understand how, which hour of the day it is high, right? So most of the times we are not required to increase the manpower. It is just the adjustment of the manpower. And trust me, once we have those insights, it helps us reduce costs rather than put up costs. I'm moving fast just in the interest of time because I have a heads up that the time is about to be over. So expanding access and reach, of course, telemedicine, given the country strata, the focus, the geography, the limited manpower, we have to move on to telemedicine. Then only healthcare will be accessible to everyone in the country. Key barriers. So key barriers, one of the key barriers is, of course, the regulatory framework, what we have spoken about. Then my workflow disruption. So what all of us fear about largely is, so that's where the resistance to change comes in, that the workflow will be disturbed. And I say that there's a mitigation measure to it. Let's start by running pilots. Let's understand. So when I just spoke about this queue management system, the token management system, the feedback one, which we have put across in the hospitals. When I was about to pilot this thing, all the users, 70 plus users came to me that this will be a system where complaints will be put up in the thing. We are very scared. Complaints will go up. But today, after 3-4 months of implementation, everyone is happy. Because eventually the complaints are solved bedsides and it is more of a resolution thing rather than a complaint thing. And the patient is ending up happy. They are also seeing that patients are getting up happy. The complaints are going down. Because we are able to understand what the customer is looking for. And that thing, real time, is getting corrected. Costing, of course, is a major thing. So costing, with all the players looping in and more things coming up, this is about to go down. And data privacy. So that's the biggest thing. Why deploying AI in healthcare? What will it lead to? I've already said a happy patient, a happy customer, and good clinical outcomes, precise and good clinical outcomes. That's what the healthcare is meant to. So I will end on a note that healthcare, the digital and the AI is to augment us. It is not to overshadow any of the manpowers or workforce work. It is to augment us. And we should happily acknowledge it. And the more we leverage it, the more efficient the healthcare system will become. Thank you, everyone. Thank you so much. Happy to answer if there are any questions, or maybe we can take at the end of the session. So.
Thank you, Dr. Arora. So I think we will invite all the questions once all the panelists are done. Amazing, thank you. So I turn to Dr. Yaduvanshi. Dr. Yaduvanshi, over to you. We'll have 7 minutes and 3 minutes for your interactions.
So, good afternoon, everybody, and thank you, Shashiji and Bharat Exhibitions for inviting me for the talk. So, Dr. Vishal had already mentioned the use of AI in hospital management and how AI can actually improve our workflows and can augment the clinicians as well as the management's processes. However, I'll be going a little beyond that, and I'll be talking about how artificial intelligence can do things that is probably humanly not possible as of now. So I'll be talking about artificial intelligence as related to what has been done in the field of cardiovascular medicine and where we are today. So we are still in the nascent phase. So this is a painting that, can anybody guess who is the painter of this painting? Well, I can give you a hint. How many fingers are there in the physician's hand? So obviously this is an AI generated. So you have AIs which can generate all kinds of things, and then this Ghibli phenomena we all are aware of. So how we can use AI in the natural history of disease? So how does a disease progress? So we have a situation where a person is feeling great, and then like a bolt of lightning, you have signs and symptoms, and you undergo a diagnostic testing, and you detect a disease. But unfortunately, many a times, the first event which leads to this detection may be life-threatening or life-changing. So it could be a stroke, it could be a heart attack, or it could even be sudden death. So, but this process did not happen when we had those symptoms. This is a process that started way back, years back, and it developed over years, and we got to know about it only when that symptoms develop or we did some testing. So waiting for signs and symptoms to develop, we have been doing this for the last 2000 years. Can we do something better? So there are few key areas where these research is going on, and low ejection fraction is one of the important aspects. So why is it important? Around 2% of global population suffers from asymptomatic left ventricular dysfunction. So why is it important? So you will realize, you see in WhatsApp, you see in social media, people just falling down, young people dancing and falling down, people having sudden cardiac deaths. So this sudden cardiac deaths is probably because of arrhythmia. So there is a differentiation between a heart attack and a sudden cardiac death. Heart attack is when you get blockages in the arteries, you get chest pain, you can reach to the hospital and get treatment. Sudden cardiac death is when you have an arrhythmic event, and arrhythmic events usually are fatal within few minutes. So unless you get a treatment, you will probably not survive. So prevention is what is required. And people who have LV dysfunction, chances of sudden cardiac deaths are very high. And you can imagine 2% of global population have low ejection fraction. And it is not possible. So how you detect low ejection fraction? That is the pumping capacity of the heart. You detect it by doing echo. But obviously, you cannot screen the whole population to detect this 2% of patients. So there has to be some way where it can be detected. So expensive tests are not the solution for population. And you can imagine that all these ECG that you get, it is the sum total of all the muscles in the heart giving out their electrical output. So it is a composite thing. So you get, when you have a heart attack, you get obvious ECG changes. But even a single cell or a small amount of cell, if they get damaged, there would be some ECG changes, but that will not be possible to be detected by a human eye. So Mayo Clinic did this digital workup. They developed a model where they had an ECG and echo paired. So what they do is they fed ECG of the patient, and they gave them that this patient has low ejection fraction or this patient has normal ejection fraction. And they developed this training module where they did not tell anything about anything else. They just did these two things. And then they were able to validate this model, and they were able to achieve what is called as area under curve of around 0.93. And this is, in fact, one is perfect, so 0.93 is almost perfect, because When you talk about other tests that we normally do, like pap smear or mammograms, their area under curve is only 0.7, 0.85, but we know pap smears and mammograms are the standard screening tools that we are using. But if you use this AI ECG, the predictive value is in fact better. And then there were concerns, there were few patients who were so-called false positive. So there were the AI told that this patient would have low ejection fraction, but when you do an echo, you find the ejection fraction is normal. But when they followed this patient, they realized that the patients who are labeled as to possibly have low ejection fraction, within the next 6 years, 5 times more likely to develop heart failure. So basically, it was predicting the disease before it manifested on the echo. And high risk for these patients who are so-called false positive, they can then be subsequently sent for further follow-ups. And then they thought whether adding the information of gender and age of the patient, can it further improve the predictive value of this AI? And they realized that it did not help. So this was quite surprising for the clinicians who were there. But the technologists that they were not surprised, because they thought that the AI is able to interpret the ECGs and get all the information of the sex as well as the age of the patient, looking at the ECG only. And this is what they actually found out, that when you just give the ECG to the AI, 0.97% AUC. So that means it was almost certain to detect the sex of the patient just by looking at the ECG. In fact, that might be more accurate than we looking at a person, and sometimes we are also not able to define whether it is a male or a female. So this is more sensitive. Secondly, the age estimation was also important. And as you can see, the correlation is quite good. There are certain areas, but there is a person who is probably 40 years of age, but physiologically the age may be, because he may not be very healthy. So physiologically the age may be 60. Similarly, there can be a 80-year-old person, but physiologically the age may be 70. So that again adds to the value of this. So this is another case. So this patient had these ECGs, and this was the ECG age. As you can see, it's progressing. Then something happened here. Can anybody guess what happened here? Well, some people thought that maybe he started exercising. Some people thought that maybe he got divorced. Some people thought maybe he got married. But something happened and his physiological age came down. But what exactly happened is, this patient had a heart transplant. So with the heart transplant, you were able to, the ECG obviously got better, and the algorithm was able to tell the age of the transplanted heart rather than the age of the patient. Similarly, another patient who had a ECG age of 40 years, her actual age was 35, so age gap of around 6 years. This patient, after 6 months, the age became less, 10 kg weight loss. 10 kg weight loss, the age gap became 0, and so it suggests that weight loss associated with loss of physiological or biological age. So it is like a biofeedback. So again, ECG was able to tell us whether the person is doing good or bad. So they have correlated with all these factors of aging, and they found that deep learning derived cardiovascular age is associated with cellular and molecular markers of senescence. So again, just by looking at the ECG, you can derive so many factors. Another patient, a 35-year-old asymptomatic male who presented after his sister had died suddenly. And when you see the ECG, I'm sure there are few clinicians among us, ECG seems to be normal. This would have been passed as normal ECG by 99% of us clinicians. And in fact, the standard ECG algorithm also labeled it as normal. But when it was run through the AI, it was detected to have a 76% probability of having a low ejection fraction. And when the echogram of this patient was done, ejection fraction was only 18%. And this patient actually had familial dilated cardiomyopathy. So the sister died because of LV dysfunction. The sister had sudden cardiac death before LV dysfunction. if this ECG was done on the sister, or if this ECG was done on siblings, we would have been able to prevent that death. And in this patient, the death is prevented by putting an ICD. So another patient, this patient had positive for low ejection fraction. The echo was done. It was labeled as false positive because the ejection fraction was normal, 50%. However, 5 years later, at the age of 33, his ejection fraction dropped to 31%. So this is one of the examples where something that has been found to be false positive on the AI, when you follow this patient up, you will find that the ejection fraction decreases. So it identifies a group of patients who may have a normal ejection fraction at present, but would in future develop. So it's like a AI disease preventer. So you can predict and preclude the disease. So this was one center. Then they have been done, the similar kind of algorithms have been done in other centers also. And multi-central, you can see the area under curve is quite good in all these centers. And they also found the similar pattern where false positive, when they followed up, they would found that the ejection fraction did decrease. So this again is reproducible. So can our clinical practice be modified? So if you get an ECG and you get an AI algorithm that is attached to it, and a clinician, although it looks as a normal ECG, finds that the AI is positive, this patient can then be referred for echocardiogram, and subsequently it's like an evidence-based therapy depending on what is the echo report. So this was the trial that was done. I'll not go into details. They found that even general physicians, they were able to detect low ejection fraction just on the basis of the AI. Similarly, they found that even with not just the 12-lead ECG, if they use just the Apple Watch, the same algorithm can be applied, retaught and applied to the Apple Watch ECGs, and you can detect patients who are at high risk of low ejection fraction or who actually have low ejection fraction. So again, this can be then propagated across to all consumers. Another important aspect is hypertrophic cardiomyopathy, again a very leading cause of sudden cardiac death. And these patients, again in Mayo Clinic, they developed this, this algorithm. And again, the area under the curve was 0.97, it's almost perfect. And this was the example. So this was a 25-year-old woman who had HCM, hypertrophic cardiomyopathy. He was referred for surgery. But if you see the ECG, it looks almost normal except for a little bit of T-wave changes, because this is not the typical ECG that you see in a hypertrophic cardiomyopathy patients. But when the AI algorithm was applied to it, 72% possibility of hypertrophic cardiomyopathy. Then the patient underwent surgery. After myomectomy, if you see the ECG, it looks even more worse. So if I am a clinician, I would think that this ECG is not abnormal. But when you do the algorithm, AI calculated a 2.5% probability of HCM. So that means once you correct the HCM, although the ECG looks worse to a clinician, the AI is able to detect that this patient no longer have HCM. Then another important, I'll just take a couple of minutes. Atrial fibrillation, we all know symptomatic AF is just the tip of the iceberg. This is an example of a 92-year-old female who presented with stroke. All evaluation of her stroke protocols were normal. ECG was normal. So in this patient, what would you recommend? We can recommend observe aspirin or anticoagulant. So now, when you talk about stroke, there are two independent mechanisms of stroke. One is an LAA independent mechanism. That means you can have atherosclerosis in the intracranial vessels or the arch vessels, and that causes a stroke. So the treatment for that is aspirin or antiplatelets. However, you can have stroke because of left atrial appendage clot, which is seen in atrial fibrillation, and the treatment for that is different. It is warfarin. And you may say, okay, why not start warfarin in all the patients of stroke? But you will realize that treatment depends on whether the patient has AF or not. If AF is present, antiplatelet helps. However, if you give anticoagulants helps. If you give anticoagulants to patients who do not have AF, the outcomes are worse. So you have to strive to detect AF. So the way is through costly things like a loop recorder, extended Holter. But is there a way to detect possibility of AF on a normal ECG, just 2-3 minutes? So they developed this algorithm where a normal ECG, you are able to detect the possibility of AF. So the AI converts this 10 seconds of ECG, which is a normal sinus ECG, to possibility of detecting AF. And in this patient was on normal sinus rhythm, also on Holter normal sinus rhythm. She was treated with aspirin. 5 years later, had another stroke. Thrombus was seen in the LA, confirmed to have an ECG on a subsequent ECG. And what if ECG was detected sooner? So when they retrospectively analyzed her ECGs, this was the time of her first stroke. And even 10 years before, these were the ECGs that were available to Mayo Clinic. You can see that even 10 years before, the AI algorithm was saying that this patient probably has AF or has intermittent AF. And if at this point of time, if she was started on anticoagulants, we could have prevented the first stroke and definitely the second stroke. So what is the inside the AI, what it sees, nobody really knows. However, when you talk about this explainable AI, the same low ejection fraction, you can see that there's something in the V3 that the AI is checking. What it is checking, it would not be possible to determine. So can we treat on the basis of AI? Not yet, but these patients can still be followed up more diligently and subsequent treatment can done. So again, they are AIs that are developed for AS. Then there are AI that are developed for early detection of cardiac amyloidosis, again a very serious condition. There are AI that is developed for development of cirrhosis. So you do an ECG and you can see whether the patient has possibility of developing cirrhosis. So again, there are multiple things that are being done, and there are certain AIs that have been developed which translate to diseases which have new effective treatment. So we can, if we are able to detect disease before it actually manifests in symptoms or signs or the standard protocols, investigative protocols, we may be able to save so many patients. So with that, I thank you for your attention.
Thank you, Dr. Yurvanshi, for such an insightful talk. I will let now Sham take over, for about 10 minutes.
So, very good afternoon to all of you. Myself, Shyam Kumar. I'm the Chief Operating Officer at STPI Medtech Center of Excellence, which is located at SGPGI, Lucknow. So, thank you, organizers, for inviting me here. And thank you, Vishalji, for setting up the context of this session. So, this panel is very unique, actually, because one gentleman from the hospital, one from the startup, I'm from the incubator, one doctor is here. So you'll get actually the complete package, how the AI is actually helping us in smart hospitals or many other ways with respect to healthcare. So I divided my presentation in two parts. One is just something on AI, and down the line, what exactly we are doing with respect to our incubator. Okay, starting with this, some introduction and some key figures that I received from internet. Like the global AI market is projected to grow from USD 19.7 billion in 2023 to USD 613 billion by 2034. Okay, with a CAGR of 36.83. These are the figures actually, but this actually indicates that the reported estimate, what is the role of AI in coming future with respect to healthcare. Since morning, Dr. R.S. Sharma was indicating that after fintech, healthcare is one area where lots of problems are there. And where there is a problem, solution is always been there. So with these words, I continue. So where the innovation is actually happening in this domain, healthcare innovation framework, which is a 3D printing, the mobile health, the artificial intelligence that we keep talking about, the big data analytics, then IoT of things, robotics, then wearable devices, etc. So what are the key emerging areas for the AI? So medical imaging and diagnostic is one of the key area. AI algorithm can analyze the medical images and try to like X-rays, MRIs, and give the faster and often more accurately than humans, okay? Predictive analytics and risk assessment, drug discovery and development, remote monitoring and wearable devices, mental health solutions and behavioral analytics, and hospital workflow and operational efficiency. So these, I just curtailed a few 6 areas where AI can help us in a broader way. What are the key challenges? We are talking about how the AI is beneficial to us, but what are the key challenges that come up with the AI? Is the availability of data. Since the morning it's highlighted that without data is nothing much. You can develop an algorithm, but you don't have a sufficient amount of data, how it actually works out. So this is one of the key areas we have to thought of. The quality of data is not like that somebody has to take a form and go to the market and collect some data. It's a healthcare data which is very precise with respect to the patients. Data privacy and security is also always been a concern. The regulatory and ethical concerns has also been there. Interpretation and trust. Cost and implementation of AI with respect to healthcare. Lack of standardization. Clinical validation. Change management and training. And over-reliance on AI. So these are the key points, the key challenges that AI comes up with. So are our ecosystem is ready? Are we talking about too much about AI, we can do this, do that? Definitely, it gradually help us. But currently, the practical situation is a little different, what we are talking about. So we have to sincerely thought on this. We have to keep gradually working on this. All the stakeholders like hospitals, startups, companies who are working on this, they have to open to sharing the data, because until unless there is a problem, startup is there for solution, and until unless you don't provide the data, it's actually not worth. Now come to this Medtech Center. The center was established in 2021 in STPI Lucknow, since we are working a bit, in the honorable presence of Shri Rajiv Chandrasekhanji. And the center was set up with the help of MIT, UP government, and AMTZ, and the Association of Medical Devices, IMED. So these are the key partners to us. Academic side, we have IITs, Kanpur, IIT Lucknow, IIT Prayagraj. Knowledge partner, we have AMTZ, which is located in Visakhapatnam. Industry association, we have IMED, TV Inland, and from the investment side, we have Wilgrow, 3Line, IPV, and BioRx. So these are the key pillars, actually, the brain behind to establishment of the center. Dr. Saurabh Srivastava from IAN, Dr. Jitendra Sharma from IMED, Dr. R.K. Dhima sir from Director SDPGI, P. Siva Kumar sir from IMED, and Dr. Sunil Mugaji, Dr. Arun Mohan Shari, and Dr. somebody from IM Lucknow. So these are the key brains, actually help us to establishment of the center. See, these are the key mentors that helps our startups to, on every level, from ideation to POC to prototype, whatever the support is required, the clinical guidance, mentoring, business aspect, funding. So these are the people who are actually helping us, hand-holding the startups, and keep helping to grow with. So what is offering? Somebody is come to us, he said, I have this idea. We want to start this idea. So these are the key offerings that we are providing is a 24/7 plug-and-play stations, research and prototyping facilities, compliances and IPR assistance, IoT and Medilabs, clinical and business mentoring, and funding and industry connects. So a couple of glimpses of our center, like co-working space, Medi and IoT labs, and this is a beautiful infrastructure that we have. Now, the labs that I was talking about, that we have two labs, which is IoT and MediLab. So all the startups coming to ideation, to proof of concept, to the prototyping, they are actually using our labs to creating their prototypes. 3D printer is there, so people are keep replicating their ideas and testing it. IoT labs, we have oscilloscope and multimeters. So IoT-based things can be tested easily. So these are a couple of high-impact startups. One is Dectrocell, Arficus, Palmocare, Manodem is in the back, MedBlue. So these are the couple of snapshot stories, what exactly these startups are doing. Like somebody is working on pulmonary diseases, somebody is working on neonates, somebody on mental health issues, addressing mental health issues, somebody also on spectrometer, etc. So these are a couple of event glimpses that we have. We participated in the past. Last year, we did a program with Stanford. So these are a couple of awareness sessions. Now, this is a very interesting part that I would like to communicate to all of you, is that recently we have launched a program called Open Challenge Program 6.0, in which I encourage startups, anybody who's having idea, please apply to this program. You can, detail can be explored on the Sayuj or the Medtech website, or by scanning the QR, right? So these are a couple of broad problem statements that we have, like early disease diagnostics, point-of-care devices, next-generation technology, deep tech, IoT-based, peri and post-operative solutions, or any other product which is aligned with our focus area. So anybody who's having something working on it, they can apply to this program. So these are timelines. We are already running behind it, and the challenge is closing on 20th of this April, hardly few days. So you can, if you have any wonderful idea, please apply to this. So the program was launched on March 20th in Delhi. You please take this snap of this QR, apply it down the line. So this is all I want to say to you. Thank you so much.
Thank you, Shyam, for covering it much before time. And I can only share, since I'm also associated with this institute as a mentor, startup STPI is actually a startup. They may be 33 years old organization, but I can tell you that some of us representing private companies do not move the speed at which STPI moves. And I would really encourage, if you are there as an innovator, if you are doing something in healthcare and if you're doing something in Medtech, and if you are not knowing about STPI and Medtech, I think you're missing something. So please do reach out to Shyam to take this opportunity forward. Thank you, Shyam, for such a wonderful presentation. Now, let me invite Prashant. Prashant, I think the pillar of any infrastructure, technology infrastructure is cloud management and many more aspects. So we'd love to hear from you. Thank you.
Good afternoon. I'm Prashant from Northern Communication. And I am probably one of the guys. There is obviously another panelist, which is probably we would be deviating. We are no so-called medical practitioners or something, or directly related from hospitals. So we would be talking something different, which these people have talked. However, but I would like to take few points, because being a product company, and I would be talking more of product, and this presentation will be full of product, which I don't want to bore you with the whole of technology, just to give you the briefs. So those products have been put in the presentation, but I would like to take few things from my previous presenters. Like Shyam gave us the numbers about emergence of AI and the CAGR, what we are building. And then Dr. Arora in one of his slides said, one of the challenges for any hospital is that these new technologies which are coming up, can they cope up with the existing infrastructure what they have? That is one of the challenge which he has put. Then there are the challenges of latency, because these AI applications are very data intensive. The latency required, the uptime, the SLAs. And one more point which Dr. Arora put in his presentation was overall resistance to change. Yes, that's one big challenge. So I would probably be putting more focus on when he said the new technologies running on current infra and the resistance to change, and with the related to our products, and obviously doing the job for the company, I have to talk about the products as well. So, but yes, one challenge for sure, which we have seen over, not now for, with AI, it is becoming even more challenging, but it has been always there, that the technologies keep changing. For every 3 years, 5 years, we see some kind of an intervention coming, and then the current infra is not able to cope up with it. And obviously, there are two parts to the infra when we are talking, active infra and the so-called passive infra, though I hate to call it a passive infra. But unfortunately, that's what it is known as in our industry. And it is very easy to replace the active infra, like your switches, routers, your cybersecurity components, and all those things. But unfortunately, it's not easy to replace the passive infra because of the downtime required to replace it and the effort which goes in to replace it. So anyway, I would move on with the slides with these words. We are a UK headquartered company and presently across 42 countries in the world. Our journey started with 98, and then we moved towards Middle East and towards various geographies and various certifications and other things which we secured. The total 40 countries. These are the three primary product ranges which we cover, which is the cabling system, the public address, and the surveillance system. And that's where I was talking about, there is an active part and a passive part. Unfortunately, the cabling system, known as passive, which I hate to call it, unfortunately, but that's the pillar, because when you do a particular infra, you can upgrade all the active technologies every 3 years, 5 years, because downtime is much lesser, but literally this passive infra goes inside your bricks and mortars also. It is running in your, probably the raceways and other things, and to change it, it's a horrendous task. And this typically infra is put for 20 years in place, 25 years in place. So that's where my always the word of caution is, we should, specifically on this infra, which we cannot replace, we should have that futuristic vision on this particular thing, so that whatever is Dr. Arora's one point, that whether the new technologies can run on current infra, we should not face those challenges. Certain things, obviously, as I said, I would not go into the overall thing, but as the tagline of the event is, future of healthcare is digital, which means we are moving towards everything which is related directly, indirectly, we are moving towards digital. Be it, we have seen in the past the monetary thefts or even the child thefts in the hospitals. Today there are AI interventions based on surveillance system, where we can track those people moving inside anywhere in the hospitals. It can pick up we can have those alarms set up for various activities which are suspicious, and thereby reducing those thefts or challenges. Typically we are talking about right from entering, where it can be a manless entry, and even the parking system can be automized, the perimeter can be secured, the in-vehicle surveillance, the body-worn cameras, because we have seen this with the administrative staff as another challenge which he was talking, there could be very good patient care being taken, but unfortunately, because of certain administrative challenges, the discharge process takes particular time, and we have seen there are heated exchanges between the staff and the patient, and then we really don't know who was at fault. So there could be these kind of interventions of body-worn cameras coming into picture, where we know everything is recorded. Similarly, the comprehensive coverage in terms of, as I said, the one person's whole movement can be tracked across the whole hospital, and we know whether he is entering a zone which he is allowed to enter or not. So that's about the surveillance part. Cabling solution, which I was talking to you about, the passive infra, this is the backbone for any application to run. and this particular infra goes into the particular, any building. Obviously, we are talking about here hospitals, so that's why I'm using the word hospital. But in any building for that matter, this cannot be replaced less than 15, 20 years. So this has to be really futuristic, and it should have that much headroom available that tomorrow, any new intervention in technology which is coming, which we want to adopt, our basic infra is able to cater to it. Otherwise, there is a huge time of kind of downtime which is required to replace this particular infra. We should be very, very cautious about it. I would not go into the details of the products, but as you can see from the slides, we have the whole range of products to cater to various solutions. Normal cabling for a smaller healthcare facility to intelligent cabling. When I say intelligent cabling, this has moved towards the SNMP, where we can have alerts in terms of if any particular port is down, we know which port, where it is patched, which rack it is, thereby increasing the SLAs and reducing the downtimes, and obviously giving that much, because we have seen that particular thing where especially at the discharge times, again, I'm giving that example because I have faced it some time back personally, where you are waiting and somebody says, no, I am not able to access the server, unfortunately, for whatever reason it may be. So we have to wait. Those kind of things can be reduced with this kind of intelligent solution where we know is this particular port is not working and why it is not working, and is it a connectivity issue within probably few seconds rather than spending few minutes or maybe couple of hours onto it. Again, the accessories related to it, I would not get into that details. This is a software GUI features which are there, and the kind of dashboards which are there where you know what exactly which I was talking, which port, which rack, which particular thing is not working. And the third set of product which I was talking about is the PS solution, the public address solution, where again the interface between the patient and the staff comes. And obviously there is one panelist where we have voice to text to voice, and similarly multilingual things which are going to come into my next speaker. But these are the base, again, the infrastructure projects which will be the base for those, and based on this the interaction can be much easier, clarity of sound, clarity of information, even the evacuation system which forms one large safety part of any large building, including hospitals. The telemedicine and conference system we have been talking, again, the core which goes into is obviously the video conferencing overall system, the fire announcement systems, fire evacuation systems, the emergency SOS. These are the nurse calling stations which most of the hospitals are already using. These are certain international certifications which we have for our products from various geographies, and more or less we are catering to all the regions, all the global regions. However, one question comes is probably there are many people like us, so why not? Obviously, the whole range of solution which we have, which makes us one window solution, the futuristic, and as we typically call, I have not covered in this slide, but we would like to call ourselves as global. The global products with the local touch, with the local people available, and with the local solutions. So that's why, probably why Norden. Thank you very much.
Thank you, Prasant. I think there is a company called Global HealthCare, which is actually producing a lot of social impact in Northeast. And of course, you know, we cannot get smarter without your help. So now segue to introducing Wasim. And one of the things that I've also looked at and which I spoke about was medical legal issues. And I think medical errors do happen. Now, how do we utilize the power of AI to reduce medical error is a very, very important aspect. And we have a very able speaker, Wasim, to talk about it. Over to you, Wasim. Thank you very much.
Please bear with me for 1 minute. Ladies and gentlemen,
Vadarva and gentlemen,
my name is Wasim Ahmed. I'm excited to stand in front of the representatives of well-known healthcare organizations of India. I thank Mr. Sashidharan and his team for inviting me here.
my name is Wasim Ahmed. I am excited to stand in front of the representatives of well-known healthcare organizations of India. I thank Mr. Sashidharan and his team for inviting me here.
I'm sorry for this glitch. Basically, I was trying to show what we've been doing and how we communicate when there's a language problem. So what I was trying to show you was a real-time AI-based interpretation and translation of speech to speech. We believe that when people travel from one corner of the country to another and from one country to another, for whatever reasons, whether it is education or healthcare, they face language problems. They fail to communicate. Human interpreters are available, but they are available not to everyone, not at all the time, not at the language that they want to have, and not at the price that they want to have. At MeetMonk, we saw this gap and tried to come out with an AI-based solution where language was treated as a bridge rather than as a barrier between two or more people to communicate. And this communication has to be seamless and does not carry only voice. It carries text as well as videos. So our vision was to create a world where language has been a barrier, and now we want to transform it into a bridge. And as a part of mission, we continue in building innovative solutions around that to enable the organizations to carry out their internal as well as external communications seamlessly. So who we are and what we do. We are MeetMonk. We are world leader in the real-time AI-based multilingual translation. We have been acknowledged and deployed at the US Congress and the G20 event in Brazil held in 2024. We are working very closely with the leading healthcare hospitals in Los Angeles, and we are also working with our own prestigious Banaras Hindu University. We are a startup starting in 2020, headquartered in USA, and our founder is a person of Indian origin, Mr. Brahma Mishra. In India, we are registered as MeetMonk Private Limited to take care of the Indian ecosystem. We started off with OCR and the text translations, gradually evolved with video and speech, and then the evolution continues till date. Because it's just not standalone products, we believe not every organization has the same needs and the same solution can fit all. So we are very much customized. We are providing customized solutions. We are working with NIC to take care of the government needs in India for various departments and ministries. We are working already with Heartron, which is a Haryana state IT consultancy firm. And we are working with Kroll, which is a Brazilian Senate. So we are present everywhere. Now, we see that, okay, this is a solution which is not just required for a particular industry. This is required by every industry, every sector, wherever there is a communication in all forms. We've been hearing in the morning and afternoon session as well that hospitals needs to be patient-centric. The patient experience needs to be better. Smart hospitals are in the fray. So what actually are smart hospitals? Smart hospitals doesn't just necessarily mean robots moving around. They just don't mean only the new devices in the market, in the ecosystem. Unless the doctor understands the problem of the patient well, or the nursing staff is able to interact with the patient well, the patient experience is not going to be happy. So they need to communicate very well with each other. Converse AI helps two-way communication instantly when a patient can talk in his or her own preferred language and the doctor can respond in his or her own preferred language. Today we see medical tourism in India is on a boom. People from Middle East, from Africa, from European countries are flocking to India for quality and efficient healthcare services. We support about 45 plus global languages, including 11 languages in India. Now, this has got a highly accurate translation rate we'll see later, and easily deployable. You don't need any additional hardware for it. It's a simple plug and play. You can carry out this with the doctor's own tablet or a laptop or his own mobile device. You can use this with the patient registration desk or patient help desk or at the doctor's OPD or the ICUs, wherever you want. We've been hearing about EMRs. EMR is a time-consuming activity for doctors. Doctors are not meant to write the EMRs or type the EMRs. So why not try to save their time, what they are taking about 15 to 20 minutes. Let's enable them to do that in 2 minutes job and free up their time, free up their workload to take care of additional patients. This is Dicta EMR, wherein doctors can simply speak to the system, and our audio-based platform can take it and capture it into the EMR template easily, which can be downloaded and translated if required. The system is very well versed with the medical vocabulary, and all the terminologies are fed, and it's constantly being trained regularly. Voice-based systems can help you create the discharge summary as well. So today, most of the government hospitals, at least in Delhi, I have a couple of experiences where the discharge summary is of 2-pager, and the doctor spends time in writing that. Recently, about 3 days back, in the Hindi version of newspaper, Navbharat Times, if I recall correctly, there was an article stating that WHO report states 1 in 10 patients, they fear medical negligence. And one of the major reasons of this medical negligence is the doctor's handwriting. With all due respect to their hard work, but yes, they keep on writing and the writing gets a little illegible. They cited an example wherein a patient, a well-known patient, they had not named for obvious reasons, he was supposed to be administered a dose of 10 mg each day, and because of the handwriting, the patient or the pharmacist, they could not understand well, and they did not even bother to go back to find out what exactly. They went by what it was appearing on the paper. Instead of 10 mg dose every day, he was given 100 mg dose each day. Imagine the condition, imagine the side effects. So it is very much required that doctors spend lesser time in typing and writing, and instead they could use audio to text applications. These two were specifically for the healthcare sector. Now I'll just spend about a minute and rush you through the other offerings that we have, which may be useful at certain use cases, not for all the levels of the ecosystem in a hospital. So you have a video streaming translation. Let's say if this conference is going on and some doctors are referring to about a specific surgery, about their experience in a complex surgery, and you would want that to be translated into multilingual to be shared across your stakeholders, we could do that. You have document translation. There are many people doing that. We take the differentiation in saying that, yes, there's no limitation of numbers of papers that you could translate. You could translate a book either, and you could do multilingual translation at one go, including the generation of audio files. Here we support more than 100 languages. Indian languages included are 11. This is multi-speak. This is an evolution from the Converse AI. That was only for direct across-the-counter communication. This is for mainly people being on a conference, in an audio conference or a video conference for various events, internal or external. They could do that in their own preferred languages. Real-time transcripts being generated. Transcripts can be downloaded, translated into any other language that you want, and at the same time, AI can use to create a discussion summary or the minutes of meeting from this. Now, this is a very important term for delivering efficient meetings or efficient governance overall. Voice-driven engagement, you can, we are open to develop any application for any organization, including hospitals, wherein you would want to reduce the paperwork and go for more of voice-driven. Whether it is the voice-driven patient registration, it helps in the queue management, as one of the challenges which was posed by one of our speakers here. And this does not require literacy. We are doing a survey app for a government in Haryana, for a state government in Haryana for their housing schemes. And the entire survey will cover about 96,000 people, all on voice-driven, no paperwork required. Imagine the time saved and the cost saved. We claim to be 95% faster from our existing solutions, and in most of the languages, we are about 98% accurate. Patients and doctors are the key for any hospitals, and the use cases are just listed here. And use cases are not just these two. Any hospital can think of many more use cases. Healthcare is very confidential and strict with compliances, so we comply with HIPAA. Most of the data protection regulations from Europe, from Brazil, from California, and the quality management systems and the information security management systems specifications. And yes, we are totally made in India. That's it from Meet Monk. Thank you very much for your patient listening.
Thank you, Wasim. And I think one of the best things that I've seen in this session is that everybody is just carefully listening, and hardly anybody moved out even for emergency, right? So this talks about the impact that each one of us was able to deliver, and it really made sense. So we have about 5 minutes, and we didn't want to keep it monologue, but we landed up doing that. But in the interest of everybody's time, I would like to request at least a couple of people to ask questions. And yeah, please go ahead.
Hi, good evening to all. My name is Rahul Kumar, founder of MyDR24 HealthCare. हमारा जो प्लेटफॉर्म है ये टेलीमेडिसिन प्लेटफॉर्म है. बेसिकली मैं ये जानना चाह रहा हूँ जो ये लैंग्वेज बैरियर है टेलीमेडिसिन प्लेटफॉर्म पे क्या जो अलग अलग लैंग्वेज से अलग अलग रीजन से लोग आ रहे हैं तो डॉक्टर हिंदी में या इंग्लिश में टॉक कर रहे हैं तो वो अलग लैंग्वेज में तो क्या टेलीमेडिसिन प्लेटफॉर्म में ये इंटीग्रेट किया जा सकता है?
Very easily. We already have a module, as I mentioned, about the multi-speak, right? You could integrate this with audio or video conferencing. So we also have a telehealth module wherein it's very simple. Patient don't need to travel, right? So we can integrate easily with your telehealth module. The patient can talk in their own language. The doctor will listen in his or her own language and vice versa. मैं इंग्लिश बोल रहा हूँ, आप हिंदी बोलेंगे, हिंदी में सुनेंगे, आप हिंदी बोलोगे, मैं इंग्लिश में सुनूंगा. अच्छा. Prescriptions, template हमें दे दो, हम prescription भी बना देंगे. The doctor will give audio inputs to the prescription, show it to the front camera, वो automatically on हो जाएगा, and the patient can download the prescription there itself.
क्या ये टेलीमेडिसिन प्लेटफॉर्म में इंटीग्रेट हो सकता है?
Easily.
अगर क्रॉस क्वेश्चनिंग में यदि कोई डेटा बैरियर आता है तो फिर क्या किया जाएगा, उस नेग्लिजेंस को कैसे दूर किया जाएगा?
डेटा बैरियर से मीनिंग
अगर ट्रांसलेट में कोई इशू हो गई, डॉक्टर कुछ और बोल रहे हैं या पेशेंट कुछ और बोल रहा है, डॉक्टर कुछ और चीज़ों को समझ रहे हैं तो
नहीं, दिस इज देखिए एआई की ब्यूटीफुल चीज़ यही है कि इट इज़ टोन कंटेक्स्ट सेंसिटिव, वो कंटेक्स्ट समझता है। जैसे अभी कई बार बोलेंगे, जैसे फॉर लीगल केसेस कोर्ट्स में हम बोलते हैं लीव पिटिशन, अब किसी ने उसको समझा कि भाई छुट्टी की अर्जी, बट कोर्ट में लीव पिटिशन इज नॉट द छुट्टी की अर्जी, इट्स समथिंग एल्स। तो लाइकवाइज इट इज़ कंटेक्स्ट सेंसिटिव और ऐसे एरर के चांसेस बहुत कम हैं। बट येस, नथिंग इज 100% गारंटीड। मिस्टर शर्मा ने सुबह बोला कि द मोस्ट वाइडली यूज्ड एप्लीकेशन टुडे बाय ऑल ऑफ अस इज गूगल मैप्स, राइट? एट टाइम्स इट कैन ऑल्सो गो रॉन्ग। तो यहाँ पे ये है कि अगर समझ नहीं पाए तो वी कैन ऑलवेज आस्क अगेन।
ओके,
इट विल 100% आप उसको टेक्नोलॉजी ने आज तक कभी ह्यूमन को रिप्लेस नहीं किया है, सो यू कैन ऑलवेज आस्क अगेन।
ठीक है,
Thank
you
for
so much,
asking
sir.
that question. Yeah, gentleman there. Yeah.
Hello, sir. I'm Dr. Jagdish Shivhare, professor and ex-scientist ISRO. Sir, my question: what specific innovation practices, interruptions, and smart decision-making AI technologies are being incorporated by Indian hospitals to cope up with current threats in terms of drastic climate change, obesity, antibiotic, and antimicrobial resistances?
So I would like Dr. Vishal to respond to that because he represents the hospital. Yeah.
Yeah, so specific to climate change is what you're looking at?
Obesity also. So in terms of climate change, obesity, antibiotic, and antimicrobial resistance.
So
these things are
antimicrobial
threats.
resistance and the antibiotics, right? So that's an area which is being leveraged, and there are tools already there which can help hospitals to accurately predict the dose, the type, and the drug reactions and other things. So there have been technologies which have been put around that. So last I believe that's something happening in one of the hospitals in Gurgaon also. So Medanta and Imli, they have developed a stewardship program which leverages technology, and they've been able to reduce the length of stay by leveraging this thing on the antibiotic microbial resistance. So if someone wants to add to it. I don't think so that has happened in India yet. Nothing to the best of my knowledge.
I can just supplement to what Vishal said. There are IoT technologies, which are tracking all this. And one of the KRS for any hospital is to reduce the infection rate, right? And so I think there is already IoT, automation, everything is there. But your question is too broad. And I think even if one writes a PhD for 5 years, still not be able to get there you want to be. But there is an approach of something called One Health, right? And I think that is what each one of us is trying to, endeavor to achieve that, right? But thank you for asking, such a stimulating question that we will all set thinking about it, and probably, I'm sure we'll learn together. Thank you. Great. There's one question there as well. Okay, let's give the chance to him first and then to lady. Yeah, thank you.
So wonderful session.
Thank you.
I have a question to Yaduvanshi, Dr. Yaduvanshi. So you very beautifully explained how AI can help the existing ECG data, right? Now there are also issues in terms of biases because there is a question of ethics which comes into AI. See today most of the medical equipments and the analysis out of that must have gone through rigorous regulations and testing and everything, and that's the reason why they are kind of in practice today. But when AI comes into picture, then the deep algo or the algorithms which have been written, only the creator of that algorithm knows whether it's been biased or whether it's left or right or straight or whatever. So how does one because they don't disclose anything about the algorithm. So how does one know what is the outcomes which will consistently come out of that, and are they biased or not? So ethics is one thing which I am.
So I think it's a good question, and actually the way the AI needs to be trained, that also answers your question. So there is a population where it is trained, then there is a population where it's validated, and then there is a population where it is tested. And these tests, they go on, and as more and more people are using it and more data is getting generated. So, but definitely, as of now, all these AI-based, ECG-based things, they are not clinically applicable as of now. They are undergoing testing, and they are also in the process of getting FDA approvals for various technologies. Once that is there, so this happens to anything that we do. So there are randomized controlled trials where we have to prove that, okay, what we are seeing is actually true. So this is how it will be, and then obviously AI is its own problem. Even the people who have written the algorithm will not be knowing what the AI is actually saying. So like you have what is called as AI hallucination. You can get data, you go to chat GPT, he will give you a very good article and references, and all those references will be bogus. That's what is called as AI hallucination. So all these things can happen. So that's why it requires rigorous testing and rigorous re-evaluation till it becomes commercially available or widely used.
Yeah, I can just add here. So, you know, whatever you mentioned, there is something called software as a medical device. Now, you know, all this is undergoing certain regulations, and regulators are looking at the data and then they're approving it. So there is a clinical validation, ICMR is equally responsible, so the DCJ office. So anything which has a tag of SAMD, which means that you can be rest assured there's a clinical validation, and everything is happened in a manner that actually required to be happening, even as equal to a drug or a pharmaceutical or a vaccine. So it's not like the software is a very simple thing. No, software is also going through the regulation, and India is really embracing this. And that's where in the beginning I mentioned that we are entering an era where we are talking of digital therapeutics, right? Where every bit of the digital therapeutic is responsible for delivering the right value in a measurable way. So that's where, you know, it's not the future, but it is where we are today. Thank you. I think the lady in the last, because we have limited time. So Shashiji, I think we can take one more question. Is that okay? Yeah, please.
Yeah, my questions are for Dr. Yadvanshi. You mentioned that your AI tool has about 97% accuracy for determining the gender based on ECG. Yeah. Now, as a cardiologist, how would you explain it? Because we haven't been taught in physiology that there's any difference between the male and the female heart.
Yeah, so that's
one question. And the second question, if you would like to, you also mentioned that the predictive role of the AI in low ejection fraction or atrial fibrillation is probably because it detects something in the V3 lead. Now, my question is, supposing in patients where we think necessary, we do a 12-lead ECG with long lead 2 VF. Maybe we'll pick it up. Maybe we don't need AI to pick that up. So these are my two questions.
So regarding your first question, what was it?
The male and the female heart.
Yeah. So basically that is the beauty or the problem with an AI system is we really don't know because it's a black box. So you input the data, it gives you out the data. So that is what probably we humans do not still know what the ECG is, what is the change in the ECGs. There may be certain subtle changes because the level of accuracy that is there, in fact, it is probably more than what we can, looking at a person, we sometimes get confused whether, especially in modern era where people are cross-dressing and all kinds of things are happening. What the ECG, what exactly the machine is seeing, we don't know. Similarly, when you talk about the ejection fraction thing, we see that is what is called as a heat map of the AI. So it tells you what area of the ECG it is concentrating on. So they found that V3 is the area of the ECG where it is concentrating on. So they jumbled the ECG. Instead of V3 being at the standard point, they made V3 here. And they found that still it is looking into that area. So that means there is something in V3 which the AI is able to detect, and based on that, it is able to predict the ejection rate. Exactly. So the difference between this type of an AI and probably another AI is there are ways where we say, okay, suppose you talk about ChatVest score. So you say age hai, sex hai, hypertension hai, heart failure hai, ye hai, wo hai, and then you derive a score and you say whether there is possibility of stroke is there or not. In this, there are so many unknown, unanticipated changes that are there in the ECG, which we don't know as humans. So that is why it is kind of a machine learning. So it will learn on its own, and we don't know what it is learning, but it is able to give us the result. I think the IT people will be more.
So on a lighter note, I think maybe the clinical trial design was not robust enough and it was not approved by the biostatistician. So that's why we are not able to get the right answer. So I think towards that, I would like to thank all my wonderful panelists, for bringing such a wonderful perspective that smart hospital is not an option, but actually it's a reality and it's pretty much happening here. And I'm sure even the return on investment case for a smart hospital eventually will improve the EBITDA, and there improves the valuation, and there improves the attractiveness of healthcare sector to grow leaps and bounds, and then thereby accountable healthcare to 1.4 billion people. So I think with that note, I'll pass it back to Shashi Dharanji, where we started from. Thank you, organizers, for the wonderful opportunity, and really thank each one of you who has been patiently listening to us. I'm sure some of you got chance to ask questions, some of you may not have, but we are all available here for a coffee break, and you can all look up on LinkedIn. I'm sure we all have a LinkedIn account, and thank you once again. And Shashiji, over to you.
Thank you so much for chairing this session. As we move on to the next session, before that, let's present the memento to the distinguished speakers. I request Dr. Vishal Gandhi to present the memento to Shyam Kumar, Chief Operating Officer, STP Medtech. As we heard in the morning, STPI is doing a lot of good work in the startup industry. Dr. Amitabh Yaduvanshi, the coordinator and head of cardiology of Holy Family Hospital. Dr. Saab, thank you very much for being here with us. Prashant Oberoi, who's the director, global business for the Northern Communications. Vishal Arora, Chief Business Transformation and Operational Excellence, Artemis Hospital. Thank you, Vishal. Wasim Ahmed, Vice President Sales, MeetMong. So MeetMong is the startup company into AI. As we heard that AI is going to change the doctors in the future. So Dr. Amitabh, you need to think what to do now. As per I heard in the morning that AI will change doctors. I don't know what is the truth. So let me present a memento to the chairman of the session. I request Madam Upasana ji to come on to present this. She is the managing director for Yashoda Hospital, which you see in Ghaziabad and Noida. She was also the co-chairman of the event which happened in the morning. Madam, please. Dr. Upasana Arora will be speaking in the next session. Thank you, madam. Thank you so much. We have a break now? We'll have a quick 15 minutes break, not more than that, as Dr. Upasana Arora has to leave early. So we'll have a quick break, tea break of 15 minutes, not more than that, huh? Just 15 minutes. May I request all of you to please take your seats so that we can start the session.
Hello?
The session of the chair is Dr. P.N. Singh, Clinical In Charge and Senior Consultant, Holy Family Hospital, New Delhi. May I request Dr. P.N. Singh to come on the stage, please. In this session, we have a special address. The other distinguished speakers in this session are Mr. Sumit Puri, CEO, Prana Wellness; Dr. Samir Singh, Vice President, Clinical Services, CK Birla Healthcare; Amit Singh, Founder and CEO, Logics Boards Private Limited; Dr. Gautam Singhal, Associate Professor, Medical In Charge, Cath Lab; and special address by Dr. Upasana Arora, Managing Director, Yashoda Super Speciality Hospital, Ghaziabad. May I request Dr. Gautam Singhal to come on stage, please? Dr. Gautam. May I request all the delegates, please walk in with the cup of tea in your hands. Prashant, please take your seat. Chair of the session is Dr. P.N. Singh. I request Dr. P.N. Singh to take over from now. Thank you, Dr. Sir.
Good afternoon, everyone. We had an interesting sessions on smart hospitals and AI, and our next session is on digital health tech startups driving innovation in medical devices and pharma, revolutionizing the healthcare system. So first of all, what is digital health? The term digital health encompasses all applications emerging from the intersection of healthcare and technology. India's digital health landscape has undergone a remarkable transformation driven by convergence of technology and healthcare. Initiatives like the Ayushman Bharat Digital Missions have established a unified digital health ecosystem, providing health IDs, personal health records, telemedicine service to millions. Platforms like CoWIN and eSanjeevani have set benchmark for scalability and integration. Innovations in artificial intelligence, blockchain, telemedicine, and wearables are redefining patient care, making healthcare more accessible, efficient, and affordable. So let us start this interesting session. I would like to invite the first speaker, Mr. Sumit Puri, CEO, Prana Wellness.
Good evening, everyone. I think I'll probably just try and, again, keep it short. So I'm Sumit, and I basically will be talking about how today healthcare is being driven by the consumer, because we are seeing the new consumer basically wanting a much better experience overall. So why is it the consumer age? Because today you're seeing a lot of information being passed on. They see Amazon, they see Zomato, they see Blinkit. It's a totally different experience. Consumers today expect a hotel-like experience from hospitals, which is why healthcare delivery is changing and will change even further, with the new technologies also coming in. So for us, yes, it is one of the many providers in the ecosystem. Given hospitals serve a particular need, there is a need to look beyond also the out-of-hospital services, which is home care, how do you really make sure that there is a lot of convenience made available to consumers. So I'll talk about the fact that today consumers are informed, they're savvy, there's obviously social, because there are a lot of references, a lot of people connecting and talking about their experience, which also causes issues. So we look at, I think one of the presenters in the morning said 2/3 of patients don't come back when you have a bad experience. In fact, it's 81% number. And 2/3 patients don't come back because of a discharge, gone wrong. If you're waiting for many hours in the hospital and you're not discharged in time, that's one of the reasons why you probably change a hospital. So it is becoming a new center of gravity. And new age hospitals will need to adopt this reality that there are now much more demanding consumers. So for us, it is about convenience. It's about making sure that we are obviously, customer-centric and really creating some real value, to customers in general. We need a much more connected, coordinated, and integrated ecosystem. So it's about how do you also reach out to other possible, solutions, because it's an ecosystem. How do you really make sure that these, whether it's home care services or it is wellness providers, they kind of connect with you to give real healthcare to patient. And that's where we look at, the various categories as such. And I'll not even talk about multiple things, but IoT devices or new age solutions. We saw in the morning, like Meet Monk. That was very interesting for me because language barriers, you can actually, bridge those barriers if you're able to do this in a way that helps telemedicine to reach out to the farthest corner of the country. So it's about new innovations and connecting the dots. So overall, I think there is a significant problem in terms of healthcare. Today, we are doing more sick care in hospitals because, even in that sense, we are not really looking at prevention because there's a lot of volumes, a lot of load, and there is not enough scientific treatments happening outside. So hospitals are overloaded at the moment. And we are still not able to get to the root cause, which is why diagnosis becomes a problem. So frankly speaking, third largest cause of deaths is misdiagnosis. We've heard about the case of how difficult it is for a doctor who's seeing 40 patients in 1 hour to really get to the root cause. So that's where I think there is a need to probably use AI, use new innovations, which can make that much faster, much more accurate to look at trends and patterns. So we know, of course, when we look at it, that most patients, when you talk to them, they say, I wish my doctor gave me more time to understand my symptoms. I wish, there was basically a little bit more information available to doctors about nutrition, about, about exercise, about, stress management. I mean, I was talking to the chairman of cardiac in Vedanta, and I was talking to him and telling him that Harvard studies say 50% of people who come to hospitals come because of stress. And he said, you're wrong. And I really said, I'm sorry if I basically, made a mistake. He said, no, 90%. So the fact of the matter is, there's a lot of stress which causes cellular imbalance and gets people to go to hospitals. So the fact is, we will need to understand the root cause. Only then we can solve it. And many ways today, hospitals in general are looking at productivity. They are looking at much more, efficiency and productivity. There will be a need to move slowly into stage 2 in terms of consumer-centric health ecosystem, which is covering multiple aspects, not only about productivity, but beyond. And the same thing then will probably move to a cutting-edge health orchestration, which will actually now enable various institutions, various kind of devices, also various innovations to collaborate with each other, to create that ecosystem to deliver best health span. By this, I don't mean lifespan. I'm talking about health span because it is about quality of life, not just quantity. So that's what probably we will get to, from productivity to a consumer centricity and then to collaboration. If you look at the competition that healthcare institutions face, it is not the traditional healthcare institutions today. Amazon is getting into healthcare, right? Amazon, I think the CEO, a couple of days back, I was looking at the papers, it said, we would like to be the largest startup in the world. They need to be agile because healthcare institutions, unfortunately, are still, in some ways, insulated. They're still siloed. We have specialists looking at their own specialty. We will need to understand and take the best of the best from anywhere and everywhere. So you have to imbibe technology, imbibe innovations. And that's what even very agile companies like Amazon are doing. They are trying to see how we can leverage the best in supply chain. We need to learn some of this. Even for hospital, we can learn how to innovate in supply chain for inventory, for pharmacy. And I think we heard in the morning, we could even have dynamic rostering system, dynamic pharmacy systems, which could make this very efficient. But beyond the point, we will need to move to what matters to the customer, what would really appeal to the customer. So to me, that's where we will need to be having a very open mind, a very collaborative approach, because that's what the need of the hour is. There is a new digital health trends that are coming up. There is a need for innovation. There is a need to actually look at, obviously fairly new knowledge areas being worked upon. So also collaborate with research institutions, see what can be done. AI, we saw some absolutely amazing work, in the previous session, on how AI can detect, the amalgamation of echo and ECG. Now, this is very new, and I must tell you, about 7-8 years ago when I was in Max, I was invited to speak at a conference in Amsterdam where there was radiology, a lot of radiology people there. We were incubating startups in Max at that time. So we actually incubated Niramaya, which became a unicorn. And, they invited me to talk about, how AI in radiology could be a very big game changer. And when I went there, there was a bunch of radiologists from UK, a lot of radiologists from Netherlands and Belgium. And even that time, the accuracy of AI in radiology was about 80%. I'm talking about 6-7 years ago. And I was asking them, why are we not using this enough? Because they said the last 15% or 20% is so wrong that I can't use it. So AI needs training. You will need to train it. You will need to have the patience to train those algorithms to become better. And that's what we need to do as, technologists, as of course, also with clinicians, partner with them to create that ecosystem, to create that confidence that we will basically be able to give you the right results and ensure accuracy. It'll never be 100%. But that's what we need to work upon, because a regular radiologist is at 70% accuracy. Technology is giving you 80% or 85%. Let's work to make that 15% better. That's what will give you the results. In transitioning from where we are to digital health, there is a need, it's a continuum of care. We are talking about various stages. We'll need to move towards a more patient-centered ecosystem. We'll need to look at various elements of digital health. How can we really create an excellent, connected ecosystem? Because that's what will give you results. I'll not spend too much time, but I'm just giving a sense of how the new hospitals are going to evolve. We're going to look at the future of healthcare. You actually look at 72% hospitals highlight improved quality of patient care as the key focus area. Absolutely critical, because insurance companies are now going to demand outcome-based payments. It's not going to be fee-based payments. We will actually move towards outcome-based payments because healthcare costs today are not sustainable. We will need to start changing the way treatments and the way diagnosis is being done. We will need to start leveraging technology because that's what is going to be needed. And there's a huge amount of possibilities if we have an open mind. Obviously, from our standpoint also, we know that we have to make technology easier for clinicians, easier for the administration staff, easier for employees within the company, and of course also for our own patients. But it is in some ways doing this in conjunction with the clinical staff, because they are the one who are under most pressure. And for that, we're just saying there is a need to look at SMAC, to look at the social media, the trends and feedback that is basically coming up from customers, because it has to be patient-centric. We will need to look at mobility, because 24/7 access, anytime, anywhere. We need to look at analytics, data-driven decisions, and of course, the cloud, which is going to be very beneficial. But all of this is possible as we go forward. I'll not go into too much details. We talked about precision medicine and genomic medicine, how AI can really create a lot more accuracy in what we do. But it's a curve. There will be troughs and crests along the way. What we need is to basically be clear about how we're going to impact actual outcomes. Aspects like operations, are going to become, like I said, from productivity, we'll move towards patient-centric approach and ultimately towards a very, very collaborative approach towards starting with image analytics, but tomorrow it will also be diagnosis. We are trying to do image analytics and, in fact, diagnosis, with AI in 2016 with Babylon Health. There is a lot more improvement that's happened on AI since then. It's all about actually having the confidence to embrace it. The bots and conversational AI, this is all something which is now coming together very, very well. We've had a huge amount of work now with ChatGPT coming in. People are much more confident. I mean, I talk about, AI when we say, can I do predictive analytics in terms of, the customer attrition? Can I do predictive analytics in terms of my pharmacy levels? But then customers, and even today when I talk to healthcare institutions, because we also do Six Sigma for hospitals, they tell me, where is the AI here? Because I'd like to see the ChatGPT, the chatbot, where I can connect and get answers. AI is beyond ChatGPT. AI is much, much more. If you really start leveraging it well, you can do wonders. Incredible possibilities in revenue growth, incredible possibilities in patient safety, huge possibility in customer experience. And of course, you can also look at cost efficiencies. But it only is, you're in some ways limited by your imagination, nothing else. So I'll not cover too much beyond this, just that say that there are lots of possibilities, teleopthal, mobile ventilators, robotic wrists, and mind-controlled wheelchairs, new initiatives happening around this. And to end with this, I'll just say that at Prana AI, we're looking at holistic wellness. We're creating an AI-based wellness platform. In fact, with just a 1-minute facial scan, we're covering multiple parameters, including your stress, including blood pressure, including SpO2, pulse rate, diabetes risk, I personally feel non-invasive diagnostics is going to be the way to the future. You'll enable access, you'll enable accuracy, and really make it convenient for the customer. So we are kind of looking at various elements, where we're connecting the dots. Hopefully, we can really connect and make this a really continuum of wellness, which will become extremely powerful as we go forward. So thank you so much for the time. I know my time is up, so I'll probably leave it today. Thank you.
Thank you, Mr. Sumit. Very informative talk. And AI gets more and more interesting. The more you know about it, the more interesting it becomes. But at the same time, it is scary also. Whether it would have its limitations or not, that only time would tell. So I would like to invite the next speaker, Dr. Sameer Singh, Vice President, Clinical Services, CK Birla Healthcare. His topic would be enhanced patient experience and workflow automation.
Ladies and gentlemen, a very good afternoon to all of you. So it's often said that it remains artificial intelligence, and I will prefer human foolishness over an artificial intelligence, right? Because it comes with real. Okay. Anyway, so why am I here today? I'm a part of Nat Health expert group. We are master trainers who promotes adoption of digital health. What you heard about, you've heard Mr. Puri very well spoke about, where the future of technology lies, where the future of AI lies in there. You've heard the previous panel with Mr. Arora and I think from SGPT, how I think the tech is going to change the community and healthcare at large. What about smaller hospitals, 50-bedded, 40-bedded? What lies in store for them? So I think there are 4 basic pillars of advantage. My topic has been how do you enhance I think operational efficiencies and effectiveness into hospitals. So the first is obviously it streamlines your operations. It gives you a clear visibility on operational specifics to boost your efficiencies, and it reduces cost. The second bundle is higher patient satisfaction. The third is obviously to improve its financials. And fourth is the business growth. Eventually it all culminates into the word of mouth, trying to multiply your business and of course patient retention. So, quick questions. How many of you have actually stood in the queues in banks 5 years, 7 years back? My father still goes there. My mother thinks he's probably having an affair with the teller, but then, or the lady who sits at the counter, but he prefers to do it online. He's retired. He feels that's the way to go. But now we all do it on the tip of a finger on our apps. How many of you remember communication where you had to post a letter or give a phone call or stand in the STD booths to get your number? I will remember in my medical college. Now it has gone into minutes and seconds. You pick up a call and at I think thousands of lakhs of kilometers away, you could just call them, FaceTime them, stuff like this. Retailing industry, you've seen how you have to travel to stores. I still travel to store because I want to, feel the stuff before I buy, whether it's vegetable or cloth. Of course, that's a different thing that for people my size, you will get clothes only if you try them once, not online and keep on returning. Transportation, if you remember, you'll have to stand in queues and wait till the person in front of you. By the time he asks which train, what station, even if he's going to somewhere in Bihar and I had to go somewhere in Tamil Nadu, my seats are full because he's there in the queue trying to still fill the form, right? So now I think multiple people could, simultaneously book tickets. That's the digital transformation in any industry, any service, anything that touches your life. So why not healthcare, which is, which is what is keeping you living, correct? So Why do hospitals need to adopt healthcare? Where would you buy from? Would you go to a shop A which accepts only cash, customers have to wait in line, does not have change or cash to return, or also accepts digital payment? So now you have hospitals placing QR codes everywhere across. I worked into a hospital where they even load money into your wallet. So as you move, every time even you don't have to repeat the QR code. It is just one-time payment at every time you crosses and does a transaction, even if you pick up a bottle. And trust me, it's still in India. I'm not talking about somewhere abroad. You cross, you pick up a bottle, it builds in you, right? You have searched for toothache last night. I am crossing in front of your hospital in a public transport bus. I get a pop-up message, there are 2 dentist slots available right now in that hospital. So that is that hospital's AI-based cross-selling marketing. When I get into there, it actually tells me go to 2nd floor, 4th room. That is where the dentist sits in there, gets your appointment. It also does me a queue management system. So there is the medicine written, diagnostics written, tests written. So it will tell you go first, give your blood test. Although you're 6th in queue, but your number will come faster. Go to the pharmacy. After that, your medicines will be ready. And although you're 2nd for X-ray, but it's going to still take you 20 minutes. So that does the queuing in for you. Nobody else has to do that math for you, right? And this is still in Bangalore. There's a hospital based in Whitefield. We commissioned that. Now I'm not so sure whether it is still running, but that's the aspirational digital hospital which a group had planned to run. Also, you would, patients could scan throughout QR codes. You have e-ticketing through mobile apps. A lot of good hospitals are building up their own apps where a lot of service deliveries could be accessed in, including your valet car parking, including ordering food from using their apps, right? So dynamic scheduling with real-time tracking, automated updates and notifications. So it's a two-way one. I booked an appointment at 10. My doctor knows somebody's going to come and see me at 10. He's running late. I will come to know. I'm running late. He will come to know, right? So that's the kind of talking mobile apps which a lot of hospitals are developing through. So obviously, which hospital would you go for? And a lot of us, I think almost all of us thinks these things happens only into large format hospitals, 100-bedded, 200-bedded. The answer is absolutely no. I run 50-bed, 70-bed, small format hospitals. I cannot afford to keep so many staff. I have shorter space. I don't want too much of crowd in there. I would be the first one who wants to invest into that technology. I want to streamline my operations, bring in operational efficiencies, get better patient satisfaction. Anyways, I'm 70 beds. I want my patient to be out, right? I can't have 500 beds and I can't keep on admitting patients. So the sooner the patient gets in, the sooner they get out, the faster my bed is ready for the next one, right? So when I adopt technologies like robotic, people think it's a fancy one. No, it allows my patient to go home the second day. So without really creating extra beds, every month where a particular surgery was taking 3.5 days, I'm able to relieve them by 2 days, adding 1.5 bed days per day to my hospital. So at the month end, I have actually added about 15 beds to my hospital. So I'm not a 70-bedded hospital anymore. I'm an 85-bedded hospital without really investing a single rupee, right? So that's where technology comes into picture. Why does hospital needs to adopt digital health? This is a question for the audience. Oh, I'm running out of time. Traditional check-in with front desk assistance, paper-based room services, in-person booking confirmation, or physical keys to room access. Versus, would you like to take a mobile check-in, online booking with instant confirmation, digital keys, room services, like how you feel in hotels? The choice is very obvious. You also see where catering and food could also be ordered through your online hospital apps. Your attendants could order, you're back from surgery, when are you out of NPO. All these are real-life examples which happens into hospital. It allows registration on apps and websites, stores all your you've heard of electronic medical record system. I'm sure you've been hearing it since morning. You've heard of follow-ups, AI-based decision-making tools. You've heard of, I think, partnering with insurance companies, what process will go, what claims would come back, right? All that will obviously, linking in your registration and billing modules and taking into more advanced, I think, versions of that. As in when we progress, every 2-3 years, we keep changing and evolving into a higher one. Of course, you have enhanced patient experience because of record management, care coordination, improved decision-making, ends up into business growth. How do I get my work efficiencies for management? Is streamlining administrative processes, resource allocation, compliance and regulatory ease. It lowers my waiting times, cost saving, increase in engagement. And for patients, it's actually also ending up into education and self-care. So I don't have to keep on training them post-home, post-discharge. I give them QR code-based videos. So they know what is my wound care, how do I do my infection control care, what time of medication has to be taken, everything. If I'm a primary surgery center, every piece of information, including physiotherapy exercises, are on QR codes specific to each surgery, so they know how to take care of themselves, when to follow up, what is to be done. And I think that's how it is bringing in, efficiencies for doctors and needless. I don't have to mention, you have better access to patient data, collaboration, better time management, patient throughputs. They don't have to spend too much of time at looking at paperwork. They can take care of the patients. I think I'll skip all of this. And don't think government is not applying through this. We all remember CoWIN app, right? That's how we were getting our vaccines. So that's digital technology. There is ABDM, where government is trying to put up a repository of doctors, hospitals, patients, everything across. So one click, and I think everything is under a single umbrella. We have eSanjeevani, which is e-prescriptions available. Punjab has even implemented telemedicine using mobile apps even at primary healthcare centers and wellness centers. And Nextcha is a TB follow-up kind of an app. I think everybody has spoken about this. Possibilities are endless. Have you started your journey towards digital healthcare? That's my parting question to you. Thank you for your time.
Thank you, Dr. Samir. Artificial intelligence is making life easy for common man, for patients, and for the service providers. Thank you, Dr. Singh. We have with us Dr. Upasana Arora, Managing Director, Yashoda Super Speciality Hospitals. May I please request ma'am to address the podium.
Good evening. I think morning till evening now everybody is tired, especially getting so much gyan, it's overflowing now. AI. When you will sleep today again, you will start thinking about AI. So I just want you all should take a deep breathe in, then out. At least feel fresh. So these days everything is now AI driven. Sometimes, your phone is also AI driven. You are searching for someone, he is telling you other someone. So it's so difficult also. It's not so easy to adopt AI. But fortunately or unfortunately, now hospitals are also digital. It's good. Sometimes it's really helpful. At the time of Corona, it was really good for telemedicine, that we can talk to our doctor. Now even surgery is also digital. I mean to say, like robotic surgery, you can do a surgery from different hospital. We are making new hospitals, so we have made 20 modular OTs with facility that if some doctor who is in America and we have collaboration, he can do surgery from there with the help of this digital thing. So life is changing, world is changing. I don't know. I feel lots of things are very good in healthcare when we talk about digital health, when we talk about that you can get your registration done, you can pay your fee, lots of things you can do. But I always say, there are place of a doctor and a nurse. I think that human touch, that human touch has to be there. Machine cannot give you that kind of confidence. I can give an example. When Corona was there, everyone was so scared, and there were few hospitals in China, in I think Singapore, or maybe in India also, where this robot was going to give medicine. And the kind of depression patients were feeling, because they were, what is our sociology told us, that we are human beings and we are basically by nature, we are social. We need to have people around us. We need to have human beings around us. So I think all this digital thing has to be there for the comfort of a patient and a doctor. And lots of things can help in the digital thing. Like I am also making a hospital which we are calling it digital. But I don't know how we can replace that touch of a sister and a doctor. So what I want, that AI should do whatever they want, that radiology will now take place and there is no need of a radiologist. AI will make reports and this and that. It is actually happening also. Like somebody told me that they have got a report from some other country where there was no doctor, but they got a report. So I was thinking, काश मैं भी वहाँ होती, मुझे इतने doctors ही ना ढूंढने पड़ते कि भाई आओ मेरे यहाँ ज़रूर काम करो. So I believe that these things are quite good, especially patient monitoring from you know, like DOSI we are also using, or when thing comes to home care, it's good that you can monitor your patient on your mobile, that how vitals are doing. But I never prefer that, and I am telling you, it is not going to happen any time that AI will or digital things will take so much, you know, takeover of healthcare, because other industries can do this. Manufacturing can do that, wo robot is banata ja raha. Even everybody asks me to put, because we are also doing surgeries through robot, Da Vinci robot we are doing it, and now Da Vinci has made my new hospital as their Southeast Asia center. Even for knee replacement we are using this Mako. But still I believe that everywhere we cannot use robot or we cannot use all this thing, because sometimes if there is any problem, any error, the human is there and he can correct that mistake. You know, there was an incident, I think everybody must have read in newspaper, that doctor who was doing a robotic surgery, he left for lunch and he just forgot to lock that robot, and that robot just, patient was unconscious, so something wrong happened. So when we are using technology, we need to be very, very careful, and we need to have all the trained staff. If you are using all the technology, if a person like me is going to use some technology, I don't know what I am going to do, some disaster. So it's better, person like us should be away from these technologies. And those who are really good in technology, or who are, and it doesn't mean that age is a factor. Yesterday I met 3 people who are really aged, and even I asked them, why you are here with some technology thing? आप तो हमारे जैसे हैं. मैंने कहा ये आप अधेड़ उम्र में क्या लेकर आए हैं मुझे दिखाने कि हम ये करते हैं. Then he said, oh madam, don't say like this, and you know, I am the IIT engineer and all. So it doesn't matter of age. It's a basically matter of interest. Who is interested in new things? Who is interested in technology? But 100% now healthcare is going on digital, and especially I really like this idea, airport. When you go through DigiYatra, it's so convenient. But why we are not able to do something in healthcare? Government is able to do many things like CoWIN app. Saurabh was telling about CoWIN app. But we made many, I think lots of companies are here, they have made many things, but not as easy as these 2-3 apps are so easy. Like Amazon, Blinkit, they are keeping very simple. Just यहाँ दादी जी भी कर लेती हैं, यहाँ दबाया, फिर अपनी आलू की शक्ल देखी, उसको दबा दिया, फिर पैसे देखे, उसको दबा. That's it. But we are making things very lengthy, ये form भरो, वो form भरो. So I think if we are going to digital, we need to make it very short, crisp, and very easy. Only then everyone be able to, like we are going to put kiosk for, you know, this receipt generation. I don't know how many people are going to do it, but we can't say that we will not use it, because it's a demand of time, because young generation actually wants to do everything just fatafat. They want to do everything in seconds, and I think that is also good, because life is very fast and we are going like that. And hospital is a place where if person who is sitting or living alone in a home and kids are away, they need to see the hospital and the hospital functionality and lots of things. So they can book from there, from even Australia, they can book a doctor appointment. So all these things are good, but I always want human touch को रहने दो, क्योंकि उसकी जगह हम लोग कभी किसी को नहीं दे सकते. लोग डॉक्टर को भगवान कहते हैं और नर्सेस को हमेशा ही देवी के रूप में देखा जाता है. तो कीप इट लाइक दिस, गो डिजिटल, बट डोंट फील दैट यू कैन रिमूव दैट टच. वो एक टच था जो मुझे आज भी याद है मेरे अपने डॉक्टर का. वो कहते थे, बेटा ठीक हो जाओगे, चिंता क्यों करती हो. एंड देयर वॉज ओनली फैमिली डॉक्टर, देयर वॉज नो सुपर स्पेशलिस्ट. नाउ देयर आर सो मैनी स्पेशलिटीज, सुपर स्पेशलिस्ट में भी सब स्पेशलिटी. ऑलरेडी इतना कॉम्प्लेक्स है हेल्थ केयर, एंड वी आर मेकिंग इट मोर कॉम्प्लेक्स with lots of new things. I don't know how many inventions. Like we are also going to do this cell therapy, gene therapy, and CAR-T therapy. Everything is good for the future, but same time, if you think and if you see how simple life was. एक जगह बैठे हैं, अपना खा पी रहे हैं, खुश हो रहे हैं, बात कर रहे हैं. अब nobody has time to talk, nobody has time to discuss anything. We are just running and running. I don't know running behind whom. But anyhow, thank you so much for calling me, and thank you so much for this digital health conference. It's always very good to see new talent who are making new things, and then they want that I have to go there to see and then talk about them. Thanks a lot.
Thank you, ma'am. Very encouraging and assuring talk. At least, now medical personnel can be assured that AI is not going to replace them. In fact, AI is going to help them. And that technology should be used to assist human beings, not replace them, to make our lives easier. Thank you, ma'am. May I request the next speaker, Mr. Amit Singh, founder and CEO, Logic Boots Private Limited. He would be speaking on artificial intelligence and medical imaging.
A very good evening, everyone. This is Amit Singh, founder and CEO of Logic Boots Private Limited, a startup working in domain of development and manufacturing of, I'm sorry for the word AI once again, since morning everyone is fed up by listening to artificial intelligence, but I'll be clarifying few things related to AI. So let's start. We are incubated at SGPGI Lucknow, as well as we have a presence at TIDES IIT Roorkee as well. So basically, AI is not going to replace doctor or nurses. It is going to enhance, and it is going to be proved as a helping hand for the medical fraternity. Like suppose we are working with medical devices. So starting with, let's suppose a patient living in remote areas of any hilly state, Uttarakhand, where the availability of the doctors is not present as of now. I'm talking about telemedicine. And if there is a telemedicine or AI is used in the diagnosis segment, like through the heartbeat or through the lung sound, on what we are working as of now. So the disease can be diagnosed by a doctor sitting in Delhi or Mumbai. And over the phone call and through the telemedicine, he can give the proper medicine and he can be safe. So that is one part. And second one is if we start. We are working on the imaging part. I'll be explaining in the further slides how we are working and how we have gathered the data and all. So importance of diagnostic, I have lost 2 family members because of the delay in diagnosis of breast cancer. First one, I lost my Buaji back in the year 2013. And because of this uterus cancer, I lost my grandmother. I was a small child. So the reason was that there was a delay in the diagnosis. हमारे पास वो होता है ना, एक तो इंडियन पेशेंट के साथ समस्या है, जब हम पूरा बिस्तर पे पड़ जाएंगे तब हॉस्पिटल में जाएंगे. रेगुलर चेकअप का कोई सीन ही नहीं है हमारे पास. हार्ट अटैक हो जाएगा तब हॉस्पिटल की तरफ भागते हैं. तो एटलीस्ट वी नीड समथिंग कि भाई रेगुलर चेकअप होता रहे. और लोग पेशेंट इस वजह से भी नहीं जाना चाहते हैं कि हम जाएंगे तो डॉक्टर 4 और बीमारियां ना बता दें. भाई तो वो है, यू हैव टू बी ओके. आपकी फैमिली डिपेंड करती है तो वो आपको दिखाना पड़ेगा. सो दीज आर द थिंग. तो मेडिकल इमेजिंग पे हम आते हैं. सबसे पहला डेटा सेट AI के बारे में सुबह से हम सुन रहे हैं. वी आर लिसनिंग आर्टिफिशियल इंटेलिजेंस. इट्स अ वेरी क्वाइट फैंसी वर्ड. अभी हो गया आज के टाइम में. but what are we really working on the AI, artificial intelligence? Like, अगर AI की बात करें, we need to have a data set of multiple of 100 crores. हम 5,000, 20,000 और 1 लाख के डेटा के ऊपर we can't say we are diagnosis कर रहे हैं हम किसी बड़ी बीमारी का, लंग कैंसर का, ये किसी बीमारी का. तो ये 20,000 और 50,000 और 5 लाख डेटा के ऊपर we can't go for the AI part. Rather, this is called machine learning. जो काम हम कर रहे हैं और उस मशीन लर्निंग को AI बोल के हम वी आर जस्ट मेकिंग इट फैंसी, थोड़ा सुनने में अच्छा लगता है. AI अगर गूगल हेल्थ करता है तो दैट कैन बी कंसिडर्ड बिकॉज गूगल हैव द मैक्सिमम नंबर ऑफ डेटा, आधे ऑलमोस्ट 60% ऑफ अर्थ पॉपुलेशन. सो स्टार्ट हम वहाँ से करते हैं. तो लाइक वी हैव ऑल्सो वर्किंग ऑन द इमेजिंग पार्ट. इमेजिंग पार्ट पे इसलिए बिकॉज रेडियोलॉजिस्ट की जो कमी है अभी लिटरली में करी है. 1 radiologist on 1 lakh people. So that time जो जाता है ना, like it can be like life threatening for most of the patients. और जो होता है डॉक्टर के पास जब तक रिपोर्ट पहुंचेगी नहीं, how he can diagnose. So that is one of the reason to use AI for the early detection. And यहाँ पे दो चीज़ें आती है. First one is diagnosis, second one is prediction. कुछ होने की संभावना है. लाइक अगर हम कैंसर की बात करें, देयर इज अ स्टेज कॉल्ड प्री कैंसर. सो दैट हैज़ टू बी, दैट कैन बी डायग्नोज. सो अभी आगे बढ़ते हैं. इससे इमेजिंग पे क्या क्या काम कर सकते हैं. लाइक वी कैन डायग्नोज वेरियस काइंड ऑफ डिजीज थ्रू द एक्सरे, CT स्कैन्स, कैंसर, निमोनिया, ट्यूबरक्लोसिस, TB. गवर्नमेंट भी काफ़ी अभी चला रही है सिस्टम टू डायग्नोज द TB एट द वेरी अर्ली स्टेज. So this is what like types of imaging where we can apply the AI over the X-rays, over the mammography, like breast cancer. जिस तरह से patient बढ़ते जा रहे हैं, we have to really work seriously on that. At least on the diagnosis. Recently, I was reading a report from the MIT USA, and a startup over there is working like they have made a probe and which can be used by anyone over their breast to get the pre-cancer signs. And in that case, he can just visit the doctor and get the treatment done at the very early stages. So how Logic Boots, how we are working on the imaging part as of now, we have worked on tuberculosis and pneumonia. So we have collected a data set of almost 5.5 lakhs, which is with us, and the model is working perfectly with the accuracy of 97.6% as of now. I thank you, my team, Mr. Ayush and Ritik, for the same, who developed the complete model for this. And now we are working towards the detection of lung cancer, and not only early diagnosis, we are also working on the prediction part. एकदम शुरुआती स्टेज में अगर कोई चीज़ पकड़ आ जाती है तो वो आप लोगों के लिए भी काफ़ी बेहतर होता है फॉर द ट्रीटमेंट पार्ट. अभी लाइक वर्ल्ड की बात करें, अब दो चीज़ें हैं सर. लाइक एक तो बीइंग अ इंडियन कंपनी, फर्स्ट ऑफ ऑल आई विल लाइक टू रिक्वेस्ट ऑल मेडिकल फर्टिनिटी टू join hands with the Indian startups also, because वो एक सीन हो जाता है ना. लाइक अभी हम सर्जिकल बॉट्स की बात कर रहे थे, मैं बॉस टॉकिंग अबाउट लाइक रोबोट्स डूइंग ऑपरेशन. सो इट हैज़ टू बी एदर कुका रोबोटिक्स और जापानीज कंपनीज की हैं, तो दैट इज़ मच बेटर एज कम्पेयर टू एनीवन हु हैज़ डेवलप्ड दैट इन इंडिया. सो लाइक वी आर टॉकिंग अबाउट दिस मॉडल. सो दिस इज़ द रियल एग्जाम्पल ऑफ डिटेक्शन ऑफ लंग कैंसर. इवन छोटी छोटी चीज़, ह्यूमन एरर को अगर हमें नेगलेक्ट करना है, हो जाती है कभी कभी. लाइक वी ऑल आर ह्यूमंस, गलतियाँ सबसे होती है, या कभी मिस हो गया या डिले इन डायग्नोसिस हो जाता है. तो उस केस में लंग कैंसर अगर शुरुआती दौर में है, वी कैन डायग्नोस, वी कैन प्रिडिक्ट दैट. एंड अपार्ट फ्रॉम सेकंड इमेज इज रियल प्रिडिक्शन ऑफ द ब्रेस्ट कैंसर थ्रू द AI मॉडलिंग. एंड दिस हैज़ बीन डन बाय द स्टार्टअप्स ऑफ द यूनाइटेड स्टेट्स एज ऑफ नाउ. लाइक बेनिफिट्स जैसा मैंने बताया, जैसे हम बात हो रही है, लाइक इट कैन इंक्रीज द एक्यूरेसी ऑल्सो. इट कैन जो डिलेज होते हैं वो डिलेज को सॉर्ट आउट करेंगे. थर्ड वन इज़ लाइक प्रोडक्टिविटी, थोड़ी जल्दी चीज़ें हो जाएंगी. वी डोंट हैव टू वेट फॉर डेज और इवन वीक्स इन सम केसेस जैसे टेस्ट होते हैं. सो लाइक फ्यूचर ट्रेंड्स, भविष्य क्या होने वाला है. लाइक AI इज़ गोइंग टू बी यूजफुल फॉर नॉट ओनली फॉर द मेडिकल फर्टिलिटी बट फॉर द ईच एंड एवरी पर्सन. लाइक पेशेंट हर घर में है. मेरे माँ भी खुद आर्थराइटिस के पेशेंट. आई लॉस्ट माई फादर बिकॉज ऑफ द डिले इन डिटेक्शन ऑफ हिज ब्लड प्रेशर एंड ऑल. रेगुलर चेकअप कराते नहीं थे, सो इट वॉज हिज फॉल्ट. तो ये सारी चीज़ें वी हैव टू कीप इन माइंड, एंड अकॉर्डिंगली द फ्यूचर इज़ गोइंग टू बी लाइक AI हैज़ टू बी इंटीग्रेटेड. not for the surgery or not for the jo human touch, what ma'am was talking about was absolutely right. The human touch is required for the patient, but in the radiologist part, like for the imaging, for the early prediction of diseases, and which it will be too much helpful as compared to normally अगर हम wait करते रह जाते हैं इन सारी चीज़ों को ध्यान रख के तो thank you so much. That's all about us. Like this is the market segment.
Thank you, Mr. Amit. Our next speaker is Dr. Gautam Singhal, a very promising cardiologist. He is Associate Professor and Medical in Charge Cath Lab, DMCH Ludhiana.
Can I have my presentation? Thank you, sir. Well, I'll try to do justice. I'm not much into artificial intelligence, and probably I'll start with a real-life incident. Probably a couple of years back, when our team was taking rounds in hospital, and we asked our fellows a question, and when they gave an answer, it was wrong. But then they immediately took out their smartphones and started looking for the answer. And my senior colleague looked at me, smiled, and said, Gautam, are we actually entering into an era of smart intelligence or probably artificial smartness and natural stupidity? So I don't want that that artificial intelligence should make us look stupid or should just totally replace us. But then, of course, it is here and it is here to stay. And it's going to get incorporated in healthcare much more than we probably have imagined, and in a big way. Much further ado. It all started with Alan Turing during World War II when he broke Enigma, the code Enigma. The actual commuting started from there. So he is probably not actually regarded as the father of artificial intelligence, but of course, he is the one who actually started it. It all started from there. So how it actually started from 1942 to where we are actually today is it's actually a long way. In 1995 and 1996, there was the first supercomputer, which was Deep Blue, who played with Garry Kasparov, and actually it lost. And the very next year, the refined version of Deep Blue actually defeated Garry Kasparov. The 3 matches, one was won by Garry Kasparov, the second one was a Deep Blue computer, the third one was a tie. But the computer, being a computer, was labeled as the winner because it actually surpassed human intelligence at that time. So that's how we evolved. So now AI is of 2 types. It's a generative AI where you just ask something and it generate a text or generate something for you. And there's a predictive AI which just looks at the various data sets and predicts the future events or something like that. And then there are 3 stages of AI, where we are right now is the narrow AI. It is just like just you give them some task and they'll do it. And they are specified to do a specific task. They're not going to take over anything. The next stage is a general AI. It takes knowledge from you of one domain and transfers to another domain. Probably you give AI some data, they'll give you a website, they'll give you a totally different a world altogether. The next stage where we probably never want to venture is the super AI. Machines that are an order of magnitude which probably would be smarter than humans. They may not even require prompts from the humans. They will do everything on their own. That is probably world we should never enter. That's what I feel. So like I said, we are in the world of narrow AI currently, and in a narrow AI, we have machine learning, deep learning, and they're all different modules which probably help us in healthcare and in all other fields. So like I said, that artificial narrow intelligence is currently where we have Siri, Alexa, Cortana. The next stage is artificial general intelligence, and then probably will be the super intelligence. And so like I already spoken about it. So now we know that digitalization and artificial intelligence already revolutionized finance, manufacturing, retail and services, and education policies and governance also, even governance also. But what we actually are lacking in where is digitalization in healthcare and where is artificial intelligence in healthcare. So like I've spoken about this. So working on the principle of healthcare using artificial intelligence, what it does is we have loads and loads of data. Why do we have loads and loads of data? Because computing has become cheaper. Data storage has become cheaper. There were days when even the floppy disk could hardly carry a 5 MB of data and used to be very expensive. Now you can have GBs and even terabytes of data, which is almost free. So you have enough data. We can have enough computing powers to process that data. We can have enough machine learning modules, and there is even human artificial intelligence collaboration. So these all factors, when come into integration, they usually help us having a better healthcare, probably integration of artificial intelligence in the health. So how application of artificial intelligence can help us? There is medical imaging analysis. There are electronic health record analysis. It can also help in discovery of newer molecules and drug molecules, and even the delivery of the drug molecules. And it also helps us to do prescribe or practice precision medicines, where we can target specific molecules that's specific in a patient and do therapy, especially in oncology. So it also can help us with the various modules and the various data sets to have a diagnostic accuracy, personalized treatment plans, predictive analysis. So, they can have, if you just, give your ECG to an artificial intelligence tool, probably, and if you give your family history, probably they can predict your future risk of developing heart disease or any other event. So AI is not actually really new to medical imaging. It has been there for years. This is one of the flow charts where we do a myocardial flow imaging or a PET scan to actually see whether a tissue is viable or not. So it is actually helping us for years now, but yes, it is one field of having an artificial intelligence. So it helps us in having, it may help us in having, make diagnosis. It is already helping, we may further improve on it. Radiology is probably, in imaging, radiology is the probably branch which is probably having benefit most of it. Even the most of the patent devices which have got patent, 70% probably are in the radiology. The next probably 15-16% are in the cardiology, then in the pulmonology, and few are in pathology. I'll be coming on to those. Even Siemens have probably, making the setup and CT scan machine, probably, just patients lie down, it's a roof-mounted CT scan. Radiation dose is minimized, the predictive panels are there, so everything is this. There's no human error. This is one slide I would like to show. This is one X-ray of air under diaphragm, which we put up in as an experimental in a DMC. We put up it to on a ChatGPT, and we just asked us, please analyze the attached image and share your observations, including potential findings and their implications, and share whatever you can with your limitation. Use guesswork if possible. Share with reference to images. Right. So the observations were that the elevated right hemidiaphragm. There is gas under right hemidiaphragm, well-aerated lung fields, mediastinal cardiac salute were normal, and the possible clinical implication was pneumoperitoneum or elevated right higher. They give it to that, and they further suggested CT abdomen, urgent clinical correlation, and surgical consultation. Probably one thing probably they would miss out, it did miss out was it could have been a post-surgical, right? So there are limitations, but then it was probably, to me, it was fairly accurate at that time. It was just an experimental, we just put it to ChatGPT, and that's the response we got. So like I've already said that there are various modules, learning modules, and convolution neural network also, which helps in predicting diseases, probably, or any event that can happen to a person's lifespan. So it helps in genomic medicine, precision medicine is there. It can help us, it also helps us in having, diagnosing Alzheimer's disease earlier. Cardiology, since I'm a cardiologist, so it's a core of it. So I'm not using it, but yes, of course, when I was making this seminar, so there are many things which I was unaware of. So probably, in future, probably I'll be using it. The latest buzz is about the eSanjeevani app, probably a tool which is, developed by a 14-year-old Hyderabad guy, which is probably in the news. It just listens to your heartbeat for 7 seconds and probably, detects if you have an, risk of any defect in the future. So I'm not used it, so I'm not aware about it, but it's just, it's getting news. It's a hot news these days. So there is, like I said, there is a big data in public health and cardiology. So AI is, probably will use that data and help us make modules and algorithms to better detect those diseases. And where we are already using it is in cardiac imaging, wearables, and remote monitoring, like Apple Watch, which was the first one to detect atrial fibrillation. Then we have various other devices, and we have been using in monitoring devices like with the pacemakers and AICs that they have now come in, telemedicine and this thing. So you can always detect arrhythmias or probably heart blocks if you put in something sitting at home. So this open evidence is in collaboration with Mayo Clinic and New England Journal of Medicine. This is where you put in the data and they'll give you some risk specification, can give you disease. Unfortunately, it's not yet available in India. I tried to search for it, but it clearly says that it's not available in India. So I have not yet had the chance to speak with my US colleagues or UK colleagues to actually know about whether it actually helps or not, but then of course it is there. So what it helps in arrhythmia management, imaging interpretation, electrocardiography, risk stratification, and wearable devices. So this is what it gives you. These are the references for that. And I mean, these are all the other various branches where we can have AI helping us. So probably radiology is at the forefront, cardiology, pulmonology, oncology, and gastroenterology is also there. So like I said, there are 692 devices on the FDA's new list, 76% are in radiology, 10% in cardiovascular, 3% in neurology, 2% in hematology. So now why AI in healthcare? There was a study published in Tech which said that 84% of the doctors feel burnout. They said, I mean, they're at the end of their services. They feel burnout. They feel that probably AI would probably help them shorten their patient visits, help them maintain records. Even NVIDIA is coming up with a software called Abridge, which will help in note taking and probably keeping records also. So, like I already said, that how the digital tech has revolutionized is electronic records, wearables, and improved outcomes are already there. So another thing where AI and digitalization can help us is having virtual assistants for physicians. You see a patient, you prescribe medicine, then you have a virtual assistant. There are times because of time constraints, you may not have that much of a time to spend with the patient at times. So at that time, your virtual assistant comes into play. So the patient can ask n number of questions, they can have an answer. Our cardiac surgeon has its own ChatGPT module. He showed it to me the other day. So what he did was that his patient can ask for an appointment, can ask multiple questions, and there is a set of answers probably the patient can get an answer from. So there are virtual assistant AI chatbots like babylonhealth.com and ada.com, which probably are helping patients. So now I'm talking about this. This has been developed by a surgical colleague of mine. This is basically an AI tool to detect early wound infections. So he has so far gathered the data of around 703 patients and 5,300 images or different images of different diabetic foot wounds. So what he wanted to say that, I'll just come into that. So can AI see what we can't, what human eyes can't? So what he did was, the premise is, so he took in images of various diabetic wounds, and so then he processed it. So the basic was that biomarker emission. So whether the metabolic markers, NADH, flavins, infectious marker, porphyrin, polypeptide, whether the bacteria had it, whether they not had it. So they were labeled as the red one was the gram-positive bacteria, and the green ones were the gram-negative bacteria. I'll be coming to the pictures. So these are the wounds, which probably looks healthy to us. Multispectral image is the one, and the AI-enabled image is the one showing that a small focus of a gram-negative bacteria. So they were started antibiotics early. Even this is probably healthy-looking wound to the naked eye, and of course they were corroborated with cultures. Of course, it's not 100% accurate. Few cultures have come out to be negative, but it definitely has enhanced the patient care and the patient outcomes. So now, what are the caveats for artificial intelligence? Data privacy and security, of course, are the first and the foremost. There could be bias, there could be over-reliance. Like I said, that we may stop using our own intelligence, our own brain, and then there are ethical and legal questions that have to be asked. Where digitalization can probably, can never replace, the human touch. Empathy and human connection, like ma'am said, saying a doctor saying just one word, that you'll be all right, it makes, does a lot of wonder to the patient. It does a lot of wonders. Clinical judgment, complex decision making, probably, AI may come to that, but so far I would not say that. Procedural skills, the innovation that you do, when you go out to surgery, or probably we go out to PT, do a stenting, we go with a, fixed subset, but when something happens, we change it on the table. So that is probably where AI may not replace us. And of course, trust and accountability are the first and the foremost. So like I said, so lack of human touch and empathy, it will probably, it's not going to replace that. To summarize, AI augments care. Probably in future we'll have smart hospitals and devices. Probably, and these are the challenges that require caution. And probably it should be, the approach towards AI should be human-centric rather than totally digitalization or computerization of it. So we should embrace the innovation. We could continue integration with it. We should treat patients not just as patients. They should be our partners because they are probably the ones which probably are helping us. So like with my final few slides, AI is a resident which is never tired and always learning and always working. So probably, integration of AI in healthcare probably is the future to go, of course. And, there was a thought by someone which said, AI won't replace doctors, but it definitely will replace the doctors who won't use AI. But like I said, patient care will likely involve human contact and probably will always involve human contact, unless the patients are robots and probably would like to be treated by the robots themselves. So with that, I would like to end, keep your smart gadgets with you, but always, take your smart gadgets with you, but always keep your mind and intelligence with you. So far, there are the different sites which probably are helping us. And so far, the future hangs in balance. So I don't know what the future holds. So currently we are in balance right now. Thank you.
Thank you, Dr. Gautam. AI is definitely here to, basically it is going to be integrated with the medical system and it is here to stay. The future is in AI. Thank you, Dr. Gautam.
Thank you.
And the session is open for questions. Any question, please? Yeah. Yes, please.
Sir, my question, is there any specific AI-based treatment which can help to reduce the level of negative mentality in the people?
Yes, so I think, look, this is a question of, again, I think, as ma'am also said, this is about psychologists and psychiatrists, but what AI can do, AI can help you measure stress. So if you measure, you manage. So negative mentality also, ultimately, if it's because of stress, you'll be able to understand that this is something that is really causing me problems. Maybe I should change my behavior. I should probably start doing something different. So it's all about measurement and management. Ultimately, you'll still need the help of a psychologist and psychiatrist, but AI can be there with you 24/7. Psychologists, psychiatrists can only spend some time with you, so it just augments the psychologist.
AI could also tell you 101 ways to die. So if the stress is too much and somebody is...
Any more questions?
So the things we have been talking about is benefits of AI, right? So are there any other side of it, basically the regulations and the negative AI, basically, the screening tools, diagnostic tools, and how do we take care of the false negatives and regulations around it? Open to anyone.
I had an experience. A lot of AI tools are, say, decision-making tools are based on population demographics, right? So something in oncology, which we tried out in one of the hospital groups, I had not named it, we invested very heavily into it, along with IBM Watson. And then we realized we started giving it free of cost to patients for a second opinion, because the lines which they were suggesting were not suiting Indian patients. So that's some project where we tanked crores of rupees, all right, because the entire, I think, repository was based on European and I think, the Caucasian race. So I think how your data comes across, who has participated in that, what has been the meta-study sample. So what has worked in China for COVID treatment has not worked for us. What has worked for us has not worked in Africans. So it's so on and so forth, right?
So more than the implementation.
So what data goes in there, that would be the output. So you have to use the right set of comparator. You can't compare an apple to an orange. So that's where we said natural intelligence has to, to be used on how to help you use AI, right? So AI cannot work on automation. There has to be a natural, human intelligence which has to guide AI and how to help him, right?
Just add to what Samir mentioned. I think I've also used IBM Watson some time ago, and again they were here about about 7-8 years ago, and they were obviously talking about AI-based diagnosis for oncology. and they had data from the US and Europe primarily. So in fact, we were very keen to partner with them to give them Indian data, because you're trying to structure data and give it, a very good shape. For the first 6 months, it did well. They started seeing very promising results. But then, the team basically felt that we should start paying for it in a big way. And, if you look at, let's say, when they charge you something in crores, actually speaking, we don't realize the value of data that we have in India. If we start understanding the value, we can really, really make a huge thing. So we actually, they asked us 55 crores. We said, I'm sorry, we can't pay 55 crores for 5 years. We are the ones who are helping you make the product. So I think, ultimately, if we recognize the value of our own data, start standardizing it, we can create Watsons of our own. There's no question. So there is a negative for sure, because we are relying on Western data. We are relying on a lot of data outside India. If we start building our own India-based AI models, we'll do wonders. That's what I'd say. Absolutely. Which is why we have to standardize the data, what we have today. And now we have AI tools that can, both structured and unstructured data they can collate. That's a very important element. But we need to start realizing the value, and hospitals and all of us need to collaborate to help us get to the right level.
Any more questions?
Hello, the panel. It was very interesting to know about what are the lacunas that AI is dealing with into medical space. I would like to understand one specific thing. Since the morning we were saying that we should have a collaborations for data, we should have integration for the data. Here I am identifying that it should be geographical specifications for the data integration, for the data collaborations. Specific to India, we are having different observations. If we go global data interactions, then the observations are very different. So do you have that identification that Indian data would cater by ABDM, by Aadhaar, and that would facilitate the AI to understand the data and give the solutions to the Indian...
I got your question. For paucity of time, I'll cut you short. Yeah. So what we meant was not geographies, that the minute you cross Telangana and the data changes. What I meant was gene pool. I specifically said that data was based on Caucasian race, all right? Did not work with us. So probably an Aryan race data may not work with the Dravidian race as well. So that's where when we capture demographics, we actually ask what region, the data has to interpret what surnames, what is the mixed race, why do we ask our parents, tree line, because all these AI-based precision medicine, they're all based on your genes. Most of them are genomics, whatever new things which you hear, predictive oncology, precision oncology, personalized care, I think gene mutations to, manipulate your, how you will respond to your treatments. All that happens because there's a certain gene where it has been studied on, right? So obviously when the race genes differs, so would be the protocol-based ones. And that's where you'll have to use your sensibility. What protocol is being used where? So of course, if I start following a European School of Medical Oncology guideline for my Indian patients, it is not going to work, right? I have to have my Indian School of Oncology where I have studied probably not 10,000 patients, but at least 1,000, at least 600 patients, and I know where works, correct? That probably is going to be more effective, as Sir rightly said, than a 10,000 meta study done on some other unrelated population, right? Thank you for your question. I hope it clarifies.
Thank you very much for chairing this session, Dr. Pian Singh. As we keep on hearing since morning, AI, still continuing. So we have a fantastic session next, which is going to be full of doctors talking about AI and digital health and everything. So before we move to the next session, which is a very interesting session, I request that we should present mementos to our distinguished. I request Father George, PA, Director, Holy Family Hospital, to please present a memento to Madam Upasana Arora ji. As you know, Madam have 3 hospitals now. Thank you so much, Upasana ji, for joining us today. Now I request Dr. P.N. Singh to present it to Dr. Sameer Singh. Then to Amit Singh. Then to Dr. Gautam Singhal. And Sumit Puri has already received in the morning. And I request Dr. Sunil Khetrapal to present a memento to Dr. P.N. Singh. Is not joined? It's not yet? Yes, sir. Madam, 2 more minutes. Madam, 2 more minutes. We'll have a group photo and then we'll leave. Yes. Dr. Khetrapal is the Director, Association of Healthcare Providers India, AHPI. Thank you so much. We'll have a group photo before we move to this next session. Let me introduce the next session, which is going to be the last session of the day after a long day. Digital public health. Kaun sa? Preventive care, ethical AI, building a responsible healthcare ecosystem in India. I request Dr. Sunil Khetrapal, Director, Association of Healthcare Providers India, please join the dais. Dr. Sumit Ray, Medical Director, Holy Family Hospital, New Delhi. Commander Navneet Bali, Chief Executive Officer, Clear Medi Healthcare. Dr. Archana Atreja, Medical Superintendent, Rajiv Gandhi Cancer Hospital. Dr. Sunil Sambil, Head of Medical Services and Medical Superintendent, Sir Bajaj Action Medical Institute. Over to you, sir.
So a very good evening to all, and we are at the fag end of this event, and this being the last session. I think since morning you've been listening to AI, and I think there's another AI now which we are going to talk, but of course on a little different page. But one thing I would like to just mention here, that it's very important that, the session ultimately should, have some key takeaways after each session. Once you go back, you should have some key takeaways with that. Otherwise, I think, these events will happen, sessions will happen, you talk, and then you go away. But most importantly, what impact it is going to create is more important. So I'm really honored to moderate this very important session titled Medical Directors Panel Discussion. We have with us, not only the medical directors, but also we have Dr. Commander Navneet Bali as the CEO, and we have medical directors, medical superintendents, so it is a mixed group. And at the heart of this session are, digital public health, very important, because it's going to, digital public health, where we talk about the real-time surveillance and tools like ABDM, And then preventive care. Preventive care is very important. We have these wearables, IoTs, and these analytics. Then ethical AI, very important. We talk about data privacy and consent frameworks. See, the aim is to build a very responsible and resilient healthcare system. Now, but we must never forget, as you know, many of the previous speakers have told, that technology is an enabler. Technology is an enabler, and it is not a substitute for human judgment and empathy. So human touch will always remain at the core of the patient care. So I'm privileged to be joined by an eminent panel of leaders, CEOs, MDs, MS, who are experts and who have steered their digital transformation at some of the very leading and reputed institutions in the country. So I'm sure that their insights will spotlight challenges and innovations in digital health. We have Dr. Suresh Kumar with us? No. Dr. Suresh Kumar, I think he is the medical director, GTB and LNJP Hospital. I think probably he could not make it. So there's no representation from the public side. But I must mention here that Dr. Suresh Kumar has been the medical director of GTB and LNJP Hospital since 2020 during the COVID era, where he did an amazing job, and he was the nodal officer for the task force on COVID-19, where he was responsible to expand the hospital from 330 beds to 2,000 beds, and their ICU beds from 50 beds to 300 beds. And he did an amazing job. And there were a lot of digital initiatives and interventions taken by LNJP, and how they managed COVID was really mind-boggling. I think since he's not there, we'll move to our panelists who are present here. So the first question from my side is to Dr. Sumit Ray, who is the Medical Director of Holy Family Hospital. Dr. Sumit, Holy Family Hospital, I would just like to mention about this hospital. I was the casualty medical officer at Holy Family Hospital in 1978 and 79 during Sister Lucia and Dr. Sridharan those days. So it's very close to my heart. I still am attached to Father George is here, and I get the invitation for the Christmas dinner every year, and I try to make it. So Holy Family Hospital, those days when we talk of the healthcare quality, I remember it is amazing, run by medical mission sisters, and how the care, the compassion, the quality of care, I used to see those days. We got NABH in our country in 2006, ISO, NABH, JCI. But those days I could see the quality of work being done in Holy Family, which was unmatched, I think. I must appreciate that and put it on records. So thank you, Father, for serving the society in a very nice way. Now, Dr. Sumitra, my question is for you. So in these high-stake situations, how do you balance between relying on clinical experience and using the data-driven insights to guide your decisions?
Thank you, and thank you for the nice words you have for Holy Family Hospital. I joined there 5 years back, and I'm totally bowled over by the kind of empathy and kindness with which the nurses and the doctors take care of patients there. And so my area of, in answer to your question about, so I'm a critical care specialist while being a medical director. So I would probably give an example from my experience as a clinician. Would be that in critical care, or let us say in the coronary care unit or the OR, there is, when I'm standing there in front of the patient is there are monitors with a lot of data, there is a ventilator, there are multiple infusion pumps, and there's a chart with a lot of information that has been gathered over the last 24 or since when the patient has come. Okay, so I have to look into all this while I'm looking at the patient, trying to integrate all that data in my mind to try to see what I can change or continue for that patient at that point of time, or to look into the next 2 days of therapy. Where am I going to take this patient along with my team? So in that process, AI really hasn't helped us yet too much. There is some element of it while I am integrating the data with my mind with the information coming. Where AI could possibly help in transforming this is, particularly in critical care, let's say, would be that all these data integration would help us if there is a mechanism to integrate all this data and tease out what now we look at in advanced medicine as sub-phenotypes. So they would identify the sub-phenotype of a patient which I am dealing with, not taking away the fact that my intellect, along with my team's intellect and caregiving, has to be involved in it, but where it will really help me as a clinician in many of these advanced fields would be to tell us which sub-phenotype, or in another way of saying it, which pattern of disease process is this patient taking. That is where it will be really helpful. Now there's been a lot of, I'm just taking it forward a little bit, a lot of discussion of AI replacing the doctor. I don't know if there is a question on that or not, but because I was listening to the discussion, as everybody said, it will not replace the doctor, but it will augment. That may or may not be true. There may be fields where the role of the doctors will get reduced, particularly where it is high technology driven. But having said that, as has been emphasized, the caregiving part and the empathy part is important for the doctor and the nurses. But interestingly, if we look at history, doctors handed over a lot of the caregiving work to nursing about a century and a half back, okay? If we, as doctors, we want to maintain our jobs, somewhere we have to get back to more caregiving and empathy, along with using technology. That is going to be the role that we have to look for ourselves while integrating artificial intelligence. You cannot avoid it anymore. You cannot say that it is not going to be there. Where our roles will come in is our emphasis on these elements also. So that is where the integration is going to happen.
Thank you, Dr. Sumit. I think you as a clinician and as an administrator, so your insight, the perspective of both, it was really meaningful. And secondly, when we are talking of this AI replacing human being, I must say that AI will definitely replace a human being with the one who is using AI, with the one who is not using AI. So AI will definitely replace the human being who is not using AI with the one who is using AI. So this is something, we must, so we have to, keep in mind that you cannot get away with the AI. Thank you. And my next question is to Dr. Commander Navneet Bali. Commander Bali, when we say AI, there was a question that, negative AI, and, sometimes AI is not trustworthy, not reliable, not dependable. So, there are any example, if you can quote from the real world, where AI was tried to give a medical solution, but it failed?
Yeah, so thank you very much. I think we just finished a panel in which a mention was made of IBM Watson. I think this is often talked about for its failure. So let's little bit understand about IBM Watson. And first of all, very, very importantly, I mean, there are a lot of nurses sitting here, a lot of doctors, a lot of eminent people sitting here. I mean, almost every week I attend a conference on AI now. Every week. And everybody seems to be talking about AI. Truly speaking, if you ask me today, in our country, there's not a single institute, not a single research organization, nowhere, not a single bit of AI work is being done in India, which is going to be proving anything near to what is going to happen, let's say 10 years from now. So we are going to be 100 years behind. And this particular program that we spoke about, in 2014, I remember, and this is about IBM Watson, because everyone spoke about it. Let me tell what IBM Watson was all about. 2014, I was the head of Rockland Hospital, Qutub, and these gentlemen came to me, and they talked about IBM Watson. Basically, they said that there's a program which, for cancer, oncology, it gives a solution or help to the medical oncologist to determine what chemo pathway should the patient be taken through, depending on all the factors, etc. And as everyone said here today, that the data was Caucasian, and it failed because it was not Indian data. First of all, we didn't even know. I mean, we talk about it, and we are very sure about it, that if we had used Indian data, the results would have been different. We don't know, actually speaking, truly. The medicines that today are in the world, about most of the oncology, none of them are Indian produced. None of them have been researched in India, none. So as it is today, every oncology pathway that you are practicing, it is data from the Caucasian world or from the European world or from wherever it is. So when we said that IBM Watson failed, it failed, true. But they were the first people who actually decided or thought of a pathway which could be taken by a machine using data, algorithms, or whatever be it, we talk about it, all of us, to give a solution to the doctor. Not a solution, actually, to hint towards a pathway what a doctor could take. Now let's talk about, we talk about AI a lot, and I thought I will just take a little different path. Where do we require AI? Tell me. Do we require AI to perform a bilateral TKR, or how AI will help us to perform a better bilateral TKR? Or where do we actually require AI? Why do we require AI? Why do we talk about it so much? Why? Do we require about the mundane, normal tasks that we do? Do we require? And what about the cost? Who's going to do it? Who's going to crunch the data? Where are going to be big machines coming from? What about the heat generated from the massive, huge data generating towers of computers? What is going to happen? Have you ever thought about it? We don't think about it. I'm just trying to open our minds to something that we hear all the day long, every day, morning to evening. AI, blockchain, data, this. AI, when it will be used where life and death matters, it will be used only when there is 101% trust in that solution. Will you sit in an aircraft tomorrow, a Boeing, when you go from, let's say, here to Heathrow, where you're told that this aircraft is being flown by AI? You will never, because you don't have the trust in that aircraft being flown by AI, whatever advancement in technologies have happened. So do the doctors believe in AI? They won't. Even in US, I was just sitting with someone from US today, having lunch with him. Sorry, you know what the AI is being used in US today? Because there are no internal medicine and physicians available for 6 months, they have now chatbots or bots where you enter data, they will give you whether you should take a paracetamol or you should take an antibiotic or whatever it is. In US, I'm talking about. I'm not talking about some small country where, you know, so yes, the arrow has been shot. Yes, we all are talking about AI. Yes, AI is the future, but I'm sorry to say the entire euphoria around AI is completely misplaced as on today. And I don't see it happening for next 100 years. The way we think about it, maybe it will happen in a different way, I'm not sure about it. So now coming to your question, IBM Watson failed, but IBM Watson gave it a try. That can doctors be helped to take decisions? And that is where we stand today also. Everything in AI today is nothing to do with replacing anybody. It doesn't replace doctor, it doesn't replace anybody. It just gives you a little bit of indication. For example, AI is today being seen in a lot of radiology investigation where the X-rays are being put through a lot of data available, and they churn and they tell, okay, but can you just tell with that AI solution that please you do not have cancer without even going through a biopsy? If your doctor is sure about it, they won't do it because biopsy is the gold standard for looking at the cancer. So similarly, I think very, very nascent stages, we talk too much about it. We know little about it. Right now, we are very, very far away from it solving real life solutions where life and death is concerned. And so, the future, AI is going to enter in all our lives. Right now, it is only to Ghiblify your photographs and to take some data and do something about it. Maybe, solve some data, one or two problems like, which hall has got less tickets where you can go and sit down. But beyond that, for it to really replace a doctor, to change the way we are looking at medicine, it's going to be more of a catalyst maybe, a helping agent maybe, when it actually becomes something that we can truly use it. Thank you.
Thank you, Commander Bali. I think your message is very clear that, of course, don't get married to AI. Keep some distance, but of course, where to use, when to use, how to use, that is your discretion. But of course, AI will go a long way, no doubt. But then be mindful of where you are using it, how you are using it, how much to use. So that is something important. Thank you, Dr. Commander Bali. My next question is to Dr. Archana Atreja. Again, she is from Rajiv Gandhi Cancer Institute and Research Center. My immediate past organization where I worked as a chief operating officer, Rajiv Gandhi Cancer Institute. So this organization is very close to my heart. I have seen this institute growing from 150 to 500 beds. Today, it is one of the premier institutes in the country, providing the comprehensive cancer care, and we get patients from all across. Very nice. I mean, Dr. Archana, nice to have you in this panel. And, hospital is, healthcare industry has got humongous amount of data, full of data, patients' data, employees' data, this, that, diagnostics. It's very important how you use your data, right? So how are you using your data to make the clinical operative decisions in your institution today? I mean, for the clinical decisions you want to make, or any operational decisions you want to make, all this oncology data, how are you using it? So.
Thank you, sir, for the lovely words about our RGCI, I would say.
Our RGCI.
Definitely, I can't take that away from you. Sir, since you are well aware about that, how RGCI works, but I'll say it for the audience. Okay. But I'll speak it out loud for the audience. So sir has asked about how it helps, the data helps in clinical and operational decisions. Being an administrator, I will first speak about the operational decisions. So it is very practical. Everything that we do today, be it the number of the OPD. Now in RGCI, from the data, I know that the footfall in the OPD is more on Monday, Thursdays, and Saturdays. So these are 3 heavy days. So I channelize all my resources that way. Be it the manpower, the patient care services, the housekeeping, the billing staff. I know how to shift the duties so that the staff on Monday, Thursday, and Saturdays are more. We avoid any offs on those days. So patient experience is better, the queues are shorter, and we distribute the timings so that we are able to improve the experience, and we are able to utilize the resources without adding on to any additional cost. There are many such things in other areas as well. In clinical, you would say, sir, data is what drives oncology. All the treatment that we give is based on NCCN guidelines. And NCCN is nothing but the collection of the data. It is all data-based. What medicine we are going to give, what are the prognosis, what are the improvement chances. And in RGCI, because we also believe that no patient should be denied treatment because of cost, so that human factors come in, not just in operational factors, but also in the treatment, in the clinical decisions. Because when we prescribe a medicine, looking at the patient's affordability, we also see at the data as what is the difference between one drug and another. If the clinical outcome is not that significant, and the patient cannot afford a drug A, though I know it has lesser side effects and more chances of outcome, but the patient might just leave the treatment in between because he can't afford. It is better that we give drug B so that he completes the treatment with maybe a little more, one more drug added to cover the side effects. However, in RGCI, we have that advantage of a very strong philanthropy department. If we see that the difference between the 2 drugs is huge, and we will not help the patient by giving drug B, we would rather tell them, do not go for drug B, go for drug A, and please approach our philanthropy department. They will help you out with the cost coverage. So that is how it helps.
Yeah. Okay, data-driven decisions are very important because it is evidence-based medicine where we are. And I remember in each OPD in RGCI, the oncologists, medical, surgical, or radiation oncology, they have in their system, NCC guidelines are uploaded there. Even if the patient, different, patients some are very educated, they wanted to know. So they say that we follow these guidelines. These are NCCN guidelines. And they are explained, and they say the best we will do. If any complicated cases are there, then they are posted for the tumor board, because it's a multi-specialty clinic. So I think it's a wonderful, the model which RGCI I have seen, how the physicians, the clinicians, they arrive at the data-driven decisions. So I think these are very important, the evidence-based. Ultimately, see, we are all concerned about in healthcare, what matters is outcome. Outcome, patient experience, patient satisfaction. And in oncology, it is very tricky situation most of the time. So I think this is very important. Thank you, Dr. Archana. Now I have Dr. Sunil Sambli he is the head of medical services and medical superintendent at Action Balaji Hospital. So my question is to you. It's always a challenge to take the clinicians, and administrators together. I mean, bring them on a common platform, bringing them on a common page. So what challenges do you face in fostering a data-driven culture among the clinicians and administrators? So challenges, they will always remain. And how do you tackle, and what are the solutions for those challenges?
Thank you, Dr. Khatripal. On day-to-day basis, every day talk about AI and all of the things, and now every hospital is becoming digital. So we have to also adopt all these measures, which will help our clinicians to get better. We have some apps also. We have some patient appointments are done on apps. And now the most important thing is the data which we are supplying them, or they should trust the data. All clinicians should trust the data which we are providing them. For example, in any case, whenever we have a patient's data with us, the previous history, if it is not provided to them, they will not rely on that. But the challenges we face, the trust they should always have on their data. Whatever we are giving them, we provide data for our day-to-day working. For example, how much housekeeping we require, how much doctors we require, how much beds we require. But clinician doesn't understand all these things. He has to have the symptoms of the patient, then only he can, whenever we say him that we are being replaced, your radiology with AI, he makes fun of us. No, I have to see the X-ray and I have to see the clinical symptoms of the patients. As doctor have already discussed that, a chest X-ray which can detect a lung cancer, but it can't be confirmed without a biopsy. Whenever we say any patient will not believe a clinician, if we say only on seeing X-ray that you have a lung cancer, on seeing any shadow in the lung cancer, the AI can detect the lung cancer on a shadow, but it can't see the biopsy. What type of, the further treatment will also depend on that only. These challenges we are facing with the clinicians. We give them the data which is proven. Wherever we have outright them, we have to give them the trust that this data is only for helping you, not to treat them. This is how day to day we face them.
Thank you, Dr. Sunil. Dr. Sumitri, can you add on this, in the challenges which you are facing in fostering this culture, data-driven decision
So I would agree with Dr. Savit that, the trust in the data, but also in a sense, how do we utilize the data to convince doctors also? A lot of the data that we gather, we have to put it up to them to convince them that probably, working in this pattern would be better than another pattern that they are working in. Sometimes without the data analysis and the data being put forward to them, lot of the discussion becomes anecdotal. In my experience, a senior person will say that probably if, in the emergency, if we treat patients like this, it would be better. If you have data to show that, as Madam said, at this point of time, the footfalls are higher. If we have your resident stationed in the emergency this period of time, rather than in the IPD side, it could be more useful. So data can be used. Actually, I don't think data and clinicians by nature go against each other. It is how we present as administrators or managers the data to them to tell them that this would actually improve your delivery of care. See, as administrators or as technologists, we look at what the data is telling us. The clinician looks at patient outcomes, as you rightly said, sir. So our job as administrators is to connect the information we get from data to convince them that outcomes will get better. If we are able to do that to the clinician, that this data will improve your outcome, they are the easiest to convince, I think. This is where our role is.
I would like to add an example. I totally agree with sir. And I would like to add a live example from our hospital. Like in our hospital, as you know, the cancer care is a lot about daycare now. So we have a big daycare center of 50 beds, 60 beds. Along with it, we added a 10-bedded special daycare because it was suggested that the patients nowadays require special privacy. They do not want to waste time. They can add, they might add, you can add little more. They will pay for the facilities more rather than an encroachment on their privacy. Time is more important than money for them, and the privacy is more important for money for them. So we developed a wonderful, beautiful setup with a great ambience, with every facility right there, so that no time is wasted, and they have their privacy, and they have the ambience. So a 10-bedded special daycare was set up. And then now, since that daycare is running short, we needed to add more beds. So the discussion was that we are going to add 20 more daycare beds. The area was mobilized. Now we had to decide how many beds to be allotted to daycare and how many to special daycare. Again, the suggestion from the doctors was that we should add 10 to special daycare and 10 to general daycare. Then we administrators, we just collected the data and showed them the ratio that the requirement of the beds, the occupancy of the bed in the general daycare was 2 point something, and in the special daycare, it was 0.8. So after seeing the data, they were very much convinced that an addition of general daycare will definitely help more than an addition of special daycare. So that is how data changes the decision.
I think data-driven administrative decisions she just talked about, management of beds in daycare. I think wonderful example she has given. Thank you, Dr. Archana. Now, I'll come back to Commander Navneet Bali. You have that model of, you are expanding now. You have a good number of hospitals. And you have good number of hospitals, ClearMedi HealthCare, and you are expanding. So anything new or any development which you are aware of or you have done in the field of oncology, something new which is happening? So please.
So we thought that India does not reside in where we are sitting right now. It resides in at least 40 kilometers when we travel outside Delhi, Bombay. So many of our hospitals are in tribal areas. We have a hospital in Goraj next to Baroda which treats 300 patients on couch on a day. No one knows about it. Every day we treat 300 patients on couch, and these are all tribals of Madhya Pradesh and Rajasthan and Gujarat. So there was an Israeli guy whom I met about 5 years back. And by the way, let me also tell this, that everything that we're talking about AI and we want to develop or we want to do requires a lifetime. So if you want to really do something, it will require a lifetime to be dedicated to what you want to do. Anyway, so we started thinking about how do we truly develop a preventive oncology test, which is extremely cost expensive looking at India, because most of these preventive oncology massive campaigns have never resulted. We still continue to land up in 3rd, 4th, 5th stage or whatever in our hospitals. So when I started talking to him, he was a big-time tech guy from Israel. And also, Israeli dogs are used by the army in a very big way. So he said that, why can't we look at dogs to sense cancer? And this was 5 years back. And so there was a part where there's a dog, and then there's a tech high deep tech AI, and then there is what to do and how to use the dog. And dog uses its smells, as you know. I mean, smell is the one, is the most potent weapon. So what they started working on is that a mask, which just costs nothing, is taken to, let us say, a village which has got, a population of 2,000 people, and every one of them is just made to wear this mask, and which is numbered, obviously, and tagged or whatever it is, so that identification is proper. And you collect the mask back and bring it back to where these dogs are there, which have been trained, and then the dogs wear a helmet, and that helmet has also been designed, and which is connected to your AI modules or whatever. And the reaction, and this reaction is not by the dog's reaction at the outward, it's the reaction in the brain cells of the dog when it smells that mask, and then that is being analyzed. So just want to tell you that, as I said, it takes a lifetime to do that. So this is something that we are working on very closely with Israeli, this scientist. We've set up a kennel in a place near Bangalore. We have a hospital in Mysore. We have a hospital in Nanded. We are the only people who have a cancer hospital in Nanded. One single cancer. And Nanded, again, we have 100 patients on the couch. The machine works from morning 4 o'clock till almost night because there are 100%. And all these are Ayushman Bharat tribals of Maharashtra. You can understand. So the work has now started. We had to get ethical committee approvals, PETA approval, STPI approval, because dogs are involved here. The dogs have to be trained. Some deep tech models have to be developed. So, this is just one of the things that we are working on. Extremely cost effective, and can be used, in a massive scale. Only thing we need to now develop into the significant values, the specificity, and the preventing false positives and things like that, which anyway you understand. And that is where this deep tech AI truly will come, where you have a physical side of the story, you have a dog, you have these sensors, you have tech, which will then give you whatever results will come, we'll come to know in maybe 2 to 3 years' time. So imagine from where we started, it will take almost 10 years for us to develop something which will be of some use, and as we progress. So, this is something that you asked specifically, so I'm telling this to you because many of these works are being done in smaller centers which we are not even aware. Because places like Delhi, Bombay, and these massively populated places, and patients come to get treated, there is no time for anyone to do anything else. But we are trying to do something which is quite different, so I just thought I'll share with all of you.
Oh,
Thank
wonderful,
you.
wonderful. I think something new development. Of course, it will take a lot of time, and let's see how it evolves. And, maybe the future, when we are talking of the, digital health, is future of healthcare. I think this is one great example, especially, the combination of the smelling power of the dog and AI. It may do wonders maybe 10 years from now, as Dr. Commander Bali has just mentioned. I think it's a wonderful.
Sir, if I may add just a little bit to the.
Yeah, why not, please?
So
Please go ahead.
Dr. Bali also said this, that, in spite of the tremendous effort made by individual institutions to kind of look at preventive oncology or any others, or even in the previous session, the talk about, Indians don't tend to go to the hospital to get themselves tested, preventive medicine. I think it doesn't work like that. If you see a good healthcare system, and this is systemic, a good healthcare, why don't people access healthcare early in India? The predominant reason is a lack of access to healthcare in terms of physical distance, in terms of primarily of cost. So a good healthcare system, you cannot do preventive medicine. And the United States example you gave is a classic example of a rich country with no preventive public health system, right? And that's why people have to go on to ChatGPT to find out if they need a PCM or an antibiotic for the infection. So this is a sign of a poor healthcare system. And AI can only augment it, but if governments do not want to have a good, accountable public health system, all these efforts will go to naught. You cannot bring people, and it has come 2 days back, the India Fit report. There's 70% of people are not accessing healthcare, even those who are relatively well off. With insurance, 36% are not accessing healthcare because it is expensive even with insurance, right? So we have to understand why Indians, it's not Indians, it's nothing to do with Indians, it is to do with the healthcare system. It is nothing to do with our genetics or nothing to do with our mindset. It is to do with a healthcare system which is accessible or not. If we do not have an accessible healthcare system, for most of the people will not access healthcare. They will end up at later stages of disease.
Very important. I think universal health coverage, we talk of accessibility, affordability, and quality care. I think accessibility is very important. And one of the major areas where the government has taken the initiative in accessibility is ABDM. So this, I would like to ask Dr. Sunil Sambri something on ABDM. You know, ABDM aims to create a very unified digital healthcare ecosystem in the country. But what steps can be taken to ensure that, you know, there's a smoother integration of ABDM with the private hospitals in the private healthcare system?
Thank you, Dr. Sunil. As we all know, that Government of India has started this program, Ayushman Bharat Digital Mission. Every person will have a unique Health ID, which will be accessible to all the healthcare professionals, and everywhere it will be accessible. If we follow this system, our resources will be 10 times less used. At present, we go on a simple test 10 times. Whenever we go to the doctor, he prescribes a test and we get it done. नहीं तो ये मेरे पास ही कराना पड़ेगा या ये इस lab से करा लो. They don't believe it. Now there is no standardization. These Ayushman ABDM will give us an access that the test which we have done around 10 days back also, I can see it on my computer just now. When I access his ABDM, this ID, I can be able to visualize what was his hemoglobin 1 year back, or what was his hemoglobin 5 days back, what was his hemoglobin today. I don't need to waste resources. His history will be available there only. This system was adopted by our Government of India, which we are not able to proliferate in everywhere. Still, Delhi being the capital of the country, here also we lack. Still, people don't know. We had seen the compliance rate. Government of India had given us the deadline that all the hospitals should be ABDM. They should have their own individual IDs. Every physician should have IDs. But I don't think it's more than 10% in Delhi also still now. Still people go from one hospital to another. They are prescribing them one test. Another hospital prescribes them the same test. And it's everywhere. With these challenges, we face day to day. The people get for the search of diagnosis in one hospital and then goes to another hospital. There he's prescribed another battery of tests. These challenges will be overcome only when we follow this system, when the labs are standardized, our reports are standardized, and we will be able, the clinician should have trust on the report of each and every, wherever it has been done. Nowadays, nobody trusts his report. He says, no, ये MRI तो वहाँ से था, उसमें नहीं मुझे ये नहीं लगता है. We don't need to get it done. When there is a standardization, we don't need to get another test done.
Yeah, I think ABDM has a very robust infrastructure. There is interoperability is taken care of, but the challenges lies in the staff training. I think that is something, you know, is always a challenge. Training of the staff.
Yeah, most of the hospitals, whenever we start giving them any training on that, they are already taking it that one more thing has been added to my charter of duties. Already in India, we are always thin-staffed. Here, when we give them something which has to be added, but in the long run, they also come to know this was very helpful to all of us. But we need to give them a rigorous training on this. And for this training, the government should also, or whenever we make any tool, we should involve the private and the government setup together. And they should be on the same setup. The API should be same. They don't have to integrate. For integration also, they don't have to take different pathways. When the integration is difficult, if the adoption is difficult, it should be inaccessible and very easy to operate.
Yeah, I think it's a good thing, ABDM, but challenges will remain, especially with the private healthcare sector. And with my last question is to Dr. Archana. Something about preventive oncology. I'll just give you one example. When I was with RGCI, we did a study. The patients reporting for the first time to OPD in RGCI, 70% of the patients, they reported at the late stage, at an advanced stage of the disease. Why? Lack of awareness. Then the preventive, there's no preventive health checkup. I think we must gift our parents or our dear ones at least once in a year on their birthday a preventive health checkup package to them. I think that's something very important. So oncology, I told you I've done a study that 70% of the patients reporting to OPD for the first time are reporting at an advanced stage where you can't do much. Huge, 70% is huge. So how do you integrate your digital health tools in your preventive oncology, in the preventive care? So can you give some examples in RGCI?
Yes, sir. Thank you. I inherited a very robust preventive cancer system from you. And I'm really proud. The system that you started, sir, now it has come to a stage where we are conducting 3 to 4 camps every day. And the beauty about the system is that the patients who are screened positive in the underprivileged areas, till their confirmatory diagnosis, nothing is charged from them. And even the ones who are confirmed for the treatment from the underprivileged areas during the camps, we charge nothing for the complete treatment for the cancer. Now, coming to the dependency on data for this, that is what decides everything. The data tells us which belt, what emphasis should be given. We all know about the demographic shift. When I was studying in the medical college, in the PSM books, we were taught that in the Western world, CA breast is the most common cancer in the females, while in the India and the Asian subcontinent, it is more, the CA cervix is the highest one. But there has been a demographic shift thanks to the lifestyle diseases, lifestyle changes, and the changing economy. Now CA breast is the highest prevalent cancer in females even in India. So that the decisions, the allocation of resources, what kind of preventive test we are doing, that shift is very much dependent upon the data. As we come to know of the demographic shifts, we shift our resources likewise. So we know which belt, what kind of test we are going to conduct. Like in Punjab, now after Doll and Hill study, the correlation between lung cancer and smoking was well established. It is a beautiful epidemiological survey. If per person smoking more than 25 cigarettes a day, the chances of lung cancer increased 25%. Now this was well established, this was all data-based, this was an epidemiological survey. Now how does it affect the preventive oncology? We are going to Punjab, we know as due to the religious practices, smoking is not prevalent in Punjab. So we do not focus on CA lung when we conduct camps there. But when we are going to Maharashtra, when we are going to Northeast, we are conducting more of oral cancer examinations because of the gutka consumption there, the supari consumption in Northeast. So this is how the data tells you which preventive services you're going to focus on, which tests are to be focused on, which will give you a better outcome, which belt, which area, which cancer needs to be screened more, which tests are to be done more. So when I'm going to conducting a camp in Maharashtra, I'll be sending more of the doctors for oral examination. that is more prevalent there. So that cannot be missed, right? So this is how the data affects the preventive care.
Thank you, Dr. Archana. I think we have come to the end of this session. And we have today not only, talked about the AI as a buzzword, but how the AI tools can be used for digital health transformation of healthcare. Lastly, I would just like to say here that let us remember the future of healthcare is not only digital. It must also be ethical, very important part. It must also be ethical, inclusive, and human-centered. The empathy, the human touch, I think no one can, no AI or anything else which comes after AI, I don't know, can replace the human touch. I think that's very important. So I would like to thank the organizers first. Mr. Sashidharan is here for inviting me as a moderator for this session. And there was a great insight from the panelists. And of course, very engaging session and lovely audience. So I would like to thank my panelists, the lovely audience sitting here, and the organizers. And we are well on time. And thank you very much. Best wishes. Thank you.
Sir, permitted? Yes, sir. I have a question. According to World Health Organization, WHO, the health triangle is essential to living healthy lifestyle. So my question, what is meant by health triangle and how it is useful for healthy lifestyle?
Yes, who would like to answer? Healthy lifestyle actually has got 6 pillars. Out of syllabus. No, I think there are 6.
I thought it's a Viva question of a medical college.
I can just answer about the healthy lifestyle. The healthy lifestyle is based on the 6 pillars. One is your physical health, that is your physical activity. Second is diet, that is nutrition. Third is your sleep. Fourth is your social health is very important. The studies have shown that if you are socially active, if you are meeting your friends at least once in a week, have a chat and a booze and enjoy, then you live longer. So social health, physical health, mental health, most important. And so these are the elements of, these are the pillars of the lifestyle, healthy lifestyle. Because ultimately, when we are actually not thinking of all the elements of lifestyle. We are not focusing on all these elements of lifestyle, all these pillars of lifestyle. You may be having a good lifestyle, maybe 4 of these elements are good with you, but maybe you are not having a sound sleep. Maybe you are not having a good mental health. Maybe you are not in a good physical health, or maybe your diet is not appropriate, or maybe you are not having any physical activity. So all these are very important, to lead a healthy lifestyle. So that's what I would say. I don't know
if I may
about
add,
the triangle.
if I may add to that, using Chat GPT to get all knowledge may isolate you from getting knowledge from others, and that's also poor social health and poor mental health. Right? Interacting with other human beings is as important to survive and live a good life, rather than using AI or Chat GPT to get all your information. Life experiences are very important to live a good life, other people's life experiences as your own.
Tell me who does not have a smartphone here. Tell me, please raise your hand who does not have use a smartphone, right? And do you know your average screen time a day? Have you ever monitored? Yes, that lady sitting there, she nodded, very bravely she nodded. Tell me, what is your screen time in a day? Oh, very good. I must compliment. Big clap for her. 2 hours, I think.
We make her work very hard.
Yeah, see, average, the studies have shown that, 8 to 10 hours of screen time is there, which Actually, even before you just go to sleep, you will be using your mobile. Just immediately after you get up, you will be using your mobile. It says, if you really want to follow the good practice, you should stop using mobile 2 hours before your sleep, right? But very difficult, even for me, myself. I'm, officially also connected. Sometimes it's good to preach, but they're very difficult to practice personally. I'm very honest. I'm very honest. But if anybody can do that, it's really good. Try to reduce your screen time at least half an hour, every, slowly you gradually come down to 2 hours. If not 2 hours, at least 3 to 4 hours. 8 to 10 hours screen time, there is Sweden is a country, very recently, they have withdrawn all the digital applications from their school. And they have come back to this, books, all manual thing. Denmark also. So people are now, because at this very young age, if you are so much addicted to your mobile or digital health, your screen, I think where is it going to take you? You have to live the whole life, maybe 70, 80 years if your average lifespan, if you see, right from the age of 3 or 4 you are using this. We also feel very happy, when your child or grandchild is operating the mobile. Isko bhi operate karna aata hai. You feel so happy, but no, that's not good. And I remember I used to fix the timings for my son, when he was young, for the TV. तो देखो वो सिर्फ वो देखना है, वो मुगली वाला एक सीरियल आता था, वो देखना है और वो आधे घंटे का देखना है और उसके बाद नहीं देखना. Sort of, we used to follow some discipline as far as the screen time is concerned with your children. I think that's very important. So when we are talking of healthy lifestyle, these also, will take away your sleep. You will be disturbed mentally. You try to see one message in WhatsApp, you end up, operating it for next 1 hour. So I think somewhere we have to control and some limit has to be there.
Yes, please.
I was just adding to what you just said, sir. I think basically the 6 dimensions you exactly stress: exercise, sleep, nutrition, social, and substance use. Substance use is another one, which basically is substance use.
Substance, absolutely. I missed that. No, he's right. He's right. I actually missed that.
Yeah, so
substance
social
abuse.
बिल्कुल आप मिलें और बात करें, but of course थोड़ा सा alcohol कम करें. But I think I'm just saying, but in general I'm just saying, I'm currently looking at Sybil score for wellness, which is about, how do you measure yourself? And exactly right. Your devices हैं, आप कितना time लगाते हैं? It's very important. But this is exactly the kind of thing that you need for holistic health, and very beautifully explained, sir.
I just want to add out of it, there are not few, there will be more people in this country, who must be waiting for a call from you or anyone. There is no one to talk to them, especially to our parents, old parents. If you spend and if you make a socio gathering where there is no liquor, nothing, even chai pe charcha, even the evening, go to the neighbor and ask, how are you? There are so many neglected parents in this country. Even if you spend that time with them, laughing with them, whether it is in the park or anywhere, that is also part of the social life. I just wanted to add. Coming to the end of this second edition of the Bharat Digital Summit, we had a fantastic session since morning where the regulator was here, the ex-regulator started the Digital India from Aadhaar to Ayushman and then landed up in the regulator. He was talking about AI, but I'm sure AI is not going to replace completely the doctor, but as Dr. Sumit said that reaching out to the poor and medical availability and affordable is very important because that is the necessity. It is no more a luxury. And what Dr. Rachana said that screening, that Dr. Khetpal said that once in a year on a birthday or a marriage anniversary of your parents, if you can do that, that will be a great initiative. In the morning, DG STPI said, which I wanted to share it with you all, Arvind Kumar, the DG STPI said that he got an ecosystem of all startups in Lucknow. He want all the doctors and hospitals to come forward to discuss what is the need of the hour for the health, digital health. And STPI is too happy to help financially and also to create those digital health for the industry. Thank you so much. Ladies and gentlemen, we come to an end. We'll have a beautiful evening gathering, chit-chatting each other, and social gathering here also, talking about each other's welfare and anything. I request the chairman of the session to present the memento to the distinguished speakers. To start with the lady, Dr. Archana. Thank you, Dr. Saab. Excellent presentation. Can we have the Dr. Archana's? Yes. Dr. Sumit Ray. Commander Navneet Bali. And then Dr. Sunil. I request Father George P.A., Director, Holy Family Hospital, to present to Dr. Khetrapal the memento.
It's a great honor. Always part of Holy Family. I welcome always so happy and good.
Thank you so much, Father, joining us. I request those speakers are here, whoever it is, please come on the stage. All the speakers. Let's have a group photo. All the speakers. All the speakers, please come on the stage. All the speakers. Any doctors, please come on. Doctor, sister, please come, please come, please come. Let's have a group photo with all the doctors, speakers. Please come on the stage. All doctors, speakers. Yes, sister, please join us. I don't know, maybe we'll have to have 2 steps or something, or it will come in one. Okay, here we go. Yes. Are they? Thank you. Now I request all the delegates, please come on the stage. All the delegates. Please come, sisters, please, everybody, please come. All the delegates, all the partners, please come. Yeah. We can have one line here and one on the top. Please come. One here. आप लोग इधर आ जाओ. Come. Others, please come fast. Come on the stage. Some on the ground. Yes. Please, sisters, come. Sisters, this side, please come. Maybe we'll go closer to that. Yes. Come. Maybe all the tall people go to the third line and sisters come over. Please come. Yeah, come in front. Please come. Yes. Yes, let's go. Done? Yes. Yeah, yes. Cheese. Haji. Thank you. Thank you so much.
Thank you very much. Congratulations. Thank you. Thank you very much.
ठीक है Thank you so much.